1 second, guys.
Yeah, okay, got it.
Is it starting?
Looks like it's
meeting is being live streamed, it says in front of the screen.
Yeah.
Yeah, 1 second.
Yeah, okay, got it.
Yeah, okay, I think we are on now.
Looks like it's
Yeah, I think it's on like on.
We're on now. Okay, I think we are on now. Sorry guys for the delay. I think we're on schedule now. Yeah, I think we are on now. There's a lot of echo coming in from I think your room for the delay. I think we're on.
Just a minute, sir. Please mute the YouTube one, sir. Whoever is.
A lot of echo coming in from I think your room for the delay. I think we're on.
Please mute the YouTube. Please mute the YouTube one, sir. Whoever is.
A lot of echo coming in from I think your room for the delay. I think we're on.
Please mute the YouTube.
Just let me see. Is it coming?
Hello. Please mute the YouTube.
Just let me see. Is it coming? Yes, better now.
Hello.
Yeah, it's gone now. That's gone. Yeah, we can start. Sorry. Just let me see. Is it coming? Yes, better now.
So, sir, you're muted.
Yeah, it's gone now. That's gone.
Good morning, Shiv. Good morning, Dr. Sanjay Prabhu and Dr. Devnath and Dr. Anil. Welcome to all the delegates. I can see about 17 to 20 of you registered. Welcome to day 2 of FARA. We have an interesting program lined up from 11 p.m. today till almost 7:30 p.m. today. We'll start off by, because of a little bit of a delay, apologies for that. I'd like to introduce the chair for this session, who's Dr. Devnath Chatterjee. He's professor of anesthesia at Children's Hospital in Denver, Colorado. He's the director of fetal medicine, Colorado Fetal Care Center. He's program director for the Pediatric Anesthesia Fellowship, and presently he's also the editor of Anesthesia Online. He'll be chairing the session, and I'll hand over the session to Dr. Devnath to introduce Dr. Sanjay Prabhu, and then Dr. Sanjay Prabhu to carry on. Thank you very much.
Thank you so much for this opportunity to moderate the session. My name is Dev Chatterjee, and it is my distinct pleasure to introduce the first speaker for the session, Dr. Sanjay Prabhu, who is a pediatric anesthetist at the Apollo Chennai. Now, we all know that regional anesthesia is commonly performed in children, and the use of ultrasonography has revolutionized this practice. However, there are a lot of nuances to performing regional anesthesia in children, and to share some of these practical and expert tips, please join me in welcoming Dr. Sanjay Prabhu.
Thanks very much, Deb, for that nice introduction. So I'll share my screen and get started. Okay, can you hear me? Can you hear me?
We can hear you.
Yeah.
Loud and clear, yeah.
Good morning, everyone. And I thank Dr. Somnath and Shiv for giving me an opportunity to present in this forum. So today I'll be talking about how is pediatric regional anesthesia different in children compared to adults. So there are some similarities and there are some differences, which we will go through. Now, we all know that when children come for a surgery, it's quite a stressful journey, both for the child and for the parent. And the commonest symptom they're worried about when they're coming for a surgery or procedure is pain. So pain from a needle, pain from the surgery, pain from an IV injection. So there are so many sort of different ways the child can experience pain, and this can cause significant distress to the child and to the parent and to the nurses who's taking care. So we as anesthetists, I think we have an important role to make sure that this journey is pain-free, stress-free, and we need to satisfy the patient and the parent. So because of which, I think this particular aspect of pain management is very important. So why is it important to administer regional anesthesia? So children, particularly the younger children, they do have a lower pain threshold. This is because of some physiological features which are exclusive to small children. So we all know that we have ascending pain pathways which transmit pain from the site of injury to the brain, but we also have descending inhibitory pathways which play a major role in trying to dull the pain which we feel. So in children, there seems to be an immaturity in the descending pain pathways, and this is one reason why they have they experience pain to a higher extent compared to a older child. So this applies particularly in children less than 1 year of age. And smaller the child, lower the pain threshold. So we have to be very aggressive when it comes to pain management in neonates. So what happens when someone has a surgery without adequate pain relief? This tends to cause significant permanent changes in the pain pathways, which makes them more susceptible to subsequent surgery where they have a high amount of pain perception. So any inadequately treated pain will lead to permanent changes, what we call as neuroplasticity. So it's quite important that we sort of give adequate pain relief. Apart from this, the distress caused by the pain towards to the patient and the parent is quite evident. And there's also a risk of chronic post-surgical pain in any condition where the acute pain is not treated adequately. Apart from this, regional anesthesia becomes an important component of what we call as multimodal anesthesia. And then we have opioid-free or opioid-sparing anesthesia, because opioids do have a high risk of side effects in children in terms of nausea and vomiting. And there's always been this talk about what are the effects of anesthetics in the developing brain. So there is some evidence that when someone comes for repeated procedures or when they have some long procedures, it might have some changes in the brain. So in these situations, I think regional anesthesia can significantly minimize the amount of the drugs which we use otherwise. And lastly, there's a risk of emergence delirium, which is quite commonly seen. I'm sure people who practice pediatric anesthesia will see this phenomenon quite commonly in the recovery. And when you have an adequate pain relief, you tend to minimize the risk of emergence delirium. So we all say that children are not small adults, but when you think about them anatomically, they are small adults because the nerve fibers are smaller, the nodes of Ranvier are more closely spaced, the structures are more closely situated in the anatomical region. The nerve, the artery, the vein, they're all close together, which basically means the risk of injury to the vessels can be higher. It is more superficial compared to an adult patient. And myelination to be completed, it can take anywhere from 6 to 8 years of age. So all of these, basically what it means is it leads to a quicker onset of blockade when you deposit a local anesthetic. And there's also one more reason why you can get away with a smaller concentration of local anesthetic compared to an adult or an older child. Regarding central neuraxial blocks, the CSF volume and the turnover is higher in small children. So that's the reason why the spinals don't work for a long duration. So they work at most for 30 or 40 minutes. So you need to use it in appropriate situations where the surgery is getting over by that time. The spinal cord ends lower and the dura mater also ends lower, which basically means there's a high risk of spinal cord injury if you perform it at levels above L3. So we recommend that we do the spinals below L4 vertebral level. And regarding epidural anesthesia in small children, the fat in the epidural space, unlike adults where it's densely packed, in children it's a fat which is loosely packed and it's fluidic, which means there is easy spread of local anesthetic when you give it in the caudal space. And when we pass an epidural catheter, there are instances where epidural catheters can be passed from the caudal space to the thoracic level. So that's because of this content in the epidural space, which enables easy passage of catheter. They do have a high risk of dural puncture because the ligaments are not fully developed, or they could be thinner. So you just need to be aware that the risk of dural puncture is higher. And even the thoracic, the lamina in the spinal vertebral column, they are not fully bony. So which means a paramedian approach is not recommended. And lastly, the spinous process in the thoracic region, they're not angulated. So you don't need to have the angulation of the epidural needle, which you normally do in an adult patient. And to give you a depth of the epidural space, normally it's 1 centimeter in a 10 kg child. So if you're doing a child who is 5 kilos, you could encounter the epidural space within half a centimeter. That's a lot of skill in getting an epidural catheter in a very small child. Before you do central neuraxial blocks, particularly caudal, because caudal is the most performantly block in small children, look at some cutaneous markers, which could include hemangioma, a tuft of hair, sinus, or a sacral dimple. So when you have all these, it could indicate something within the spinal canal. So some of these characteristics, when you see these features, if they have multiple this sacral stigmata, or if it's larger in size or more distant from the anus, then it could indicate a higher risk of having what is called spinal dysplasia, or associated with a tethered cord. So look at this diagram here. The left one is normal vertebra. On the right side, you have a vertebra which is not fused, or the spina bifida. Okay. So in this diagram, you see that a spina bifida is associated with a tuft of hair on the skin. So this is what you can see. So when you see a patient with a hairy patch over the caudal region, then you might have to look at other features which could indicate if the child has got any other medical issue, any other neurological issues. So the common neurological condition which is associated with a sacral cutaneous marker is a tethered cord. So tethered cord basically means the cord is lying at a lower level, okay, which basically means when you're trying to do an epidural or a spinal, you could injure the spinal cord. That is one. And second is when you inject fluid in the caudal space, the cord doesn't move up. So which means you could compromise perfusion to the spinal cord. So when you have a sacral dimple or any other cutaneous marker, basically you look at a neurologic examination. If it's normal, then you look for other features like the dimple being more than 5 millimeters or more distant from the anus. If that's the case, then you can go ahead. But if you think there is any other neurological abnormality, then you have to have some imaging to rule out any tethered cord in the form of ultrasound or an MRI. When it comes to physiological features, children are not small adults. One is because the protein which is bound to local anesthetic, the alpha-1 acid glycoprotein, is lower in concentration. So this basically means a higher free fraction of the local anesthetic drug. And second is the intrinsic clearance of anesthetic local anesthetic agents is lower in small children because the CYP enzymes, P450 enzymes, are immature up to 1 year of age. So in infants, you just need to be aware that when you're giving a bolus dosage or an infusion of local anesthetics, it will accumulate with time. So just be careful that you monitor them properly. And since they have a higher cardiac output, the anesthetic which is deposited in a particular area of block gets removed quickly. And all these basically translate to an increased risk of LAST. So children, particularly infants, do have a higher risk of local anesthetic systemic toxicity. So you need to be aware of that fact. Apart from that, because of a higher basic heart rate, they have a high risk of cardiac toxicity. And they also have a high proportion of cardiac sodium gated channels, which are in the open state. So this basically means that they have a high risk of cardiac toxicity. And yeah, because of higher tissue blood flow, the block duration also tends to be smaller or decreased. So this basically means that you might have to give some adjuvants to extend the duration of the blockade. Now, so it's understood that we cannot do blocks in a moving child. So most children will require sedation or full anesthesia to administer a block. there's one exception where they recommend that we don't give any anesthesia in preterm babies because of the risk of apnea. Any sedation will increase the risk of apnea. So I think there were a lot of points mentioned about how ultrasound is the norm and the gold standard as of now because of all these reasons. So I think I'll just go to the next slide because I think this must have been discussed yesterday. How is it different in a small child? So we hardly use the curvilinear probe. So the linear probe or the probe with a smaller footprint like the hockey stick probe will suffice for most pediatric blocks. And the depth settings and the gain settings have to be adjusted because of the smaller size and the more superficial structures. And the needles which you use also have to be smaller in size. So since the bone is not fully cartilaginous, particularly in a small child, you can visualize the neural structures quite well. So unlike the adult patient or older child, you could visualize the spinal cord and the spinal cord pulsations in a small child with ultrasound. Some safety tips about regionals in pediatric anesthesia is dosing errors seem to be a very common issue with pediatrics. I've commonly seen surgeons asking for infiltration, wound infiltration, where the dose can be completely above the toxic range. So whenever the surgeons ask for a dose, just be careful that it's within the maximum recommended dosage. And since it's a diverse age group, it's easy to overdose children. So, and draw only the amount of drug which is required. In the absence of a classical simulplex needle with a short bevel needle, you could use this technique. So don't connect the syringe directly to the needle for the block. Have a tubing so that when you move the syringe, it doesn't translate to movement of the needle. And other common things is make sure that someone is monitoring the patient. And if possible, when you do a block, try and keep the patient breathing spontaneously, because one typical example is when you're doing a caudal and for some reason you inject the drug into the subarachnoid space, the first thing which will happen is they will stop breathing. So subarachnoid injection of anesthetic will cause a complete sort of a block of the medullary centers, and they will stop breathing. So that's one precaution if you can do it. Again, this is something which I ask in which I tell in most of my regional anesthesia talks is have this ready. You should have access to this one as quick as possible in the event of an intravascular injection. Yeah, we did mention this, that LAST is commoner in neonates and infants because of these two reasons. And this particularly happens when you have infusions running beyond 48 hours. And in neonates, even after 24 hours, it starts building up. So if you're trying to give infusions for more than 48 hours in infants and neonates, have a very good indication for that. And ideally, you should sort of decrease the dosage and monitor the patient for any intravascular toxicity. Again, the question is a test dose required in children? So unlike adults, since they're already sedated, you may not get the correct response when you give a test dose. So they recommend that you give a slow injection in incremental fashion and always have the ECG monitoring. Is there a role for adding adrenaline as a test dose? So many studies have shown that adding adrenaline doesn't necessarily translate to an increase in heart rate or ECG changes. So they don't recommend adding adrenaline as a routine. And now that we have adjuvants, there isn't much role of adding adrenaline in small children. So that's what you see when you have localized systemic toxicity. The first thing you would normally see is an increase in the T wave amplitude, and sometimes you might have STT changes. So regarding safety of pediatric regionals, generally these are the two big studies which have been published. One is from the PRAN, or the Pediatric Regional Anesthesia Network, from the US, and the other one is from France actually. So they've done quite a huge number of patients, and they've looked at complications. And the one thing which has been noted is there is a shift from central neuraxial blockade to peripheral nerve blocks, because the risk of complications is 6 times higher in central neuraxial blockage. And children less than 6 months have the highest risk of complications. So it is recommended that if you don't do blocks regularly, you leave children less than 6 months to people who practice pediatric anesthesia on a regular basis. And the common complications which they've encountered with central blocks is dural puncture and intravascular injection. And when you think about peripheral nerve blocks, the more distal blocks are better, obviously because the complications are less. And this issue of tunicate pain doesn't arise in small children because they generally have sedation or general anesthesia. So distal blocks are preferred over proximal blocks. Now there is one indication for spinal in children. This is proven that when you have a small child who is born before 37 weeks, they have a high risk of apnea. So any form of sedation, if it's given to this child, they have to be monitored for 24 hours after the operation because the risk of apnea is high. So in these group of children, they recommend that if you can avoid any form of sedation and just give a spinal, it will decrease the risk. It doesn't sort of completely avoid apnea, but decrease the risk of apnea. And you can do this by applying some EMLA cream over the spine for 45 minutes and then doing the spinal. And sometimes you have children with suspected myopathy coming for biopsy. Again, in these situations, you try and avoid any volatiles or neuromuscular blockages. So you could consider spinal in these patients. Again, I'm sure most of you know this, but make sure the solution is dry before you attempt the needling because the risk of chemical arachnoiditis is there. And chlorhexidine allergy is also seen. It is a late manifestation. So if someone develops allergic-like response, sort of 40 minutes an hour into the procedure, think of chlorhexidine as one of the possibilities. It's very important that you take care of pain management from the time the block wears off till you start giving parenteral analgesics. So that's one period can be quite difficult for a child. You stop an epidural or 12 hours into a brachial plexus block, the block wears off. Suddenly the patient gets a lot of pain. So just make sure that you plan something ahead to cover this transition from a complete block to decreasing block levels. So there is a different role for adjuvants. So any block which can be increased in duration, try and do them. So commonly used adjuvants are either clonidine, dexmedetomidine, or in our hospital we tend to use buprenorphine actually. Again, very important medical aspects. The moment you say injection in the back, at least 1/3 of the parents will say no. So try not to convince them if they have any strong views about not having or not wanting the caudal. Better not to give the caudal. And in ambulant children, make sure that you warn them about leg weakness. You don't want them falling off when they're trying to ambulate for the first time after the surgery. So just mention this particular feature to the parents so that they're aware. Now, what are the limitations of regional anesthesia in small children? Obviously, it cannot be used as a sole technique unless a child is very cooperative. And as I said earlier, blocks in very small children requires that you've done them earlier and you require an experienced pediatric anesthetist to do them. Yeah, that's very important. And there are some contraindications or abnormal anatomy you need to be aware of when you perform blocks. So some contraindications are lack of consent and complex neural tube defects, as I mentioned earlier. And there is a condition called, it's a kind of mucopolysaccharidosis. So type 4 is Mortius syndrome. Here, there is something to do with abnormal spinal cord perfusion. So they recommend that you don't give central neuraxial blockades, particularly epidurals, on an already compromised perfusion. So there have been reports of quadriplegia, quadriparesis after epidural in these children. So that's something which you try and avoid. Again, there are some conditions where the abnormal anatomy has to be identified. So one condition is called arthrogyphosis. So it is a condition where there is symmetrical joint contractures and it's thickened, everywhere it's thickened. So one is the actual visualization of the nerve and ultrasound is difficult. And because of contractures, you may not elicit a good response with nerve stimulator guided nerve blocks. So just be aware that these children can be a challenge in terms of identifying the anatomy, and they also have what is called sunken shoulders. So it may be difficult to do a supraclavicular nerve block. So think of alternative techniques like an intraclavicular nerve block in this situation. Another condition is osteogenesis imperfecta. This is otherwise called brittle bone disease, where they're very prone for fractures. So even positioning them for a block can induce fractures, and try to avoid any nerve stimulator guided blocks, because the fasciculations which you generate from the nerve stimulator can also induce fractures. So just be careful about this. Some newer nerve blocks, actually they have been done earlier, but something which we have restarted doing them is pudendal nerve block for penile procedures, and maxillary nerve block in the pterygopalatine fossa. This is done for adenotonsillectomy and for cleft palate surgeries. Finally, this is one article which I would recommend that people who do pediatrics regularly read. So error traps basically means iatrogenic errors, or errors done due to not following certain protocols. So they've looked at 5 common errors which happen in pediatric regional anesthesia. One is obviously trying to confirm the block site. You don't want to mess the right and the left side. So that's one. Second is in small children, it might, since they're closely spaced structures, you could sort of misidentify an artery as a nerve, particularly nerves that are more proximal. They are anechoic, so because of less connective tissue. So make sure that you look for pulsability and compressibility before you identify a nerve from a vessel or a nerve from a tendon. And there are some situations where regional anesthesia is an option, particularly when you have patients with previous neurological issues. So whether you do regional anesthesia in them, so that is something which need to be looked at. And in patients who've had previous spine surgery, or previous patients who've had spinal instrumentation, ultrasound may not be enough. You might have to use alternative techniques like fluoroscopy to identify the epidural space. And lastly, the one which we mentioned earlier about arthrogryposis and osteogenesis, there are certain conditions where the anatomy can be distorted or abnormal. So just need to be aware that it can be more challenging to do a block in these situations. So in summary, it is an important component. Doing peripheral nerve blocks or central nerve blocks has to be done when indicated as a component of multimodal anesthesia and opioid sparing or opioid-free anesthesia. Children being a very diverse age group, you just need to make sure that you calculate the dose correctly, and be aware that there's a high risk of LAST, particularly in small children. Ultrasound should be the norm. It goes without saying that it will be difficult to do a block by eliciting paresthesia or even nerve stimulator guided, because ultrasound, you can do it real time, and you can see all the structures, you can identify normal anatomy and so on. And always cover for transitional pain or the rebound pain, which happens when the block wears off. So make sure that is adequately done. So I do a block wherever it's possible. So unless there's a major contraindication or lack of consent. Thanks very much. I think, yeah. So we can, I think the plan was to have a discussion later on after the second lecture. So thanks everyone.
Thank you so much, Dr. Sanjay Prabhu. That was a fantastic presentation, very comprehensive, and you covered a lot of topics. We're going to save questions after we hear from Dr. Kothari. So our next speaker is Dr. Gaurang Kothari, who is a pediatric anesthesiologist at the Aster CMI Hospital in Bangalore. His areas of clinical interest are pediatric anesthesia and regional anesthesia, and he's going to share with us some practical tips on how to perform ultrasound-guided regional anesthesia in children. So without further ado, let's welcome Dr. Kothari.
Good morning, everyone. Is my presentation visible?
Yeah, it is visible.
Yeah, so welcome to the second day of FARA. So I'd like to thank Dr. Somnath and Dr. Shiv for giving me the opportunity to talk about a topic which is very dear to me, pediatric anesthesia. And with the permission of the chair, I would like to proceed ahead. So I work at CMI Hospital in Bangalore. So initially, I would like to say a few disclaimers here. All the videos in this demonstration or in this talk are videos and images which we have captured at our institute while doing the blogs. I'll be only speaking about ultrasound guided blogs because in pediatric anesthesia, ultrasound guided blogs give you a lot of information and a lot of safety margins. So at our institute, we do not do any stimulation based or blind blogs. We only do ultrasound blogs. So that is all I'll be speaking about. And I'll be speaking about the blocks which are most commonly used in pediatric age group, like the caudal blocks, the ilioinguinal blocks. I'll not be going into the limb blocks, which are because they have already been covered by other speakers. So this is how briefly I will go through the talk. I'll first be talking about the hockey stick probe, which Dr. Sanjay has already told. I'll try to demonstrate a few advantages of hockey stick probe, especially while using it in neonates and infants. Then I'll be talking about caudal blocks, then ilioinguinal and the dorsal pineal block, and finally a few slides about the facial plane blocks, the TAP, rectus, and erectus spinal plane blocks. So as Dr. Sanjay has told, the hockey stick probe, which is most commonly used in neonates and infants, gives a lot of advantages when doing the block in the small area of interest. So one thing to observe here is all the hockey stick probe have an obtuse angle, and this gives you a greater advantage which no other ultrasound probe gives you. So what advantage does this obtuse angle give you? So I come to that. So hockey stick probe is nothing but a linear high frequency probe. It is like a linear probe, but we're having a smaller footprint of around 10 to 12 mm less. So as you can see, that's the hockey stick probe, which is circled next to a linear probe. And the footprint of the hockey stick probe, as is measured here, is 30 mm. And your regular linear probe has a footprint of 45 mm. So around 12 to 15 millimeters less footprint of a hockey stick probe. So now here the advantages of the obtuse angle come in very clearly in this picture. As you can see, the operator's hand is resting on the patient with the thumb at the angle. And even after the thumb resting there, you can see the whole of the footprint is visible to the operator, which doesn't happen with a regular linear probe. So when you use this hockey stick probe, it allows you for the visualization of your needle puncture. So the alignment of the probe and the needle is easily seen. And when you're working in a smaller area, this alignment is necessary to get a good visualization of the needle. So when you do a hockey stick or for any matter, any ultrasound, you have the operator's eye, the needle, the obtuse angle of the hockey stick probe and the ultrasound machine all have to be in one line, and that is when you will be able to see the needle path, the needle entry, and the ultrasound image properly. So next, coming to the caudal block. So this is the dorsal view of the sacrum and the coccyx, where you can see the sacral cornu has been highlighted. And the sacrococcygeal ligament forms the roof of the caudal canal. So basically, the dorsal surface is the most obvious part is the median crest. The median crest is formed by the spinous tubercles of S1 to S4. But the S5 spinous tubercle is absent because of the non-fusion of the laminae of the S5 vertebrae. So that creates a potential space, which is called your sacral hiatus. Now, what is a sacral cornu? Sacral cornu is nothing but your inferior articular process of your fifth sacral vertebrae is joining to the coccyx. So that thickened part is called your sacral cornu. So sacral hiatus, as is there in picture C, is an is a space, potential space, which is caused by lack of the fusion of the fifth sacral laminae, and the sacral cornu is the thickened area where the inferior articular process of S5 joins with the coccyx. The green arrow shows your needle entry, which is a more zoomed up picture. So when you're doing a caudal block, there are three views which you can have when you're performing the block. The first is the transverse view, where you keep the probe on the two sacral cornus. The second is your sagittal longitudinal midline view. It's basically the same thing, but if you concentrate on all the three words, it'll give you a more clearer picture. Sagittal, because it's in the sagittal plane, it's kept longitudinal and in the midline. So it is kept with your caudal tip being in the sacral canal. So this allows you for better needle visualization in plane technique. And the third view is your parasagittal longitudinal interlaminar view. So in this, from the midline, you go laterally to the level of lamina and tilt the probe medially. This is trying to look between the laminae. So this view is helpful when you want to see the drug spread, or if you're using a caudal catheter to see the position of the catheter, this view is really helpful. So when you're doing a caudal, especially in neonates and infants, as Dr. Sudhir has Sanjay has pointed out, that you should always try and look for some anomalies, looking for the ending of the dura. If it is a low-lying dura, then the chance of dural puncture increases. You look for any spinal cyst or any spina bifida or tethered cord or things like low-lying tumors. This all, if you need not diagnose them, but if you have any suspicion in such case, if you have an ultrasound, it'll always be better. You can screen the spine, and if you have any suspicion, you can avoid the caudal block and avoid the consequences or the complications which can occur. So coming to first the transverse plane. So here, as you can see, is the schematic diagram where the ultrasound probe is kept transversely over the sacral cornu. So this is what the picture you get. So it's important to remember here is your posterior is your most superficial and your anterior is the deeper structures. So you can see the two sacral cornus at the edge and the sacrococcygeal ligament and the sacrum. So this is again the same picture. The two sacral cornus are at the edge. The sacrococcygeal ligament is marked in green with an arrow, and the sacrum, which is the bright white arch that is present below which the ultrasound beam doesn't penetrate. So it has been told that the transverse view resembles the frog eye sign. So if you can imagine, the two eyes of the frog resemble the sacral cornu. The area between the two eyes is the sacrococcygeal ligament, and the mouth is the sacrum. So again, if you can use your imagination and put it to this picture, you can kind of imagine a frog eye sign. So next you go to the longitudinal midline view, in which your probe is turned 90 degrees and it is placed in the midline over the sacral canal. So this is the view that you get. So here again, the posterior is the most superficial, anterior is the deeper, and the right side of your screen is the caudal and the left side is cephalad. You can see the dural ending there with a hypoechoic fluid filled structure. It is marked there. So that should generally correspond to your S1, S2 interface or S2 body. And then if you go on counting, so it will be S3, S4, and S5. I'll talk about that view a little later with a video. And lastly, going to the parasagittal interlaminar view. So this is helpful when you want to see the spread of the drug. Generally at lower lumbar or higher sacral levels, you can see this view and you can know the spread of the drug. So this is your picture that will come. So you can see the two laminae marked in the red arrow. So, and the circle is your ligamentum flavum, and the dotted line is your dura. So if you can observe this video, you can see the neural elements moving here. So you can see the neural elements moving within the dura, and the ligament flavum is fixed, and your lamina. So this is also called the galloping horse sign, the interlaminar view. Okay, so this is a video of the spine screening. So this I am going from cephalad to caudal. You can see that the conus medullaris is already come, and now this is the cauda equina, which is bathed in the CSF, that is a hypoechoic structure, and the cauda equina is a white lines in there. So I'm going down, and there you can see the ending of the dura. Okay, so from there, if you can start counting the vertebrae down, that is, if that is S2, this should be S3, S4, and S5. And after S5, if you can see, there's a turn, the start dipping of the phylum terminal happens, and that is where your coccyx starts. So that is the sacrococcygeal junction. So if you know where your sacrococcygeal junction is, you can go back counting backwards and count where your dura is ending. So this is how we do this spine screening. So again, this is the schematic picture. And this is a video. You can see the dural ending there at the S2. And then you can see S3, S4, and S5. And the green area is where your caudal needle can be placed, and you can manipulate there and inject the medication. So when I do a caudal, what steps do we take? So initially we palpate as you would do for a landmark base. So we identify the sacral cornu and place our ultrasound probe in the transverse process and identify the frog eye sign to confirm that we are in the correct place. Then I turn the probe longitudinally to identify the entry into the caudal space from where our needle will come, and also do a spine screening, mainly to look for the dural ending if there are any obvious anomalies that I can see. And once I see the needle enter into the longitudinal plane, I again go back to the transverse and go at maybe S1, S2, or L5, L4 and see the drug spread. And then if we are putting a catheter, we look in the parasagittal view to see for the catheter. So I'll discuss all the steps with the help of videos and diagrams. So at our institute, all the caudal, or for any matter, only ultrasound-based blocks are performed. We do not do landmark-based, or we do not do PNS-based blocks. So this is one thing which we rarely do. We do not use the transverse to put the needle into the caudal space because it's very difficult to see the needle. But sometimes, if you can see here, the needle, it's popped through the sacrococcygeal and is in the canal. Very rarely we do this. Like if we are encountering the sacral cornu every time we are trying to go through the longitudinal plane, then in this view we can see the midline and go in through the sacrococcygeal ligament. But I do not recommend this video when you're starting off with your caudal blocks using ultrasound. So this is a schematic picture here. You can see the posterior anterior is marked. You can see the needle coming in from your caudal. So it's rotated from the previous one. So your caudal is on the left and your cephalad is on the right. So you can see the needle now sitting in the sacrococcygeal ligament. And now the needle is into the sacral canal. The green area marked is your sacrococcygeal ligament. So it appears that and is in the sacral canal. So this is a video of the same showing the drug spread. So now the needle is in the canal. I'll be injecting the drug. You can see the sacrococcygeal ligament getting lifted up and the drug spreading. So now I have confirmed. So I have done the screening. I have put the needle and I've confirmed I'm in the caudal space. Now what do? Now I go back to the transverse view. This is probably L5 view where I want to see whether the drug is spreading appropriately or not. So again, I look at it. You can see the dural pulsations and you can look at the screen in the center on the left, and you can see the dura getting pushed down and the cord getting compressed. So you know the drug is spreading well and it is extradural. So you are satisfied that the drug is spreading well and you are not into the dural space. So again, this is the same. You can see the dura has got pushed down and that is the drug that is collected outside. So this is the parasagittal view, parasagittal interlamellar view, where you can see that if you look closely, you can see the dura getting pushed out. Yeah, there the dura has gone down. I'll just play this video again just for you to take a note. The dura will start getting pushed down as the drug is getting injected. So this we use more commonly when we are putting a catheter or when we want to look at the lower thoracic level. So the drugs which we use at our institute for caudal is only ropivacaine 0.2%. If we have to add an additive, we add morphine, 20 to 30 mics. If we put a catheter, then we use a combination of ropivacaine with fentanyl. If less than 1 year, if more than 1 year, we use sensorcaine 0.125 with fentanyl 1 or 2 mics per ml. So infusions of caudal catheters are generally run at 0.1 ml per kg. Maximum we go up to 0.2 ml per kg. So as I said, other thing is we do not use the Armitage formula to give caudal blocks, because what we have found is if we know the level, like suppose we are doing inguinal hernia repair, we know we want the block cover till T12 L1. So we mark that vertebral level, and then we place our ultrasound probe there and look for the spread of the drug there. Once we see the drug spread there, we are sure that it has covered adequately, and we do not give the required volume as per Armitage. And we have found a reduction in the volume by around 40 to 50%. So we have stopped using the Armitage formula. We go by the ultrasound, we screen the spread, and we stop once we reach the adequate level that we need. And similarly, for the caudal catheter, if we have to pass a caudal catheter, we again scan the catheter. If we can see the catheter, well and good. Otherwise, we scan for the spread of the drug with small boluses of saline which is given. So once we reach the level of the desired analgesia, then we stop pushing the catheter in. I'll show you all this with the help of a videos. So now this is a baby who underwent inguinal herniorrhaphy, and we have given a caudal. So this is at T12 L1 level, and this is the proximal point where we want the local anesthesia to come. So if you can see this video, the dura will get pushed down. Yeah. So if you notice, the dura has got pushed down, so we know our drug has reached. So we stop the injection there. We do not give more, even if we have not reached the recalculated Armitage volume. So sometimes what can happen is, if you have noticed, all my pictures I have put posterior and anteriorly. Sometimes the caudal drug can come anteriorly, and if you are not vigilant or if you don't observe properly, you can miss the initial spread of the drug. So here, if you can see into the anterior to the dural to the spinal cord, if you observe, the drug will come in there rather than coming posteriorly. So if you see, the drug is coming in now. Yeah, so you can see anteriorly, the anterior dural complex has got lifted, and then the posterior dural complex. So this can happen when you're putting a caudal catheter also. At one level, it can be posterior, at other level, it can be anterior. So you have to keep your eye out for the anterior spread as well. So this is the caudal catheter video. So if you can see the bright white light in the center, that is your caudal catheter, the linear line. Now we feel the caudal catheter is little too in, so we will withdraw it a little too far up. So we withdraw it a little, and there the caudal catheter will now go out of your view. Yeah. So the caudal catheter has been pulled back by one segment, and we have what level we wanted. We will fix it over there, and infusion can start. So as I said, ultrasound can give you a lot of information, starting from spine screening to your needle position to your real-time view. Also, it can tell you about the wrong position of needle. So in this video, this is the longitudinal view. You can see the needle is there, and we have injected. We feel it is spreading well. So we are happy, and then we go to our transverse view to try and see where the drug appears. So in the transverse view, just look at your paraspinal area, or just see where the drug comes up. So you can see on your right side above the laminate, if you can see, the drug is accumulating. So it is accumulating in the paraspinal area, and the dura is not getting pushed. And also, if you observe, there is no subcutaneous bulge. So if you would have done a landmark-based technique in this, we would have felt, okay, we are giving the drug properly, but still the baby didn't have good pain relief. Why is that? So now you know the reason. So always try and use the ultrasound as much as possible to get a good drug spread, to see your needle position, and also to reduce your volume, reduce your complications. So in summary, when you do perform a caudal block, try and use ultrasound in the way which is comfortable to you. What we do at our institute is we look for the needle at longitudinal and look for the drug spread in the transverse view. But before doing a caudal, always try to screen the spine. And when you're using a caudal catheter, use an ultrasound to screen for the spread. So using an ultrasound for caudal, it can be time taking initially to start up, but with the results which you get, fantastic results, and you can see the baby being comfortable in the post-op. And then it's more satisfying. And as and when you go doing more and more, your time duration reduces. You get more better at that, and then in a matter of 2 to 3 months, you're an expert in caudal ultrasound blocks. So nextly, ilioinguinal iliohypogastric nerve blocks. So the nerves lie between the internoblique and transverse abdominis. So iliohypogastric is marked there, and it gives off a branch to the posterior lateral part of the glute, and supplies the hypogastric or the suprapubic area. The ilioinguinal supplies the inguinal ligament and your perineal area and your scrotal skin. Now look at this yellow nerve root of L1. So this is a ventral rami of L1, which is nothing but your ilioinguinal iliohypogastric nerve roots. So as compared to your other thoracic nerve roots, the ilioinguinal iliohypogastric can pierce the transverse internal plane and come to the internal external plate at variable places. So unlike your other nerve roots of the thoracic, where they pierce at their rectus and transverse abdominis level, in the ilioinguinal iliohypogastric, they can pierce at variable length. So it is important to give your block as posteriorly and as laterally as possible to cover this. And other thing to remember is sometimes when you're doing the ultrasound guided block, you can see the nerve root present between the internal external oblique layers also. And same can be applied when you're giving a block in adults for a hernia surgery. So this is the area that is covered. And if you can see here, the two blood vessels in the center lying in the transverse and internal oblique plane. Okay, so these are the blood vessels and the three muscle layers, external oblique, internal oblique, and transverse abdominis. And the two nerve roots are marked with an arrow, with your ASIS being laterally on the right side of the screen. So when you're doing an ilioinguinal iliohypogastric nerve, always keep your ASIS in view. If you're losing your ASIS from the view, is most probably you're gone too far medially and you need to come back, and that is where you will find the nerve. So again, you can see the ASIS, you can see the cremastic arteries, and then you can see the nerves around it. Okay, so this is the block that we are performing. So the injected seems to be still in the internal oblique. We probably need to pop in one more layer. So we are trying to pop in here, and yeah, so that's a pop, and now it's lying in the correct position, and we can go ahead with the injected. So since 3 or 4 ml is more than enough to cover both these nerves, and you do not, if you're needing more than 5 ml to block this, that means your needle is not in correct position. So generally 3 to 4 ml is more than enough to cover these nerves, and it gives a very good result for, especially for inguinal hernia surgeries. So as I said, the course can be variable. The nerves may not be always visible. Try and look for the blood vessels and try and split the fascia between where the blood vessels are. And the nerve root, as we all know, T12 is T12 to L1. So now coming to the block for the penile and the scrotal surgeries. So this the diagram on the left shows you the nerve innervation around that area. Involves the iliohypogastric, geritofemoral, ilioinguinal, and here also your pudendal nerves. So this is the diagram which shows clearly what is the innervation which happens. So the dorsal nerve of penis, which is a branch of pudendal nerve, supplies most of the penis, but except for a little bit on the inferior surface of the penis, which is supplied by the perineal nerve, which supplies all the way up to the frenulum. And also perineal nerve supplies this part of the scrotum along with the geritofemoral ilioinguinal nerve. So the dorsal penile nerve is a branch of pudendal nerve which starts from sacral level S2 to S4, and it divides into the perineal and the inferior rectal nerves. The perineal nerve further divides into the right and left dorsal nerve before continuing as the perineal nerve supplying the scrotal skin. So when you are to do a dorsal penile block, the two structures that you have to be look out for, one is the superficial dartos fascia, and secondly, try and look out for your dorsal artery. You may not see the dorsal penile nerve, but you will almost always be able to see a dorsal penile artery, especially in children, pediatric age group. So the two other things are corpora cavernosa and the corpora spongiosa. Spongiosa holds the urethra. I'll come to that later. So this is the pudendal nerve. As I said, it branches into the dorsal nerve, the perineal nerve, and the inferior inner nerve. Okay, this is again the same schematic diagram. I'll skip that. So when you're doing a penile nerve block, you can do it from ventrally, where you scan the penis from above, or dorsally, when you scan the penis from below. So whichever is convenient to you, whichever gives you a good picture, you can use any of that. So again, this is the picture. You can see the bright white arc, that is your dartos fascia. And inside, if you can see, inside that bright white arc, there's one more thicker layer, that is your buccal fascia. Okay, so the red circles indicate the corpora spongiosa, and the purple circle with the urethra is a corpora cavernosa. So now in this video, not very clear, I couldn't get the Doppler going in this. We just try and observe at these two red circles. So this is when you're scanning the penis from the top or from ventrally. Try and identify these two arteries. These are dorsal penile arteries. So if you can observe closely at these two circles, you can see the pulsations happening there. So you take a needle, come in plane or out of plane, go lateral to these arteries, and that should give you a good dorsal penile block. So this is from looking from the posteriorly or the inferior part of the penis, in which is the reverse sonoanatomy. You can see the pulsations of the dorsal penile artery on one side. The purple area is your urethra within the corpora spongiosa. So this is just deep to the buccal fascia, one side. And then if you go to the other side, you can see the other side pulsations happening. So you come in plane view on one side, and then you can go to the other side, just lateral to the artery. That will give you good coverage. So the options for the nerve block for penile scrotal surgeries include the caudal block. There can be a combination of dorsal penile block and ring infiltration at the base. So this ring infiltration is very important when you're doing a circumcision, because as I said, the perineal branches supply the posterior part of the penis right up to the frenulum, and in some cases have been shown to up to the glans also. So even when you're doing a circumcision or frenuloplasty, this circumferential infiltration at the base of the penis gives you a good cover, and then the patient will be comfortable throughout the surgery, and after the surgery they'll be comfortable. And if there is a scrotal incision like for orchidopexy, then you'll have to use a combination of ilioinguinal and genitofemoral along with it. So briefly, facial plane blocks, I'll be talking about tap and rectus first. As we all know, it lies between your internal oblique and transverse abdominis, and the lateral tap is generally helpful for covering the segments T10 to T12. This is the brief screen. Yes?
Dr. Gaurang, can I just intervene? You've got 2 minutes.
Yeah, I am done. I have 4 slides more.
Okay, just try to finish in 2 minutes, please.
Yeah, I'll do that.
Thank you.
So here you can see the facial planes are very well defined in pediatrics, and that helps us to give the blocks. And it's satisfying to see the facial planes, and anatomy is so beautiful, and you can easily give the blocks in this. And it's a good, if you want to learn for your rectus sheath or your tab blocks with ultrasound, it's good to start off in pediatrics because the facial planes are beautifully seen. So this is a tab block. This is a rectus sheath block. You can see the needle at the end of the rectus sheath, and the muscle will get lifted now. And this is your tab block. So the needle is coming in, lying between the internal oblique and transverse abdominis, and that's the muscle will get lifted now. So lastly, erectospinal plane block. It's a versatile block because you can give blocks starting all the way from the thoracic region right up to the lumbar. and where you put your needle tip at the edge of the transverse process and you look for the drug spread. So this is a video showing that. So your needle is coming, you can see your bright white structure. This is your transverse process. Once the needle makes contact with that, yeah, there's made contact with that, you do an injection, you can see the muscle getting lifted up. You can scan caudally and cephalad and look for the spread. You can see, yeah, the muscle is getting lifted there. So briefly, subcostal tap for any incisions above T10, lateral tap for T10 to T12, ileoinguinal, ileohypogastric for a hernia surgeries. Rectus spinae, very versatile block you can use for all the levels, and QL block again for the lumbosacral surgeries. This is ideal. So in conclusion, performing no block in children, it has to be a part of your multimodal anesthesia plan. There can be no excuse for not using ultrasound-guided blocks in our current day-to-day practice. And then use of ultrasound performing regional blocks reduces the amount of the needle puncture attempts, failures, complications, intravascular injections. The requirement of the drug comes down. So try and use ultrasound as much as possible. It can be a long curve, yes, but the results are satisfying, and over a period of couple of months, you can become a kind of an expert, and yeah, you can start doing the blocks independently, and you can start doing them well. Thank you. With that, I'd like to conclude my session, my talk.
Thank you so much, Dr. Gaurang. I do not know if we have time for questions.
Yes, you can go ahead, please.
Those are some lovely videos. So in my practice, I obviously do not do ultrasound guidance for all caudals, and then I typically use it just if I'm having issues with the anatomy. And I think watching your presentation has inspired me to perhaps switch to using ultrasound for all caudal blocks so that you get used to it and start doing it routinely. Dr. Sanjay Prabhu, is your practice is to do ultrasound for all caudals, or do you use it only for?
No. We have very impatient surgeons. So, no, we do it only blind, but in many instances where I've not been able to do a block blindly, we got the ultrasound and it's really helped. And in situations where we think it's going to be difficult, we start off with the ultrasound. With obese patients, landmarks are very poor, then do ultrasound guided. Otherwise, yeah, predominantly it's blind. Ultrasound if required.
That's exactly what we do as well. But it's awesome to hear that the practice is Dr. Gaurang's practice of using ultrasound. I think once you use it on a regular basis, I think you get faster, and and that's a good way.
It'll take some time. There'll be surgeons standing over your head, but over a couple of months, you see the results. Your volume of the drug requirement reduces dramatically, and then your complication risk reduces, and then it'll be very difficult for you to switch off from ultrasound and go to landmark-based technique. So I think if the access is there, I think you should give it a try. It'll be worth it.
Absolutely. Thank you so much. I have a really quick question for Dr. Sanjay Prabhu. You mentioned obviously how local anesthetic toxicity is more common, especially in young children. So do you change your epidural local anesthetic if it's a smaller baby as opposed to doing it in an older child?
So we give a lower concentration from 0.08 to 0.1% the ropivacaine. So the infusions are sort of, the lower concentration. That's what we do. And we try not to prolong the infusion more than 48 hours.
Yep.
And all of them have a monitor by the bedside, and they're kept very close to the nursing station.
Yeah. At our place, we use, again, most of the times dilute ropivacaine or bupivacaine for most of our epidural infusions. In children less than 6 months of age, we actually switch to chlorprocaine infusions, and obviously because it's safer safety profile, and most of the time you're running it without any kind of an opioid, so just a plain chlorprocaine infusion. But that's only for babies usually less than 6 months old. But for everybody else, as you mentioned, we just use the very dilute ropivacaine or bupivacaine for epidurals. I think in the interest of time, we'll conclude this session. Again, thank you so much to both the speakers for engaging presentations. Really appreciate it. Thank you.
Thank you.
Thank you, Arun.
Thank you.
Good morning, Arun. Thank you for joining in.
Oh, as they,
So,
we can still, I think we can still take few questions. There are a few actually questions.
There are a few questions on YouTube.
Yeah. I would
Okay,
actually
yeah.
start off with, I think there was one question about adjuvants. Adding clonidine and dexmedetomidine as adjuvants. By what time period do we prolong the duration of peripheral nerve blocks? Do you use any in peripheral nerve blocks in kids?
Yeah. I mean, I use dexmedetomidine, 1 to 2 mics. So if a patient is staying overnight, I tend to use 2 mics per kilogram. And we find that one is if it's given at the start of procedure, one is the requirement for volatile is decreased, or propofol is decreased. Risk of emergent delirium is decreased with dexmed, less nausea, vomiting, and also the duration of block is prolonged by 50%.
Okay, and I think Dr. Raghavendran has actually asked about ultrasound guided epidural injection and catheter in real time. Gaurang, do you actually do them?
So all our caudal catheters, they are done under real time. Our epidurals, we do a pre-screening. We know the depth, and because if we try and see, we do the LOR with a classical method, but we confirm the position of the epidural real time when we give a test dose or a bolus, and then we see the dura in the parasagittal view going down, and that is when we confirm the position of the epidural. So yes, caudal catheters real time, but our epidurals, we do the confirmation only with ultrasound based.
We have Arun as well here. Welcome, Arun. And what is your, are you also using ultrasound for all your pediatric caudals? Because I remember from our time it's just take a needle and bang, it's done. Well, obviously, I think what Gaurang actually has shown. I mean, amazingly, I actually teach doing caudals in adults with ultrasound as well.
Shiv, whatever Gaurang's told, he's my colleague. So
is he? Okay.
He's in my institute. So it's all under ultrasound there.
Sure. Okay, fantastic. And there was one other question: do you use a stellated needle for caudal blocks, or is it just you use block needles?
Yeah, so in our institute, we don't use, though that is the ideal practice. It's recommended that you use a spinal needle with a stellate to prevent the risk of implantation dermoid. But because we do so many, we do at least 6 to 7 caudals per day. So to get so many spinal needles, it is not easy. So we just use a hypodermic needle, the caudals.
We typically use a 22-gauge angiocath. We typically use a 22-gauge angiocath for our caudals, and we do not do it with ultrasound guidance. So,
but that has also got a similar kind of risk, like So, I think
yes.
Yeah. I mean, in adults, I tend to use a block needle. So it's got an extension on it as well, so it's easier to manipulate. But I don't know about children what they're using. Looks like most people tend to just use a angiocath kind of, or just a stellated needle. Okay. Any other question or any other comments from the moderators?
So there is one more question.
Sanjay?
There is one more question. How long to keep the caudal catheters?
Generally, caudal catheters we don't keep beyond 24 to 36 hours. So, and we use 0.1% ropirocaine, and so that's 24 to 36 hours is the maximum we keep the caudal catheters. We do not keep them beyond that because, as Dr. Sanjay has told, the other risks are there. So, 24 to 36 hours caudal catheters in neonates. That's the maximum that we keep.
Yeah, I think because the risk of infection, which is close to the perineum, so we just need to limit the duration.
Fantastic. I think a very good response from the people who have been watching it on YouTube. And I think, like David said, there are other people who have said they have been inspired to use ultrasound for caudals. But I think large volume centers, it sometimes become difficult because setting up the machine and getting things together does increase the duration of the time spent in the anesthesia theaters. Okay, can we then conclude? Arun, as the moderator, you have anything to add?
No, thanks. No, I'm done.
Thank you very much, guys. Anil and Som.
Nothing to add, nothing to ask. Thank you, Sanjay, and thank you, Gaurang. Fantastic presentations, inspired. I don't do too much pediatric work, but again, I echo Dr. Dev's sentiment. We'll try to use ultrasound-guided caudal at Prakriya as well. Arun, thank you very much for joining in. Dev, again, thank you very much for moderating the session. It must be very late in the night. Good night to you.
Thank you, Dev.
Thanks, Dave. Thanks.
Thank you. Thank you.
Bye-bye. Good night.
Good night. Bye-bye.
Okay, we'll carry on with the rest of the session. We have the honor of Dr. Shiv presenting the next topic, which is safety during regional anesthesia, guidelines and communication. Dr. Shiv requires no introduction. He's a consultant anesthetist at University Hospital, Liverpool. He's the chairman, theaters and anesthesia, specialty audit and improvement lead, as well as the regional anesthesia lead. His areas of special interest, apart from his extensive work that he does for education on social networks, is regional anesthesia, trauma and vascular anesthesia, and audit and improvement. Shiv, hand over to you to continue with the lecture.
Oh, thank you. So, and are you guys able to see the whole screen, or are you seeing a split screen?
Split screen.
It's a split screen.
Okay. And did this happen last time as well? Is it full screen
No,
now?
this is good, full screen now, yeah.
Okay. Right. So thank you again, guys. I think it's been a wonderful session yesterday. We had a very good session with almost 1.9K views, and we're hoping that today more people will be able to join. Now, safety in regional anesthesia, communication guidelines. This can be a very vast topic, but I will try to squeeze this in and try to, simplify it a bit. And the outline is about, what are side effects and complications. So every procedure we do actually has got side effects, and some people tend to, assume it to be a complication, and even the literature says that. For example, if you give spinal or epidural, if you're not going to have hypotension, then I don't think your spinal epidural is working. That's just a side effect of the procedure. And wrong side blocks, this is going to discuss in a little bit more details. Nerve injuries, last is discussed everywhere. I'll go briefly through this, and infection control is obviously important. And last part I will go through is about quality and safety in anesthesia, which is slightly, obviously we're talking about quality and safety, but in a different sense. So what about communication? I've talked about this. So where does this communication actually come in? So first, I think communication is about patient selection. Okay. Not all patients will agree for regional anesthesia as a sole anesthetic. Some might actually say that it's okay. Like, for example, in our area, people want to actually go to sleep. And then they say, once I'm asleep, you do whatever you want. Okay, so communicating patient, obtaining informed consent is very important part of that. So explaining them what is going to exactly happen, what is a procedure involved. You can then obviously go into things like whether they need to remain fully awake, can they have sedation? All this is going to be after general anesthetic. And then you need to also explain them the risk and complication. That's what informed consent involves. You also ruling out any contraindication to that you're not able to do the blocks. For example, you're not going to do a deeper blocks for someone who has been on oral anticoagulants. So how do you explain the risk? And this is a very good schematic given by the Royal College of Anesthetists. So if you say the risk is 1 in 10, then they say that it is something which can happen to one of your family members. If it's 1 in 100, it's someone who is in your street, walking in your street. If it is a 1 in 1,000, which is uncommon, then it may be a person in a village. Obviously, size of village will matter. And if it is rare, that is 1 in 10,000, that is one person in a small town. And very rare, that is 1 in 100,000, it's someone in a very big town. So this is I've taken from a article, a simple guide to regional anesthesia, and you can look at it. This is about central neural blockade and peripheral neural blockade, but I was going to concentrate mainly on the peripheral neural blockade. So if you look at the incidence of epidural not working, okay, so that is 1 in 8. It's not that uncommon. It is pretty common. So if you look at the definition, it is like within a family member. So if one has to have an epidural, it could still fail. Hypertension, headache, hypertension is a side effect. It's not a complication. Headache can be a complication of that. Nerve damage, which is temporary, is 1 in 1,000. Nerve damage longer than 6 months can be much more than that, or rather the incidence is much lower. But if you come to other serious complications like meningitis, epidural hematoma, or patient having reduced, that is remaining unconscious, or severe angiopalasis, these are very, very rare complications. And same is actually true for peripheral nerve blocks. But when we come to the incidence of peripheral nerve blocks, we have to understand that we do not actually have a proper denominator. People don't actually have denominator for their own hospitals. A number of blocks done, unless there is a registry of all the blocks. And we know there's so many blocks are done per year. Then you can confidently say that this is the rate of complication in our setup. Individually, you can, if you're keeping your records, you can. Now, the relationship of complication and the number of blocks performed is very, very important. So this is talking about individuals. So what is my complication rate may be different from what Som might be doing, or Guru might be doing, or Anil might be doing. So as you go with the number of blocks, as you exceed 600 blocks per year, your complication rate almost goes down to 0. That is assuming that you're taking care of other factors as well, which I'll come in a minute. So this is from, I'm going to talk about a publication in which they looked at the peripheral nerve injuries. So this is a 15 years of data from a local medical center. And over 14 years, they had 41 complications. Of this, 27 were peripheral nerve injuries, 3 central nervous system complications, 6 respiratory complications, 5 cardiovascular complications. And 14 were still present after 15 years. These were causing patient discomfort, not allowing them to function normally. Whereas all the central blocks, local toxicity, respiratory complication, they had obviously completely resolved. And so their conclusion was that more experienced anesthesiologists tend to have much lower complication. So people who do more blocks have lesser complication. Then this was taken from the ASA closed claims. This is from the same publication over 3 decades. Okay, so longer. The complications which were recorded were around 42, so similar. Of this, 20 were peripheral nerve injuries, 10 respiratory complications, 5 central nervous system complication, 4 deaths, 2 emotional disturbances, 1 other. So 19 of these which were described as permanent damages. So this is serious. Again, they concluded that interscalene brachial plexus blocks can be accompanied by substantial and disabling complications. So something which can be debilitating, and it's again more common with people who have less experience in doing these blocks. So complication rate increases with them being performed by lesser experienced anesthesiologists. And this was looking at what I'm talking about. The 2 studies were only looking at one of the blocks, that is interscalene block. So once you have selected the patient has agreed, you have explained everything, what are the other things you look at? So one thing is looking at performing the block itself, the environment, these people around. Then comes the nerve blockade itself. And one of the worst things which can ever happen to anyone is a wrong-sided nerve block. And this has been taken very seriously. And it is considered as a never ever event. So there used to be something called stop before you block. And now this stop before you block has changed slightly. It has a preparation part. Then it has a stop. And then you have a block. There is also people who actually say we should actually have something called mock before you block, where you try to go to the limb and you try to show to the team that, oh, this is the side I'm going to block. And if they think that's wrong, they should stop you there. Once you actually prepared your drugs and everything, the tray is given to your ODP, and they do not hand you over the tray for performing the block till you are ready. So you have confirmed that the site, so you have seen the arrow mark. In our patient, you have confirmed with the patient, you have looked at the consent, you look at even look at the list, the operating list. That is what has been there. So, and then the ODP hand over the tray to you, and then you can do the scan before this procedure, but you will not be handed over the needle and the drugs till you do that. So this is where the safety actually come in. And we can confidently say, at least in my trust, I'm the audit lead, we have not had any wrong-sided block for a very long time. Then coming to the block itself, obviously infection control is very, very important. Prevention of local anesthetic systemic toxicity is important. And what is the most dreaded one is nerve injury. So we'll look into that one by one. So coming to the infection control part. Now you have probe covers, how you disinfect the skin, whether you use drapes, do you use non-touch technique. All these are absolutely up to you. There are no strict guidelines, but you need to follow some amount of aseptic precautions. But there are certain things, if you actually look at this picture, can anyone actually say what is wrong here? Now, this again comes to training and education part of it. First of all, there is no, cover on the probe. It need to be covered, and you can actually see the gel, which is splashed over, and the needle is going very close to your probe, and it might also be going through the gel as well. And it is said they don't know, but it's not a bad thing. So first of all, you need to actually have a sterile cover onto the thing, and always come slightly away from the skin, from the near the probe. Don't come near the probe. And that is what I would actually teach my trainees. And that's what I actually follow as well. So you're not coming in contact with the gel, or if you're using chlorhexidine, you're not coming to that. And when you use using chlorhexidine, make sure that it is dry, but you can use it under that if you're, I use it, you get wiped out as you insert the needle. But chlorhexidine is considered to be neurotoxic if it comes in contact with the nerves or the spinal cord. Coming to the last, it's very important. There are guidelines on it. I'm not going to dwell into too much. Intralipid, everybody who's doing a nerve block should have access to intralipid. And this was shown by our RAD app, which Guru is here, that people, once they started entering data, they also made sure that they actually had last. And you should know what is the recommended doses for last is. Again, the guidelines are very clear. If you actually go into our Medisys Gas app, there is one chapter on the basics of nerve blocks, and that has got clear guidelines. It tells you how much to use for a 100 kg man or 70 kg man. It's very, very clear. So I'm not going to waste time in this part. But what's more important, what's more worrying is how do you prevent nerve injuries, which is a serious thing. So there are people who say that we should have triple monitoring. So ultrasound itself, okay, you can see the needle, but can everybody see the needle? Okay, that comes with expertise. And that's why I was saying that somebody who does 600 blocks a year compared to someone who does the occasional block, okay, you can give them best ultrasound in the world, they can still make mistakes. Then there are pressure monitoring devices, which can be attached to a syringe. Again, people tend to give in the hands of the, or whoever is in the theater. If that person is not used to it, they can inject in the wrong place. And then nerve stimulation. Yesterday, it was mentioned that it is like a parking sensor for you. So some people tend to use nerve stimulation along with ultrasound. So they call it as triple monitoring for nerve injury. But again, do this prevent? Probably not. And I'll tell you why. So if you look at a nerve itself, so you have various layers, but not all nerves are the same. For example, if you look at, this is a single nerve. So there is epineurium, and there are blood vessels, there are fascicles inside. You don't want to be intravascular. You don't want to be probably subepineurial injection, because if you inject large volume, there are blood vessels which get compressed. You will have a good block instantly. But there are people who actually say, yes, you can do it with smaller volumes. It reduces our volume of local anesthetic required. And there are data, huge data, where they have done it deliberately and found no neurological injury. So there is obviously still controversy over whether you can inject local anesthetic epineurally or not. But most people would probably inject local anesthetic outside the epineurium. But there's one nerve which is a commonly blocked nerve. This is a sciatic nerve. And sciatic nerve has got two nerves, which is encased by a paraneural sheath. So injecting under the paraneural sheath is very, very important. And it is not considered as an intraneural injection. You want a good block, you need to pierce the paraneural sheath. It's got various names, as POCUS sheath and sliding sheath and protecting sheath, or whatever they want to call it. But you need to inject injection, subparaneural injection for this sciatic nerve block to get a good block of onset. What I also teach is that you need to also scan distally to make sure that there's local anesthetic around both the nerves. But the same cannot be said to as a peripheral nerve. Which if you were to inject injection in subepineurial, that will be considered as an intraneural injection, and that is what everybody wants to actually avoid. Now, that was the sciatic nerve. Then comes your brachial plexus. There's been so much of literature on the microanatomy of the brachial plexus, whether it's interscalene area or supraclavicular area. And you see that the structures, they are not, we used to believe that there is a cervical axillary fascia, which covers the whole bundle of the divisions and everything, and you just go into that. But that's not actually the truth. There are actually small bundles within that, and which are very, very clearly seen. So you also have, that's like a paraneural sheath. So like we talk about paraneural sheath for sciatic nerve, there are also paraneural sheath, which probably is your cervical axillary fascia. But within that, there are bundles of that. And and you can actually go between these bundles. So now with the high and ultrasound machines, you can actually see that. I can actually show you videos where you can actually see these bundles very, very clearly. So you can actually go between the bundles and deposit local anesthetic between the plexus. So that again is not an intraneural injection. So the terminology is changing, the understanding is changing, and we are actually becoming pretty, good at preventing that. But again, it is all about experience. The more you do, the better you get it, and lesser is your complication rate. So precaution, we need to be very meticulous as a block technique. You need to follow high standard asepsis and avoid multiple attempts. So don't keep poking. Take your time. Okay, time is the essence. As you become expert, it will take you less than 60 seconds to do a block. But as you are training, it takes you longer. I think that's what which the surgeons don't like. They think that you're increasing the anesthesia time without realizing that they can take as much time as they want. But also then it's not about just doing the blocks. It's also important that you maintain stable hemodynamics. This become important because if the patient is hypotensive, you're given a good spinal anesthesia, caudal or epidural, but if patient is unstable, that's no good for them. And you need to monitor. So it is also important that patient has good postoperative monitoring for both the sensory and motor block. There are instances where people actually have done block in a hospital very near to us here. Quite a few years ago, somebody did a hernia block, and the patient, was ready to go home, stood up and fell and broke a hip, and they stopped that. That's because I think they had local anesthetic seeping to the femoral nerve. They must have gone deeper to the internal oblique. To internal oblique and transversus fascia, where they can go over the iliacus to the femoral nerve. So monitoring the sensory and motor blockade before you discharge the patient is equally important. Make sure that they're on. Again, insensate limbs, they are prone to injuries. So if you have upper limb block, give them a sling. Lower limb block, make sure that they got adequate power to stand on. So monitoring is equally important. And again, there is controversy about awake blocks. We just heard about pediatric guys. They do all the blocks sleep. We in UK, most of us do our block sleep. We don't get increased incidence of nerve injury. So that's not. But if you go to the US or to the European countries, a lot of people actually, tend to do the blocks awake, thinking that it prevents nerve injury. Echogenic needles are very, very important. So you have like sonoplex needles, which I've shown. These are short beveled. And also in plane, one of the advantages of in plane techniques are that you tend to go more tangentially than coming, out of plane where you're straight onto the nerve. So that actually prevents. Disadvantage is that if you have got something like a sciatic nerve, which has got a tough paraneural sheath, it will keep gliding over the sheath. But coming tangentially is much that. Then using minimal local anesthetic concentration of, the local anesthetic use. So higher concentration probably useful for getting a quicker onset and for having surgery done under regional anesthesia alone. But if you're using it for analgesia only as a part of GARA technique, then you can use lower concentration. And again, combining, long-acting local anesthetic with adrenaline makes no sense at all. But lignocaine you can understand, but not with low. So avoid using drugs mixed with adrenaline. So bupivacaine and adrenaline is no, because bupivacaine itself is vasodilator. The adrenaline is not going to do much on. Plus, they are longer acting. So coming to the last part of the lecture, what is about quality and safety on top? This was all about safety in regional anesthesia, but this is slightly going beyond that. So some of the things which can improve the quality and training and education, skill development and retention is by using something called parallel working, where there are block rooms. And this is, again, some of the centers have. So the trainee come in, they are with the consultant who's doing the block room. The blocks are done, so they do a huge number of blocks. So the numbers are maintained, and you're able to maintain your skills and development. The third thing which is lacking and which is about quality and safety is a follow-up. So one of the advantages of regional anesthesia is that it helps us to discharge patient early home, but are we able to follow what happens to them? And that's important part. Again, with the app we have just launched, the Medisys Gas app, if people are actually using it, it allows you to do that follow-up, which obviously it has to be with patient consent, but it lets us know, how long the analgesia lasts. Did they wake up in the middle of the night having to require, extra analgesics? Or did somebody actually have an injury and they ended up in another hospital? These things are very, very important, and they quantify the quality of your regional anesthesia and safety of regional anesthesia. So to end the surgery, to the lecture, sorry, we need to understand the difference between side effects and complications. You don't talk about side effects. I say you will actually have, patient will have that, but these are short acting or can be taken care of. Don't describe them as big complications. The wrong side nerve blocks is never ever event. So, every patient you need to follow prepare, stop, and block. You can also do mock and block. Infection control is very, very important, and ensure that your needle does not go through the gel when you're using that. Come from a little far off. You will get used to it. Last, make sure that your intralipid is available to you. You know how to recognize the signs and symptoms of central nervous and cardiovascular. So in last, CNS symptoms occur much early, easier to detect in awake patient. And for prevention of nerve injury, yes, you can use triple monitoring, but more important is to understand the neuro microanatomy. And also, the more number of blocks you do, the better you get at it. And in the quality and safety, skill development, retention, and follow-up, these are three things which are very, very important. I think block rooms where you do high volume blocks actually helps in this. And thank you for listening to me. I'll stop sharing my screen.
Thank you, sir. Yeah, thank you, sir. It was a fantastic lecture.
I don't know if you're still watching the screen.
No.
We have 5 minutes for discussion.
Yeah, if anybody has got any question, I don't know what's happening with the...
There aren't any questions on YouTube. If any other faculty wants to add any points.
I just have a comment, Anil. Shiv, thank you very much for bringing the wrong side block. It was not something that we expected you to bring up as part of the lecture, but thank you very much. It's very, very important to understand that the safety is not just a single person's responsibility. It's a system approach. It's absolutely essential that we get the entire system, the entire team to be fully aware that just exactly as wrong side surgery is a problem and the wrong side block is a problem, is a similar problem, and the solution is the same thing, which is a systematic approach to being having a proper check-in, site marking, consent. This is a really huge problem because we have surgeons who will want to come and take consent in OT, and we've got down to the point where we've put our foot down and said patient can reach the OT, but will not be allowed to enter the OR unless there is a consent form both for anesthesia and surgical procedure signed. So it's somebody has to take the hammer out and insist that these things happen. Otherwise, there will be people, just because we all work in a team, to make these small compromises, which then will result in one day somebody having a problem, which is something that is not acceptable. Go ahead, Shiv.
So one of the things which I did not stress upon is that empowering everyone within the theater. It does not matter whether it's your orderly, it's your sweeper, if you're nurses. Anybody should be allowed to raise their voice. So this is also known as psychological safety, wherein anyone is allowed to bring out, they feel safe. That's what it means. Psychological safety means they feel safe to raise concerns of any kind. And that need to actually come from the higher management. It says, no, you will not be penalized, because there is a huge hierarchy within the Indian system, works on hierarchy. People think that if I am an orderly and you're a surgeon, I cannot question you because you're at a higher position. That psychological safety can only be provided if the higher management actually is doing so. It is not just within the team. They need to say, no, when it comes to patient safety, that is the most important thing. That's why you are getting your salary, because patient is here. If patient comes to harm, nobody will come to us. We will be actually on the roads. So if you think there is something wrong, okay, you want to, please raise it. And if it is not the case, it's fine. You actually say, okay, fine, you raised it. Do not actually then mock them, saying that, you didn't, actually, that wasn't the case. And if you actually remember how the wrong side surgery thing came, was that a medical student was telling a surgeon to, they say, you're doing a wrong side operation, and the surgeon just ignored him and they took out the wrong kidney. So the patients now lost both kidneys, and patient later died. And that is how it all started off long ago. If that surgeon had actually, tried to actually tell, or the surgeon had listened to the medical student, that wouldn't have happened. So empower your people. Let it come from the top management that you are safe. And that requires repeated reinforcement that you are actually important to us. Everybody is important, and patient safety is paramount.
I have a few questions on YouTube, sir.
Yeah.
Dr. Raghavendran wants to know, do you site mark the block site as done for surgery? And he also has one more question. Any timeout procedure done as in the operation room if blocks are done in a separate room?
So the first one, no, there need to be only one mark on the body. You cannot actually have multiple marking on the body. It need to be a surgical mark, because that is the side of your block. So, and it need to be very closer to where the surgical site is, and that's where you normally do. So it need to be only single marking on the body. No multiple marking is actually allowed. One. The second thing is timeout. The block before you stop is like a timeout. So the check-in is done. You do not do block without a WHO checklist. The first checklist, which is done along with the surgeon comes in, they do the patient check, everything is done. Despite that, you would actually, as part of the stop before you block, you will still, go through the consent form. You will check that the site is the same, and the preparation happens, and the tray is given to the to the ODP, and they will hand over you once you have checked that. So that is a check within that. There's no separate kind of thing for the blocks itself.
Dr. Sekar has a question. Any antiseptic ultrasound jelly available?
No, it's not antiseptic jelly. It is usually a sterile gel. So you do not use the bottle gel, which is used by ultrasonographers in the clinic. These are small pouches available. So these are sterile gel. They are not antiseptic. You need to. So sterility is for the skin. You use sterilized skin with chlorhexidine. We use alcoholic chlorhexidine. And over that, you need to use a sterile gel. Guru has, I think, got a comment to make.
Yeah, hi, Shiv. Yeah. Just regarding marking for the block, with Dr. Raghavendran had suggested, look, I mean, everyone's perspective and practice is different. And what I personally do is I mark the block site myself, and that should correspond to the surgeon's site.
Yeah.
Secondly, I think I feel the most common problem of right and left comes when you go on to do blocks at the back, when the surgery is in the front. Now, I've almost, we stopped one and we had a near miss. Sorry, I'm just outside here. Just a bit of so when anesthetic trainee was about to do a rectal spinal block, turned patient lateral and was almost about to do it on the wrong side.
Yeah.
Now, the marking by the surgeon is on the front.
Yes.
And the block is done at the back. And that is where we changed our practice, stating that irrespective of the surgeon's marking, it is imperative that we mark, and that kind of is again, it empowers you, and it is in your hand, and you are directly responsible for doing the block on the correct side. So that is one key. I think we can still do our own marking of the site. And for example, in many surgeries, the surgeon's mark is quite far away from the site of surgery, and is often can be covered by drapes and things like that. So I would always do my own marking near the site where the block is going to be. So that gives me an extra assurance that I'm doing the correct site block.
Yeah. So there are various things which actually described in the literature. Things like you having sticker with the block and like Guru said, marking. Now there obviously is a concern, especially if there are double marking and the side of block. It's okay what Guru has mentioned. I think that is very, very reasonable thing. So change in position is one of the problems which can actually cause wrong side block. Okay, you confirm patient lying, that patient need to go prone for the surgery. Your right left orientation changes. In those cases, fantastic. I think good idea to actually have a mark on. The stickers are things we say, oh, this is only temporary, but stickers can actually move. Okay, so never realize. So always check, double check, check again, and this stop before you block. Where like I said, the tray is not handed over to you till you are confirmed that everything is right. And people doing mock before you block as well. That makes. But again, if people are not empowered to tell you that no, you're wrong, anybody should be able to that, they will still happen. But yes, as Soma said, it's all about processes within the system. Okay, the process should be very clear. The direction should be very clear, and everybody need to follow the instructions to that. And anybody should be able to raise the concerns.
Start the next.
I think I've spent a lot of time on this. I think we should move on. Yeah.
I'll just take 1 second, Anil, if you don't mind.
Yes, sir.
So, Shiv, basically what we do is we have our own sleeves available, which are sterile. We don't use gloves. I have found gloves really messy to use, and they're too short. And the other thing is we don't put gel outside the glove. The gel goes inside the glove. Or inside the sleeve, not in outside the glove or the sleeve. And what we find is we use either chlorhexidine or saline as the
interface
material to try to reduce or improve the vision. And saline is safe, whereas alcoholic chlorhexidine may be unsafe, especially for nerves. So probably that's a useful way to maintain the sterility during the procedure.
Yeah, the advantage of alcoholic chlorhexidine that what dries out is outside the probe. Under the probe, it can still maintain because you're not allowing to evaporate. So you don't usually get chlorhexidine. Also, as the needle is going through the tissues, it is actually wiping it as it goes. So you never actually have any chlorhexidine left on the tip of the needle. So that doesn't happen. The incidence has been where the chlorhexidine has been injected into the spinal cord. Okay, or
but we could achieve the same thing with saline.
Absolutely,
saline works equally well. Yeah,
absolutely. Okay, let's move on, guys.
Thank you very much, Shiv. It was a very elaborate and exhaustive presentation, and we all I enjoyed it particularly. So we next go on to probably what is the most important bit of regional anesthesia is its integration into the acute pain service. So we have the pleasure of Dr. Vasantarupan, who will be talking to us about setting up an acute pain service in your hospital. Briefly, Dr. Vasantarupan spoke to the quorum yesterday as well. He's a senior consultant in anesthesia. He's head of the liver transplant and hepatobiliary anesthesia at Apollo Hospitals, Chennai. His main interests include acute pain and regional anesthesia, liver and multi-organ transplant anesthesia, robotic surgery, anesthesia for robotic surgery, orthopedic, and I'll hand over to Dr. Vasantarupan to speak to us about setting up the acute pain service in your hospital. Thank you.
Yeah. Good afternoon, everyone. Thank you, Dr. Somnath and Shiv Singh, for giving me this opportunity. So my topic will be on setting up acute pain service in hospital. So what is acute pain? Acute pain is any pain which follows an injury, and it heals once the pain stops, and the pain is not depends upon the severity of the injury. It can be traumatic injury or it can be surgery-induced injury, and it will automatically stop once the trauma heals. And sometimes it can take weeks to resolve, depending upon the site and severity of the injury. Why do we need an acute pain service in any setup? We will go into this in detail because this is very important. A survey in India recently by Jain et al. Revealed, this was in 2015 published, only 30% of patients received adequate pain relief. And anesthesiologist involvement in these patients was only in 45% of the hospitals. That is, the anesthesiologists were involved in this pain relief only intra-op, not even in the post-op care. 50% of the APSs, there was no written protocols. They were just following whoever, like if surgeon writes something, it was followed. Anesthesiologist comes in between, sees the patient and writes something, it was followed. So there was no written protocols in 50% of the APSs. There was no training imparted in any of these hospitals. Only in 29 to 30% of the pain services, some sort of training was imparted to the involved staffs and members. In 60% of the APSs, pain was not measured regularly, it was not documented. And if some intervention had been carried out, for example, say if the patient had sudden acute pain, some medicine was given, the follow-up was also not documented properly. And there was no single stakeholder of post-op pain in all this setup, even though those setups showed that they have been following an acute pain service protocol regimen. There was no single stakeholder, like nobody was in charge of the services. Everybody had free hand in it. And so there was no proper protocol. So these APS services were of questionable quality in Indian setup. A survey in USA, this was in 2014 by Gan et al. Revealed 86% of the patient experienced pain immediately after surgery. And out of this, 75% were moderate to severe pain in the immediate post-op period. And 74% of these patients had the same level of pain even after discharge. This was as recent as 2014. A UK survey by Powell et al., this was an old one, in 2004, revealed that 95% of respondents revealed that better organization of pain services was needed in their setup. So this acute pain service was, this idea was mooted by Reddy et al. And suggested by him in year 1988, slowly after which hospitals in US followed, then it spread to other areas. So they suggested just a simple organizational restructuring of the pain services. They didn't advise any complicated or advanced technological introduction, new techniques, new technological instruments, nothing. It was just a simple organizational restructuring, which was required to provide a good acute pain service in the hospital to improve quality and service and patient satisfaction. So The other things which we have to see is that most of the time there is insufficient pain control in the post-op period, and there are analgesic gap. Like if there is a transition between the some nerve blocks or epidural infusion, switch over to oral analgesic, there's a gap where the patient feels pain, acute severe pain. These sort of things happen during any for any patient in the perioperative period, and we have to prevent, reduce adverse events and side effects. Okay. Side effects can be like simple side effects which can have long lasting effect. We have the most common thing as postoperative nausea, vomiting, PONV, urinary retention, pruritus, hypotension. These are not adverse events but side effects. And if the pain is not adequately controlled, and if the patient comes repeatedly for surgery, is as a condition such as he has to come repeatedly for surgery, or had a major surgery after which the pain was not adequate control, it can lead to chronic post-surgical pains, which can lead to chronic pain syndrome. And patient may develop opioid dependence if the acute pain service is not properly done due to abundance of use of opioids. And we can see this clearly in some countries where there is huge opioid dependence, and patient coming from there, when we are treating those patients, they respond to nothing else except when they are given the same opioid for pain relief. They develop physical dependence. And most of the hospitals lack experienced ward nurses in managing pain. They are not updated on the modalities, different modalities and newly emerging techniques for pain relief. So they are not as experienced in managing these pain patients. And in unavailability of competent physicians and surgeons in ward who can take care of the patient's pain side effects, who can identify the problem in the patient and communicate to other people involved in the pain services. And slowly it is being recognized that we should not restrict sophisticated and advanced analysis techniques only for ICU or HTU things. Like previously in our hospital, we have been keeping the patients in high dependency units, patients who are receiving continuous nerve blocks, epidural infusions, those patients. Nowadays, the continuous nerve block infusion patients are being managed inside the ward itself, because the nurses, ward doctors and pain nurses all have been trained to manage the problems arising and the management of nerve block infusions. So we need APS also for speedy recovery of the patient, decreased length of stay in the hospital, and lower readmission rates due to side effects and increasing pain problems. There are basically two APS models mooted. These are, one is physician-based. Physician in the sense it's anesthesiologist based. It is a multidisciplinary APS where all fields involved in the surgical, both surgery, physiotherapist, pulmonologist, everybody is involved in this physician-based model. It is costlier, and here the ward rounds are done by the junior anesthesiologist along with the senior physicians, and slowly it is being abandoned. Now the most popular one is nurse-based APS model, where the nurses take over the role of doing ward rounds regularly, twice a day at least, and this is being supervision by anesthesiologists, some anesthesiologists, and it has been found to be very cost effective. And there is no evidence that one is superior to the another. It all just needs, as I said earlier, organizational restructuring. So setting up an APS depends upon the type of healthcare system. So it can be a primary healthcare system, which we are talking about, a secondary hospital or a tertiary care hospital, some community-based hospital. It can be private setup, small nursing home, wherever the APS can be set up easily. And it also depends upon the hospital size and structure. It can be a small hospital, less than 50 bedded, 100 bedded hospital, and bigger than that, and structure of the hospital. Some hospitals have all the facilities in one building, within one building, one structure. Some hospitals have different buildings and different units for different specialties. So those will require some modification of the system, but basically the setting up of APS is the same. And the surgical spectrum. So depending upon the specialties of surgeries done in the hospital, it will differ who are all involved in the pain service. And economic constraints, obviously. The key for high quality APS. In this, there should be some minimal standards set up for delivering the APS, like adequate pain control, preventing adverse events. These are all minimal standards which are required, decreasing the side effects of early mobilization, early recovery, and early discharge. And there should be round-the-clock availability of all the personnel involved. It need not be in person. It can be on call also. The anesthesiologist involved can be on call. And adequate staffing. The staffing need not be very much. It depends, as I said earlier, it depends upon the size of the hospital, structure of the hospital, facilities available. But the bare minimum needed should be available. There should be some standardized institutional policies and procedures according to which it should be running like a well-defined oiled machinery. And this is most important, integration of post-op pain relief into multimodal rehabilitation program. You need not aim for always 100% pain relief, a VAS score of 0 or whatever. But if you educate the patient very well prior to surgery and involve all the people involved in the early recovery, like the fast-track surgery era system where physiotherapist is involved, surgeon is involved in managing the patient post-op. So everybody all get involved in it, and the patient is discharged faster due to the proper management of the patient at all levels. So we have to develop proper clinical pathways for each different type of surgery, for each individualized specialty, and so on. As I said earlier, it needs the collaboration with other healthcare professionals also who will be regularly giving their inputs in the faster recovery of the patient. So requirement of APS. It can be dealt under 4 topics: personal cooperation, education training, and quality measures. So regarding the personnel, first thing is they should be available round the clock all over the year. Second is specialist pain nurses. These are the most important one. They will do twice a day ward rounds. They will collect data regarding the patient, like how much pain they are having, how frequently they are having, whether it has been dealt well, whether they troubleshoot issues, whether the infusion pumps and whatever IV fluids are going correctly for the patients, whether any side effects have been managed well. And they also get involved in training and education of the ward nurses. This is a continuous process. It will not be the same. The specialist nurses will also be getting regular trainings and updated on the newer modalities, any change in the policies, those things. And there will be pain representative ward surgeons or ward doctors in the respective surgical wards who will take care of the pain management of the surgical ward along with the pain nurses, and make sure that the analgesia techniques are integrated into the clinical pathways. Then the anesthesiologist will be involved. He need not go for rounds every day, but he should be supervising what all be done there. And if necessary, he should go in person and check the necessary things. He will be involved in the perioperative care, that is pre-op, preemptive analgesia, intra-op care, post-op pain relief, and any side effects arising out of these medications. And he should be involved in the training of pain nurses, residents, and staffs. And there will be one director of acute pain services who coordinates between the different subspecialties of anesthesia and surgical fields for the delivering of good APS. So cooperation with the other disciplines. So in acute pain services, it's not only pain relief, but our aim is early recovery and discharge, good patient comfort. Okay, so we have to cooperate with other disciplines. For example, it's not alone that you give adequate pain relief. Example, for if the patient has undergone some upper abdominal surgery, you give adequate pain relief, but you don't take care that the patient is doing good lung breathing exercises, doing early ambulation, those things. then it's not fine. You have to make sure that these things are getting done properly and everything has to be coordinated. So you have to get the physiotherapist involved, the nurse involved who is taking care of the patient, and if needed, pulmonologist involved also, and if needed, the surgeon also involved. So you have to develop new pathways, implement analgesic and rehabilitation protocol, and you have to achieve preset goals for post-operative rehabilitation. Again, as I said earlier, these should be continuously evolving, and every way of improvising these things should be done regularly at regular intervals. So the APS also involves continuing education and training of all people involved. So both medics and paramedics, they have to be trained well in pain assessment, documentation, including the vulnerable patients like pediatric patient, senior citizens, and they have to be trained in the different types of analgesia techniques, their side effects, identifying these side effects, and all algorithms. And they should be constantly communicating with the patients. Yeah. So next comes the quality measures. So it's not just adequate if you keep on doing the services. You have to constantly reevaluate, collect the data, constantly reevaluate what has gone wrong. Is there any improvement that can be done? Take the inputs from the patients who are getting discharged. So it should be a continuously evaluating process, and quality measure is one of the most important thing in providing a good APS. So all patients have to give their outcome reports. Patient reported outcomes are to be collected by the sisters. If the patient was very satisfied with the pain relief, the post-operative physiotherapy, any deficiency was there in the medications or complications, any deficiency in the care of the patient, and risk and benefits of analgesic techniques also have to be constantly reviewed, and policies and procedures of these things have to be continuously updated and changed according to the requirements. So patient-related tasks of an APS. These can be dealt under patient education before surgery, post-operative assessment and documentation, adaptation of treatment, and APS checkout. Regarding patient education before surgery, all the persons involved in the APS should adequately be informed about the how to educate the patient before the surgery. These include giving the patient information on treatment options, all treatment options, possible adverse events and risks involved in the procedures, goal of the analgesic therapy. Always the goal is not a complete pain relief. There will be some adjustment between complete pain relief and ambulation. For example, if you are undergoing some knee replacement surgery, the patients, if you want to, and patient is receiving some epidural or some other nerve block, okay, and you can't aim at complete pain relief. If you aim at complete pain relief, then patient will have some kind of motor block or loss of position sense, and he won't be able to walk. So patient should be educated beforehand itself that these are the realistic possibilities that can be done for pain relief, and what is expected out of him in return for his proper recovery. These things should be clearly explained to the patient pre-op itself, so that patient already will be mentally prepared that they will experience some level of tolerable pain after surgery, and so automatically they will feel comfortable post-op. They won't be keeping on complaining that I have some pain, I have some pain. You had told that there won't be there will be 100% pain relief, those things and all. So assessment of pain and function. Even assessment of pain and function will be individualized according to the type of surgery. So the patient may be feeling pain-free when he's not mobile, when he's just simply lying on bed, but we need him to move, ambulate. So if then he's having pain, then it has to be taken care of. And shared decision making and communication of treatment plan. This is the most important thing, which once the patient understands clearly what we are going to give him, provide him, and what is expected of him, then everything becomes easy. Post-operative assessment and documentation. So APS rounds, everybody suggests at least twice a day rounds, once in the morning and once in the evening. That is once immediately after surgery and once post-op after some time. And surgery specific pain scores. As I told you earlier, the surgery specific pain score is some surgery will need early ambulation. So you can't tell the patient is having zero pain on at rest. You need to evaluate the pain on ambulation. So those are the surgery specific pain scores. And pain related impairment or interference in the ambulation or breathing of the patient. If the patient has undergone some thoracotomy, you have to take care of, because he has to take a deep breath after surgery. So pain related impairment and interference with the surgery, some side effects and adverse events, all this has to be documented and noted. And it is advised that you have a proper format for these things. And it has to be constantly updated and improved. The amount of analgesic consumption, need for any rescue medication, desire for more analgesics by the patient, and check for any technical issues like the infusion pump not working properly, not giving alarm at the right time, those, and connections between the infusions leaking, because of which the patient may be having pain. You would have suggested the correct dose and giving boluses if the patient is having pain, but you wouldn't have noticed that there is some leak in the catheter somewhere. All these have to be taken care of. Adaptation of treatment. So, though there will be some protocol and these things for management of patients in APS, it can't be strict and hard and fast that this has to be done. It has to be individualized and modified accordingly for different patients. It is a guideline which has to be followed, but there can be some modification depending upon the patient's desire, their preferences, and need for the analgesic requirement post-operatively. So every time you have to, if there is any change in plan, you have to discuss and communicate the plan with the patients and adapt it to the individual needs. So if there is any change in therapy other than what was previously planned for the surgery, it has to be re-evaluated, whether it's working properly, whether the patient is satisfied. Okay. And discuss and communicate the treatment plans with other disciplines also involved. So it's not like surgeon has operated some abdominal surgery, patient is having pain, you have come and given some opioid, tramadol to relieve the pain, but surgeon will then come and say, oh, you are given opioid, now patient is having gastroparesis. Why did you do this? So before doing any intervention in the change in the plans, you have to communicate with the other disciplines also, so that they are also in loop with the procedures you are doing. Finally, APS checkout. So this is like, avoid unnecessary drugs which can cause dependence of the patient or cause undue side effects, though they are very important, like timely cessation of opioids, and recommendations for GPs for the post-hospital phase. You are discharging the patient due to the proper working system of APS. Patients may get discharged early, but after discharge, they should not have pain. So there should be some advice for the patient for any post-hospital phase of pain relief. So it should be a clearly written instruction for the patient, as well as for GP, whom they may refer locally, because they may not be staying nearby. So there should be proper recommendations for these patients for post-hospital phase also for proper pain relief. So coming again to the structure and function of APS, this is what briefly needed, just restructuring of the available services needed. So you need a ward nurse who has been well trained by the APS nurse. The black arrows show the hierarchy. The red arrows show the communication between the personnel involved. Okay, so the hierarchy is, there is a director of pain service, anesthesiologist under him, and he takes care of the APS nurse and ward surgeon and doctor's roles, and both of them in turn scrutinize the ward nurse who is involved. And everybody involved gets inputs from each other so that the APS service gets improved. And other people who are involved, not directly involved, but they also take part in the services, are the surgeons, physiotherapists, pharmacists, psychologists if needed, if the patient is dependent upon some drug, opioid dependence, physical dependency, psychiatrist, EMOs if the patient is having trauma, for example, on-arrival blocks, catheters, etc. Okay. So the take-home points will be, APS needs just an organizational restructuring, nothing much of a thing, only additional 2-3 staff needed, but they may need adequate training, repeated educations, integration into multimodal rehabilitation program and clinical pathway. This is very important for early recovery, early discharge of the patient. Nurse-based anesthesiologist supervised model is best. And education and training of all people involved is must. Documentation, data collection, I need not stress this, it's always needed. And quality measures for constant improvement. And based on this, constant development of policies and procedures. These are some of the reference which I have taken from. So just to show you how we have improved our patient services. This is a 14-year-old girl. 14-year-old girl who has undergone anterior scoliosis correction. That is, the thoracotomy has been done and screws have been placed to correct the spine. It's called tether. You can't see any rod here because it's a flexible surgery. Patient can move their spine. They can bend, if they are a sports person, a dancer, anything involved, they can do. So this is a flexible nylon tough tether, what they call. So this surgery is called non-fusion anterior scoliosis correction. This is POD day 0 of the girl. Okay, same day after surgery. Surgery starts at 8. It was finished at 1 o'clock. This was around 6 p.m. or 7 p.m. Child is walking. You can see IV cannula in one hand. This is the arterial cannula used intra-op. So same day she is walking without any problem. And mind you, there is no ICD also in here. We have stopped using ICDs for these patients, and patients are discharged after 48 hours. Such a major surgery. This another example. So this patient is a 15-year-old male. He has already undergone a surgery for scoliosis correction 1 year back, which has failed now because there is still more scoliosis happening above and below. So it was planned to put more screws and change the rod. Okay. So surgery again started at 8. It got over by 12. Same day he's walking again. This is the arterial cannula. This is IV cannula. Same day he's walking. This is posterior correction, posterior scoliosis correction, POD 0. So as you can see, the physiotherapists, nurses, everybody is involved in the care. And this concerned surgeon is every day coming at night, and no, not the surgeon per se, surgical assistants are coming and ambulating the patient, make sure that patient is getting ambulated, doing the triflometry or tribal exercise, deep breathing exercise, and documenting everything. Thank you. Thank you, everyone.
Wonderful lecture, Vasanta. I think it covered all aspects of acute pain services.
Yes, sir. Great lecture. Thank you for such an elaborate lecture, and this will definitely motivate most of us to have a great working acute pain services in almost all the hospitals. So,
Vasanta, can you stop sharing your screen, please?
Yeah. I'm just doing it. Yeah.
No problem. Thank you. Thank you.
Points you would other faculties want to add?
Again, Vasanta,
yeah.
Sorry. Extremely informative presentation. Thank you. It's something that we've been striving to do, and hopefully we will reach out to you to get more details. An acute pain service, the other, I think, concept that you mooted in your previous presentation was a pain-free hospital, and that is something that is very inspiring. It's something that unless you have such lofty targets, you're not going to have a direction and the pressure to push yourself to achieve. And pain very few people understand is a very important vital sign and as a very important reason for patient dissatisfaction. None of us will want to be in pain post-operatively. And I still remember I've had 2 surgeries, and the first thing I said when I woke up for both the cases is I'm not in pain. And that's a wonderful feeling. We all wake up after the surgery believing that we will be in some sort of pain and groggy. I woke up clear-headed and completely not in pain, and I was, absolutely thrilled with my anesthetist. So it's something I've taken your suggestion of a pain-free hospital to heart, and we'll really inspired by that thought. Thank you very much.
Thank you.
Guru has got his hand up. Guru.
Yeah. Look, thank you very much. It was a wonderful presentation. For those of us who've been working in an atmosphere where there are acute pain services, we do understand the huge benefit that gives to it. It actually is important, whether it's a small hospital or a big hospital, to have some kind of a service for acute pain management to each patient. It is, I think, pain is patient's right to be relieved. It's their right for that pain to be relieved. And we should consider it as their right, and we should work towards it. And each anesthesiologist should be passionate about providing pain relief service. And it just goes beyond an intraoperative or recovery phase, that until discharge or even post-discharge. And to be honest, we learn a lot from being part of the pain service, actually, what the patient undergoes. And we can actually modify our anesthetic techniques. And that I will coming through with my next talk about auditing regional anesthesia. We have audit for our acute pain services also, which looks into various aspects and which is critically analyzed, because, it is not a healthy state for a hospital to have poor patient outcomes, being it simple pain score to patient dissatisfaction. So it does not look good. And this lecture, I'm hoping that, a lot of anesthesiologists across the world and across India, where they don't have any service at the point of time, can have an introspect and start looking at how or what I can do in my practice to achieve this aim.
Yeah, actually, all it needs is just one passionate anesthesiologist who is very mindful that no patient should have pain. If there is one such kind of guy in every hospital, then he can naturally evolve acute pain service. It need not be like setting up totally organized, recruiting more people. Just he should take care that everybody who's coming for surgery goes out smiling out with good satisfaction. That's all.
Can I come in? I think.
Shiv, go ahead.
Acute pain services. I understand that you need someone with a passion, which Vashanta, you have rightly said, but it requires a big team. It's not a small task, and even we struggle to actually provide the service for each and every patient. In our services, what happens is the patients who are on patient control analgesia, patient are on catheters, patient on epidurals, those patients are seen by the acute pain services. But if somebody is not on any of these, they are assumed that their pain control is okay with just oral opioids or IM opioids or whatever, or they're not. So that issue actually still remains, that the pain acute pain teams will only see the patients who they have there on the list. They're not going to go and see each and every patient. Also on the wards, these post-op patients are not actually in a single area. They are distributed all over. So they can't actually, so it will take them, if they were to actually see each and every patient in a hospital, which is almost 800 to 1,000 bedded hospital, it becomes a daunting task. It is not actually possible. But I actually totally agree with you that if we aim high, then we will actually achieve something substantial. There are actually, it's a very I won't say a strong statement, but I think it is something which is everybody should try to achieve as pain-free service. But at least patients who actually walk into the hospital without pain should walk out without pain. That should be the actually thing, because you will actually get patients who have a chronic pain, which I think we have not covered in FARA, is a group of patients who actually come with pain, who are already on painkillers. And how do you actually manage that? That is a big area as well, I think, which we should cover at some time. How do you manage these patients? If somebody has got chronic pain, you can give them the perfect block. You can put catheters, they can still be with pain. So how do you manage their expectations? At least you say, yes, you have come with a lot of pain. We will make sure that your pain is tolerable. It is which you can live with. We cannot always say in every patient that, okay, we will actually have you completely pain-free. And yes, aim high. That's what Abdul Kalam used to say. If you aim high, you will achieve it. Yeah. Guru, you still got your hand up. There you go.
Yeah.
Over to you.
Yeah. Thank you, Shiv. Yeah, those are wonderful points. But one of my main concern here is about more than 60 to 70% of the surgeries happen in smaller private hospitals. I'm not just talking about India, it's across the world. 50% of my practice or more than that is in private practice as a freelancer kind of thing. All right. And you are not employed by the hospital. We just go there, do the anesthetic for that surgeon and walk out. And I do wonder, where is the APS? Why is APS only restricted to those academic or public teaching hospitals? Why there is no acute pain services in private hospital? There was an attempt, but I think that was squashed off because time is money, and a lot of anesthetists don't have time to dedicate for this service, and this service is not remunerated. I would rather be doing an anesthesia for other surgery rather than going and doing pain rounds, which is not remunerated by the patient or by the insurance. So there is a lot more complexities here. And what we need to address is freelancers in India, right? How can they kind of achieve some kind of a pain service? What about that 70% of the patient who are not looked after at all? So I think it's a brainstorming session that we can have among the Global Anesthetic Society Game Changers members. And using our platform, we can provide some kind of an arrangement, being it providing, automated services of patient education leaflets that goes across to the patient digitally or through mail or something, or to be handed over. That is a good start, that if we can provide patient education and some kind of a follow-up service, again, which can be achieved digitally. The good part of this, or the silver lining of COVID is that a lot of illiterates have become digitally literate. They may still be illiterate, but their digital education, that is ability to use the smartphone for many things, has exponentially grown. So we have to make use of these opportunities to kind of improve the quality of service we provide for those patients who are not part of these big teaching institutions or where there is no APS services. So I think we will all sit together and
brainstorm.
Look, I think Vasantarupan can be part of this, and we'll be very privileged to have him on board and see how we can kind of enable almost every anesthesiologist, with a tool that they can help their patients, and improve safety and quality and improve pain service.
Absolutely. I think we need passionate people. Vasanta will come to you in a minute. Som has got his hand up. Som.
Yeah, thanks, Shiv. For just a little bit of an advice from an old man here, what I basically believe is this is a request to all the trainees who are with us today is, please do write up analgesics for your patients as you would like them to have post-operatively. I think please make sure at least the first 1 or 2 days is covered. It's not standard practice. We leave it to the surgeons who know very little about analgesics and the timings. And this is something that, you look at any post-op drug chart or instruction written by a surgeon will have tramadol or Ultraset, and, it doesn't take care of the pain properly. And you are the best person to do this post-operatively. And I think it's a responsibility that you have. I think that's my one request, that all of us should write up our post-operative analgesics for our patients, at least for the first 2, maybe 3 days. The other thing that Guru was talking about, is a big problem in private practice, but we just forget our responsibility for having provided anesthesia to the patients. And if you're talking about how do smaller hospitals or freelancers manage, I think a lot of freelancers today are working in groups, and I believe if they put their heart together, that is something that can be achieved, where the patients can still be provided the service of an anesthetist when it is required, and that's if you passionately believe that's the case. I'd just like to take this opportunity to ask Arun, who works in Aster CMI, to tell us about his pain service, how it is structured, because there are very few hospitals in India who have a structured pain service. And, Arun, we'd love to hear from you.
Now, we've been running an acute pain service for almost now 6 years plus. So initially, it was a bit of a resistance from management, surgeons, everybody. Why do you want to go and look at them? It started off by saying, no, we look after our epidurals, we look after our regional anesthesia catheters. Now, slowly it's expanded to them looking at the patients, looking at their vitals, making sure if some epidural or infusions running, patients are comfortable, patients are mobilized by the physiotherapist in their presence. So if they have to upgrade their analgesic for any reason, they will do it. And if for any reason the catheter has to come out, or say it's day 3, day 4, catheter has to come out, they will go and suggest it to the junior surgeons on what should be the timings for the drugs and what drugs should be written down on the chart if it's not already there. Quite often even our juniors would write it down on the charts, but if by chance the day 3, day 4, the charts change or it's not there, they would go and suggest, and they'll tell them. If nobody else is there, an anesthetist will go and write it and come back, but usually the surgeons will comply. Now, over a period of time, what's happened with people, especially the general surgeons, orthopedics, is if the nurses are not there, they ask why is the nurses not there, or they have not seen the nurses. Because these nurses now tend to know more about the patient's mobilization and the patient's activity level post-op than their surgical colleagues or even the surgical juniors. Because one thing you have to remember, in corporate setups, juniors come and go. They change every year, they change every 18 months. But quite often the nurses hang around for a much longer period of time if they are local nurses. And luckily for me, I've had 5 nurses till now, but at any given time, 2 nurses have always been there for more than 2 years. They will leave and go. That's not this thing, but you can always get the previous nurses to train new ones, because even now, last few months back, we had a change because somebody went on maternity leave. But before she went on maternity leave, she made sure the next nurse who came in was with her for at least a month. So they can maintain their continuity. Now, what we've realized is anesthetists can probably, as Guru was saying, it's not remunerated. So they don't tend to go and see. Private practice people don't tend to go and see. You might see the post-op patient once in a day. But I'm happy to say my nurses look at them at least 3 to 4 times a day. So that kind of input, once the nurses give, you can make decisions. They don't have to make the decision. You can make the decision, but they will see the nurse 4 times a day. And that's been happening. Okay, their services is not remunerated, but it comes out of the hospital listing. It's a nursing service. And we managed to keep track of all the patients. Now, Shiv was mentioning about patients who don't fall under the ambit of a regional block or a catheter, but they are post-op patients and they escape the net. Now, quite often now what's happening is some of our high-risk patients or the patients whom we know may have a problem, these nurses go and see them for the next 24, 48 hours. So they keep track of what's going on with them. Same thing, but say a cesarean sections happen, they will make sure that the patients are followed up for a few days. They'll make sure all spinal patients are followed up for 48 hours, 72 hours to make sure there's no headache. If a patient has a headache, has got better, gets discharged and goes home, they pick up the patient's phone number and call the patient for the next 4 to 5 days post-discharge, just to make sure the patient's fine. So we've picked up patients who headache has worsened maybe about 5 days afterwards. That's about 2 or 3 days post-discharge, it's worsened. Call in the patient, get them to the OPD, talk to them, and then you find out that the simple things, the patient's not been resting, they've not been drinking enough water, they've not been taking their analgesics. So these kind of simple interventions happen because these nurses are able to pick it up. They've been in the system, they're able to call them up, they call the patients up and they pick it up. Now, this is something which is an ideal scenario. I think Shiv and all they have the district nurses. In India, we don't have, but I've been lucky that we managed to get these nurses on board to doing it, and it seems to be working. Patients are happy. And when it comes from a nurse, the ward nurse also accepts and changes practice. Whereas if you have a doctor telling them that this is what you should do or that is what you should do, they don't take it to the same extent as what would come from another nurse, another colleague of theirs. And that's helped us in trying to pick up problems at night. We've had issues, a lot of different issues. These keep cropping up. Suddenly pumps run out, stocks are not there, or infusion sets are not there, the company changes. So a lot of on-hand training goes on by these nurses, which they will pick up, they will go and tell the ward nurses. So that kind of knowledge flow through happens much more easily if it's a nurse there, rather than a doctor going on once a day around telling them do this, do that, and not following it up. It happens much better when a nurse comes and goes 3 times a day on the ward or 4 times a day on the ward. So I think an acute pain service is an essential thing. The question is, how well can you cover most of your post-operative patients is one. We have managed to cover most of them. We still have lacunae. A lot of our patients who don't have a block or anything, sometimes we miss them. But quite often we pick those patients up as well if they've had a problem or we anticipate a problem. And it's much easier to run this service with nurses rather than running it as a clinician driven. The clinician is involved. They report to me or Gaurang or Rita, one of us they report to, and they will tell if there are problems. We are involved because at the end of the day, the patient also wants a doctor involved. They don't want only nurses. So if there is a problem patient, we will go and make a visit. But day-to-day running, almost 90% of the work is done by the nurses, rather than us being permanently involved in going and seeing them clinically.
Yeah, very, very true, Arun. I think the nursing staff, I think what message you have given to us is that sensitization of the surgeons is important. That's what it looks like. Education of the people around, especially the nurses, is important. And I think the continuing education is the key to improving these services. I think Vasanta, before we go on to Guru, I think Vasanta wanted to actually say something.
Yeah, regarding Dr. Guru's question, how to take care of patients in small private setups. There also, see, as Dr. Arun said, we can involve the nurses who are paid by that hospital. So you identify one nurse there who is passionate and good enough to take care of post-operative patient, identify. That nurse can be trained easily. Then you can do your private practice, do one case there and go off. But if any problem occurs, that nurse will identify and just call you, give you a call. You can just clarify over phone. That's the simple thing needed. Just as I told you, it will take some time, some of our time. But once we are into it, you will also feel happy and everybody will feel happy in patient care.
Absolutely. I think we need to be innovative. We need to think beyond the boundaries that we have set ourselves. lot of the time we have set boundaries, and APS is something considered new or unwanted by many institutions. And once we, break these boundaries, I think that's when you will start to see the benefits.
Yeah.
So the data which Dr. Vasantha presented, saying 60 to 70% of patients are in pain post-operatively, is really, really bothering. It's not something we would want to experience as patients ourselves. So I think there is enough reason for us to stand up now and demand our APS teams in our hospitals. And work a way out.
Yeah, Somnath, I agree with you. I think the first thing to start is then you need to have your data to show how much of your patients are actually suffering, and that will be a good kind of a selling message to the management, and kind of puts a bad picture to the hospital, and then you would kind of get a little bit more leverage from them to implement the practices.
Go ahead, Shiv. Sorry. You're muted, Shiv.
Yeah. I mean, the last point I would actually like to add is that simple outcomes, soft outcomes like, patient satisfaction works a long way. And pain is one area where you can use this very easily. If the patient actually say they're so satisfied with the care they got and the pain was well controlled, and you have this data to put it to the management or as this, and when you also go to the public, you have to actually know that the patients are the one who actually will advertise your hospital or your services. If the patient has had a good experience at your hospital, he's going to tell 20 of his relatives. In India, you have an operation, there are like 30, 40 relatives who come to see you. And I say, oh, where did you get this operation? How many stitches did you get? How was your thing? And you say, this is wonderful. Now that means you actually got 20. The 20 might actually then again, it is like a cascade, it happens. So if you actually provide that kind of services and outcomes and people are talking to you, and one of the other important thing about the acute pain services is, that's I've seen it personally, even in the biggest hospitals, the surgeons come for round, they don't even really talk to the patient. This has happened with my very close relative. I'm in the room. Okay, they're having a round. They have a huge entourage of like 20 people. Okay, they're talking to each other, but nurses and everyone are not talking to the patient. Whereas the pain team goes and they are talking to the patient, because you need that conversation with the patient to actually provide that service. And this patient will become your, they are advertisers for you. So use it to your advantage. Shall we move on to the next session? I think we are nearly there.
Yeah. The floor is open to anybody else who wants to make a comment for a minute or so. And after that, we'll move on to Dr. Guru. Guru, thank you very much. We're delighted to have you join us today. And today, Guru will be talking to us about auditing framework for regional anesthesia and pain service. Dr. Gurunath Murthy is a senior consultant anesthetist and head of the unit anesthesia and perioperative medicine at Modbury Hospital in Adelaide, in Australia. He's director and co-founder of Medusys Private Limited, Australia. His special interests include medical education, quality improvement through technology, regional anesthesia, and ambulatory anesthesia. Over to you, Dr. Guru.
Okay. All right. Can you see the screen and
yes, sir.
Visible?
Yes, sir.
Yeah.
Yes. Sir.
Okay. Thank you very much for providing me with these opportunities. And as you suggested, I'm pretty passionate about data, about quality improvement and use of technology, or any innovative techniques to ability to collect data and improve the quality and services. And it's been almost a decade-long journey so far, trying to achieve this, and hopefully we can do much better in the near future with more collaborative efforts through the Global Anesthetic Society. moving ahead, look, before I begin, I think we need to understand just 3 simple rules. Is that if documentation is the key, and if it's not documented and not signed and dated, it's not valid. And I love this last one, okay? And it's been said multiple times. I've kept saying this for years together, that in God alone we trust and the rest of us must provide data. Because unfortunately, or so, we live in the world where experience-based medicine is much underrated than evidence-based medicine. So we need to look into ways how we can convert our experience into evidence and provide that data. There are some myths I want to talk about before proceeding. So-called I'm an expert, that I've got 100% success rate. It doesn't exist. I don't have any complications from doing block. That doesn't exist. Also about having a peer review of my activities, somebody watching you over and critically analyzing your knowledge and skills and approach. Another overrated thing is technical skills, and some believe that technical skills are more important than non-technical skills, which is totally untrue. And if you look at patient-centric approach, and if you try to quantify that patient-related experience measure, you will realize that the non-technical skills play an equal important role than your technical skill. It's not about how quickly you did the job or how efficiently you did it. It's about the patient. A lot of people believe that if you report complication and failure rates, you will be penalized, because there is huge competition, and gossip will spread around very quickly about complication that you have reported. And unfortunately, people don't realize that actually competition is beneficial, and it is one way that you can improve. But there are ways that it can be anonymized and make yourself a better doctor. Another myth is that people living in resource-poor situation cannot improve quality and safety. Totally untrue. Every doctor can do it, irrespective of their situation. It is about passion. It is about thinking beyond the boundary. Another belief is that freelancers are not academicians to collect data and analyze. That is also untrue. There are ways around it. We got our own, some of our freelancers who have published. Kala Ishwaran has done many publications with the help of the RAD app, and ongoing efforts are there. If you want to know more, understand, you have to listen to Dr. Atul Gawande. His talks on TED are so impressive, and he's so passionate about improving safety and quality. And it will help you understand what you need to do, because improving safety and quality is not just about yourself, it is for everyone. And how you can achieve is that one single important thing that we need to think on an everyday basis and case-by-case basis. This is a very common statement, that we come across. With great power comes great responsibility. The responsibility about accurate documentation and doing audits, clinical audits. But is it practical in the real world is the question. Coming to documentation, often the regional anesthesia documentation is relegated into a corner. This is our form, and you will be surprised, being in the Western world, in a teaching hospital, it's only just a month ago that we have started to migrate to EMRs. We were still paper-based, and more than 60 to 70% of the hospitals are still paper-based. So we still handwrite, and a lot of places do still handwrite. So it's often relegated. There's not enough space to do this. So what do you need to document? You need to document some of the important information about pre-procedural aspect, whether it is regards to the consent. Everything has to be documented, and make sure that the patient has enough education. document about the safety issues and the availability of resuscitation equipment, procedural documentation from every step that is involved, and post-procedure, including the block regression, analgesic supplementations, late complications, and discharge instructions. Now, important thing is about audit. What is audit? At the end of every conference or workshop, there is a Prakriya regional anesthesia and ultrasound guided regional anesthesia workshop coming up in Bengaluru in November 19th and 20th. And I can guarantee that on 21st, all those candidates who are there would be so enthusiastic to go back to their workplace and do those nerve blocks that they have learned. It's good. It's great to see people are quite keen to get back to work, which is rare nowadays. But sometimes I do get worried, with that needle in their hand, they are looking for that elusive nerves, and there is a surgeon looking at their back and trying to pressurize them, and mistakes can happen, or they may not achieve a good quality block. And then they get dejected and the blocks may die out of their practice altogether. Often it may be successful too, but overall, how do we know we are doing well? How can we improve? Clinical audit is a continuous quality improvement process. What you do is you identify what are the existing standards, you collect your own data, analyze it, compare it to the existing standards, see what needs to be done, and re-audit to see if there is improvement. I'll go through some of my old data from my personal experience when I started working in a smaller hospital where there was low volume of regional anesthesia practice. There was no ultrasound, there was barely any patient follow-up or no practice or outcome evaluation. And just people used to come, anesthetize, and walk out. And gradually I came in with a special interest in regional anesthesia, started doing more and more blocks as the year passed by. Then I introduced an audit form which collected the preoperative, intraoperative, and postoperative data. Each part was filled up by different people. This piece of paper we used to go with the patient file and finally collected by the APS nurse, put into an Excel sheet, and then analyzed. We also formed a discharge information leaflet to all the patients so that they should know how to take care of their anesthetized limb, what to do for late complication, whom to contact, etc., etc. None of this existed. So there was no kind of a patient-centric approach at all. We used to keep the patient in hospital until the block regressed completely. And I thought that was waste of resources. Patient should be able to be discharged if you understand how to manage, if you can educate the patient and how to manage rebound pain. So just some of the data, I'll quickly go through this, and recorded about 625 cases, which was my own personal compared to the department, which was 811. And there were few cases which were lost due to audit sheet being lost everywhere. And I then compared my data with the department over a period of time, and predominantly over the next 2-3 years, all the data that came through were from me. So there was increased number of blocks that have been done, 100% increase. And you can also see that there were more cases where there were, the gynecology and other stuff were increased compared to orthopedic. It came down because there was a change in practice, there was change in surgeons and changeover in the hospital management. What did I compare? So I didn't have any data to compare there. I didn't know whether the standards existed. So I looked up, and there was Australian and New Zealand regional anesthesia registry established by Dr. Michael Barrington and colleagues. And I look up their data. And in between, I used their data to compare my own for basic demographic and patient characteristics, including ASA classification, who did the block, and what was the types of surgery, what were the comorbid conditions that would influence the outcome after a nerve block was also looked into. What were the different types of nerve blocks that I did? Now, this is a comparison between the years. As you can see, trunk and neck block increased significantly over 2014 and 16 since we acquired the ultrasound. And, I did use some of my data over the first 2 years as a leverage to prove that an ultrasound machine is a good kind of investment, that the return of investment is there, where we can reduce the hospital length of stay, we can reduce the requirement for HDU admission, and thereby we could acquire an ultrasound, and then the trunk and neck blocks increased. These were some of the blocks that I did, again, 2-year period differences, and there were different types of blocks that were done, and just to show how my practice changed over a period of years. And then I compared my blocks with the national registry, and you can see some of my blocks were slightly more in number compared to the national registry. I did more supraclavicular than many others, or infraclavicular than many other anesthetists across Australia and New Zealand. What was the patient status during the block? As you can see, 70% of the blocks at that point of time were under GA. Nowadays, almost 90 to 99% of my blocks are under GA. If they're receiving GA, or if it is spinal, it is under spinal anesthetic. And as you can see, even if the blocks were done prior to GA as a part of improving efficiency in a block room and things like that, they did receive sedation, and only 2% of the patient had block alone. That is just my practice. That doesn't have to reflect upon to anyone else, and it could be different with different people. What was the technique that was used? As you can see, ultrasound only technique jumped to 82% from 58% over a 2-year period. And then I compared with the Aurora data, looking at the ultrasound quality, also the image quality, and also interestingly about the nerve stimulator. I looked up in the department, there was a couple of anesthetists who used significantly high threshold currents to do their block. And that was another interesting finding, because we don't critically apprise or go and see, and there was no peer review of practices at that point of time. And each consultant were individual on their own. Then we looked at post-operative outcome measures, and looking at post-operative pain, how many patients had mild, moderate, or severe pain. As you can see, mild patients were quite significant, but the moderate patient who came with moderate pain increased at 30-minute period, but that were a combination of those who were severe who became to moderate, or those who were mild when they came in became moderate. But the good news is that no patient were discharged out of PACU with severe pain. That was the criteria we had set, and we achieved it. Next important thing is analgesic consumption, and I compared with the Aurora data. As you can see, 67% of my patients did not receive any analgesics in the recovery. And my overall opioid consumption in recovery was comparable to across Australia and New Zealand. Among the different types of blocks within the departmental comparison, as you can see, there is quite significant differences in the types of block that are done. I was the only one doing the lumbar plexus and sacral plexus block. As you can see, that is 100%. But also, I compared the blocks with Aurora results. And interesting to see the success rates across Australia and New Zealand, ranging from 89 to 94, 95, and there is 197%, and one place which reached up to 99%. But what's also interesting is, why do we have low success rates? It's hard to measure, especially if blocks are part of just a opioid reduction technique, and it's hard to measure the success. Some of the facial plane blocks are hard to measure in terms of success rate. Overall success rates have been 89%. And, some of the large volume centers, and they were doing femoral nerve blocks for knee arthroplasty. And unfortunately, that doesn't necessarily mean good outcome in terms of analgesia, because there are other components in pain relief. Remember, this is a 10-year-old data now, so this is not much comparable to current practice. What we also did as a part of APS service is compare with those who had PCA or epidural, and epidural practice has almost come down to zero in our hospital, except in some special subgroups. But in those days, as you can see, regional anesthesia was associated with reduction in both static and dynamic pain score. There were significant reductions in nausea, vomiting, and sedation scores, and overall opioid consumption was quite significantly reduced. Success or outcome is not just about, outcome is not just about success, but also looking at complication rates. And I looked at both technical complications and respiratory complication. And I myself had a lot to learn from these complications. There was an epidural spread from lumbar plexus block in 2 patients. There was respiratory distress in 2 patients, and paresthesia, which happened at the time of blocks. And then I compared my data with 4,000 procedures that were done part of the Aurora data. I also looked at late complications, so it was important. We followed up patient quite significantly, and all patients were instructed to report to us. And luckily, we had good outcomes in this. We still had few patients who had sensory deficit for up to a week, motor weakness up to a week in 2 cases. And there were 3 cases that were referred to neurologists post-operatively. One was a fracture patella who had a femoral nerve block, which was ultrasound guided, but had a prolonged sensory dysesthesia and also loss of sensation on the thigh. And neurologists couldn't find anything, and possibly he suspected there could be a lumbar plexopathy from the road traffic accident that the patient had. There was 1 case of permanent sensory loss, which we followed up to a year after a sciatic nerve block, where in fact we had used the dual guidance, and threshold current was 0.5 milliamps. And this patient, after follow-up, he was not very much concerned because it was only a sensory part on the lateral part of the leg, and he didn't mind that, and he lived with that, and no untoward outcome. Another interesting case where neurologist referral was the patient who was a known case of CRPS, had an ankle surgery, and was known to a chronic pain team. And this patient developed prolonged dense motor block and sensory dysesthesia after surgery. And immediately I was called upon because I was the one who did the block, and blame goes on to the block. And then we reviewed and realized, and along with the neurologist, it was diagnosed as the CRPS as a component which had actually flared up, and patient was started on lignocaine and ketamine infusions, which gave quite good relief and motor recovery. So that's interesting. And if you look at some of the other data from international, Dr. Shiv has already talked about in his talk about neurological complications, and also looked at other acute severe complications from across many studies and registries. And you can see in about 7,000 nerve blocks from across Australia and New Zealand, there were quite a few significant cases of vascular punctures, local anesthetic toxicity, and neurological referrals. Patient satisfaction score, again, this was touched upon in the couple of talks earlier. And again, we did follow up our patient to ask them about their satisfaction about having a nerve block, or would they have it again? Were they happy with the service we provided? And as you can see, 70% were highly satisfied, but it was also bit dissatisfaction that among us, that about 14% of the patients were not satisfied. And we did learn quite a number of things that, why were the patient dissatisfied? They didn't like about the rebound pain, especially the pain wearing off in the middle of the night and disturbing their sleep. Some patients did not like the feeling of numb, dead arm or leg. Respiratory difficulties, or that subjective sense of shortness of breath after interscalene blocks, dense interscalene blocks. We also identified some of the reasons of block failure, where a high threshold of currents were used and accepted for the nerve block. So we realized that there were lack of skills and knowledge, and poor patient selection. So we did educate our own colleagues. It's not an easy task to educate your senior colleagues, but it was important for us in terms of patient safety and quality. What we also realized that the patient paper-based data collection is obsolete. We lost a lot of data, the data quality was not accurate, and it was not timely. So there were some safety issues which we also identified about sterility, about LA dosage, and some questionable practices. And we also realized that our success rate need to improve beyond 90%, and we need to have much more opioid-free recovery, and lot less number of patients should be discharged with moderate pain. And there were also some unacceptable rates of complication, including the respiratory distress and all those things. So we realized that we need to get better, and we did improve our practice. So whenever you start an audit in your practice or in your hospital, there will always be questions that, why do you want to do this audit? And when you show how you can improve, how it is an important data for clinical health indicators, how if you implement a new technique, how it is doing, is it going to give patient benefit? And you can seek new questions. And then suddenly people will start asking, how can we do this? There are significant barriers, and that's where majority of us lie, where we find it difficult to start an audit practice. And even when you start, there is a lot of difficulties that you experience, be it a busy practice, or you don't know how to set it up, you don't have APS nurse or an APS setup, or there might be organizational impediments. The organization doesn't want you to collect data because a bad outcome or poorer outcome is reflected poorly. But if it is kept internally or anonymous, there are ways around this. And one of the biggest drawbacks in many countries, including India, is we don't have a national benchmark for comparison. There are no standards that have been set up. So how do we overcome those barriers? I know a lot of you work in these resource poor, heavily burdened situations, and I've worked in some of these places, let alone collecting data and analyzing data and improving quality. We are more focused on how we can get this patient delivered through a safe care or to some reasonable care. And this is, ladies and gentlemen, real world. This is the real world. And how can we implement any quality improvement activity, let alone audit, to be put into practice? So after brainstorming, we went a level up, and in July 2016, we came up with an idea that paper-based things are obsolete. Trying to use computers is again a bit difficult, although it has got better data integrity, but access to the computers and internet at bedsides and it's not universal. But what we realized that the smartphone evolution is kind of exponential growth. And the Digital India program has kind of growing exponentially. And whenever I come to India and go to rural places, I still get 3G, 4G connections where there is sometimes not even electricity. That took me by a surprise, that I said, okay, look, we need to integrate this ability. We need to leverage this digital revolution into healthcare to improve safety and quality. So that's when we decided that we need to bring future to the present so we can be smarter and stronger. And that is where we started our first effort, as called as RAD app, Regional Anesthesia Database app, where we developed an app which was user-friendly, which was available across all platforms. We made sure that the data quality is accurate because it can be entered at the point of care. We made sure that the health privacy policy across all countries are maintained, including the HIPAA compliance, GDPR compliance, and all those things. And we made sure that the data analytics are inbuilt so that there is no effort from this. It could be accessed through all devices and kept in an encrypted server, and all data was anonymized. Only summarized results were provided. And the data was available in terms of graphs and charts, which made easy for users to just analyze. So going through the cascade, we realized that, this was an important tool. So there was initial enthusiasm, there was a lot of take up on this. And overall, at that point of time, at the peak, we had more than 6,000 patient records, and we started to develop more apps. At that point of time, we realized that we can take it to the next step. It was spread across, and thanks to the Anaesthetist Facebook group, we could popularize this across many countries, and people started downloading the app and using the app. There were a lot of presentations, again, across the world. This data was presented. My own personal data has been presented both in the Europe and in Australia. And these are the data from my personal private practice. So there was an empowerment for private anesthesiologists, freelancer anesthesiologists who could collect their data and analyze and improve safety and quality. Many posters and abstracts were presented, and we also envisaged that we can develop a national registry for regional anesthesia and develop a national audit project. So gone are the days where you used to learn, then we used to practice, and then provide evidence. But in the current era, these can all go hand in hand so that any quality improvement is instant. As you learn and practice, evidence is generated, and that evidence will provide you with an instant feedback that how you can improve the quality. Then came the next level in this game. With the enthusiasm, growing enthusiasm for thoracic spinal or segmental spinal that was popularized by our Italian colleagues and Dr. Naresh Paliwal, take up on this controversial technique. Again, we laid barriers in our practice that what has been described in textbooks are the only things that we can do, and we cannot cross this barrier. Somebody has to, and if there is no evidence, we can't practice that. So I'm thankful to those colleagues who are able to break those barriers and practice what has not been taught before. Now, if you don't cross that barrier, you can't generate any evidence. If there is no evidence, you can't practice, but if you don't practice, you can't generate evidence. So there was something going on. So people were practicing it. They were proclaiming it to be safe and very effective. There are multiple videos and multiple presentations by many people who have taken up this segmental spinal. But unfortunately, nobody's generating data. So that is when sitting with Dr. Shiv Kumar Singh and Prashant Magdi, who's my co-founder at Medusis, we realized that we can take it to the next level, and the level that we never thought we could achieve. What we envisaged is not just about data collection, that we digitize the whole patient journey, that right from preoperative stage to intraoperative stage and to postoperative stage. Again, I keep saying that because there is a digital revolution going on, we can utilize this technique of cloud-based or app-based and digital revolution into healthcare and improve safety and quality. And safety and quality is not just about data, is not just about patient, but it is also about improving our own knowledge and skills. So we brought in educational modules. So what about the preoperative stage? So we have 3 modules. The patient management system is a tool in development. Part of it is already put into my practice for more than a year in Australia, where we digitize the preoperative health questionnaire so that we can efficiently screen the patient. We do get flags about the patient's health condition where we can optimize the patient early. So there is less cancellations. We have patients in a better state that for the surgery, so their outcomes are improved. Then we can also learn about patient-related experience measure or patient-centered outcome measure so that we can continually improve our quality. Then we have the clinical database section. And across that, we've already developed for the central neuraxial block, the labor analgesia, obstetric anesthesia. We are in development for the peripheral nerve blocks. The logbooks are coming and clinical audits are on the way. It is not just about big data, because real world and real-time data collection improves with data integrity and data quality when it is collected at the patient bedsides. With this technique, we can reduce the workload on both clinical and frontline staff on data collection. It reduces the data collection fatigue. All those barriers that I explained earlier can be overcome with this technique. And it does help us improve in safety and quality. It is representative of the population that you represent. It is cost effective. And you can analyze across any range. With putting up filters in the analytics section, you can analyze across many sections and how you can improve practice. And rare occurrences can be looked into. Then comes another important section. As I said, safety and quality is not just about performance, but it is also not just about collecting the data and analyzing, it is about continually improving. And we developed this MELS CME section where this part of this e-conference is through this section, and you can obtain certificate from the Royal College of Anesthesiologists, Anaesthetist for 10 CPD points. We'll also have many other sections. We've already have got the regional anesthesia ebook developed by Dr. Shiv Kumar Singh, available in all the chapters, where he explains in detail, in most simplified form, that blocks can be done by every individual in any location, even in resource poor situations. So, and also we will be continually providing different aspects of learning where you can continually improve your practice. It is available across all devices. You can access through your mobile or your desktop or laptop. This is the overall screen view, and analytics will be providing shortly, be coming up online in a couple of weeks' time. Will be all in graphs and charts that there is zero effort from your side. This is the e-library sections. There are many already uploaded, including ebooks, guidelines, and infographics, etc. What does it come to your responsibility? From your perspective as a user or as a doctor, you need ethics committee or IRB approval based on your local situations. A lot of places do not require approval for quality process, but if it is captured digitally and if there is any patient identifiable data, you need to obtain consent. We have provided a section for e-consent where you can obtain patient consent for data collection, and it is documented and it is securely stored. You need to agree to the data privacy and user agreement. And as a part of Global Anesthetic Society, spearheaded by Dr. Shiv Kumar Singh, we will be starting a registry database for CNBs, for PNBs, and many other registries, and you will be part of the governance and external audit. So make sure you document in the notes as accurately as possible and collect the data. Then comes a very common question. A lot of people ask, why do I need to give my data to the registry? Why do I need to share the data? Just remember that your data is shared for the nation's best interest. We do not have, as a nation, do not have a standard of practice. We do not know what we are doing, how well we are doing. And all this data is anonymized. So your data, be it a complication or a success, be it anything, is not recognizable by anyone. You cannot identify any person by this technique. So it is useful to have a complete data, and we would be able to establish institutional databases. You can establish national databases, and your data cannot be viewed by anyone else except yourself. Yes, this is the risk. You have a fear, and all these things are addressed in our FAQ section. How the data is stored. What is the risk of loss of privacy policy? What are the potential errors that can happen? Who owns the data? At the end of the day, the data is owned by you. The collective data, which is used as a national registry or a big database, will be useful for us to identify those rare occurrences in regional anesthesia. So far in India, there is no such evidence produced at all, no effort. We are all very keen to talk about novel blocks, but we don't even have a data for basic blocks. So all about data security is available in our website.
Dr. Guru, Guru, you have 1 more minute.
Yeah, I'm up to my last slide. Thank you.
Thank you.
So as individual doctor, I think it is every patient has a right for safe, high quality care and a pain-free post-operative phase. And you need to be passionate. We talked about this, about APS service just a few minutes ago, and you need to be passionate about providing these services. At the same time, you need to be passionate about collecting the data and analyzing the data and continually improving. Dr. Atul Gawande keeps talking about, do we need a coach for an expert? Yes, he gives an example about how elite athletes still have a coach. Tendulkar has a coach, because even if you are an expert, you still need a coach. You need to be innovative. You need to think beyond boundaries. And finally, I need to say that we need to be collaborative, that you don't work against your colleagues, you work with your colleagues, and we can improve safety and quality. Finally, with Medusis and gas collaboration, we would like to encourage everyone to continually think how we can improve safety and quality and efficiency. We need to empower each one of you to use any innovative techniques, any technology that is available to continually collect data, analyze, and improve safety and quality. Thank you very much.
Thank you very much, Dr. Guru. We'll move straight on to the next topic by Dr. Arun. Anil, can I have the slide, please? Yeah. So Dr. Arun will be talking to us regarding, does regional anesthesia prevent chronic pain? And I think repeatedly over the last few sessions, we have seen that if a patient has post-operative pain, he can go into a chronic pain situation. So to introduce Dr. Arun is a senior consultant and lead for anesthesia and critical care and pain management at Aster CMI Hospital in Bangalore. His areas of interest include liver transplant anesthesia, chronic pain, and regional anesthesia. So he'll be talking to us now on does regional anesthesia prevent chronic pain? Over to you, Arun.
Thanks. So I'm just going to try and see if I can share. Yep. Yes, no?
Yes.
Yeah.
Yes, Arun. Yes, Arun, we can see your screen.
Yeah. Okay. Now, thanks, Som, and thank you, Shiv, and greetings from Bangalore. Well, city of traffic. Luckily, this is an online thing, so I'm happy about that. Does regional anesthesia prevent chronic pain? Simple answer, no. That's because I think I'm going to change the topic there. Does regional anesthesia prevent chronic post-surgical pain? Probably yes. Probably we'll see what can be done to help it and how we can prevent chronic post-surgical pain. It's a vast topic. I'm just going to take a few things in that. Till 2022, that's this year, chronic pain did not have an ICD code. So chronic pain did not exist in the international registry of diseases. So this is a WHO registry. Now, at least we've got a code which says that there is something called as chronic pain, and chronic post-surgical pain has also got a code. And the definition as per that is pain developing or increasing in intensity after a surgical procedure in the area of surgery, persisting beyond the healing process. That's usually about 3 months is what the healing process is considered. And there are no other reasons for it, like infection, malignancy, or any other pre-existing conditions. Now, this pain can either be at where the surgery has happened, the surgical location, or it could be an innervation of a nerve which is passing through the same territory, or the dermatome, which is referred from a deeper visceral structure. So all these come under the ambit of chronic post-surgical pain. And luckily, this year onwards, we've got a code for it so that at least the first starts there, that you can actually classify what you're looking at. And you can say that this is chronic post-surgical pain and this is not anything else. It is a very wide definition, but at least there is a definition now. So now, there you go. It's reported with almost all surgical procedures. Now, you take any kind of surgical procedure, you will have chronic post-surgical pain. Depends a lot on how it is defined and how what kind of pain people are looking at. The incidence varies. It varies all the way from 10% up to 50% or even 80-90%, depending on what you want to do. Now, this is because till now, the way chronic pain has been looked at if you're looking at a VAS score of 1/10 for somebody 3 months down the line, he might complain. So you will categorize it as post-surgical pain. Whereas other people are a bit more stringent and they use a VAS score of about 5/10, and they'll say probably there is nothing there. So there, they will move this patient away from the chronic post-surgical pain. So you've got a very wide range. And that's primarily one of the reasons why you have a wide variation in incident reporting as well, all the way from 10% to about 80-90%. Now, usual quotes are about 10 to 50%, depending on what VAS score has been used. The other thing you have to remember is they also decide on how long the pain's been going on for. Some studies look at it for about 8 to 10 months or a year, and they find that that pain's no longer existing there. So again, your incidence comes down. Whereas others look at it exactly at 3 months and say, well, there is pain, there is a VAS score of 1, there is pain. So this is chronic post-surgical pain. So a lot of ambiguity is there on how it's classified and what is considered as chronic post-surgical pain. And that's the reason why you have these kind of instances. But generally, it's accepted that amputation is probably something which has got a long history of chronic post-surgical pain, as does CABG, standard CABG. I'm not talking about many thoracotomies. It's talking about standard sternotomy and CABGs. Mastectomy is another thing which has been associated with a lot of post-surgical pain, as is standard thoracotomies, and to a certain extent, hernia repairs and LSCs. Hernia is, again, you're talking about open hernia repairs, which would probably have about 10% incidence of chronic post-surgical pain. Does not say that lap hernias do not have post-surgical pain. They have a different kind of post-surgical pain. On one side, you would be cutting a nerve to say that it's post-surgical pain. The other side, the patient will be complaining of Tacker pains. So you have a variation in the kind of post-surgical pain. Exact numbers are difficult to come by on what will be there. But yes, these are roughly the instances which you have for post-surgical pain. Now, there are a huge number of risk factors. You have preoperative. It is found more often in females, younger patients, patients who've had some kind of preoperative pain, especially say if you're doing an open hernia, patients who've had bad hernia pain previously sometimes do complain of post-surgical pain for longer afterwards. Then there is a significant amount of genetic predisposition. There are psychosocial factors, as with any other chronic pain. Patients who catastrophize, who have depression, they again fall into this category. They have a higher instance of post-surgical pain. Then there are your intraoperative factors. You've got the kind of surgical team. A lot depends on how well the surgical team handles the tissues. You have teams which retract a lot, which do a lot of, if they do a mini thoracotomy also, they put a retractor and retract it all the way. So you have these kind of things which the surgical team does, their techniques, whether it is minimally invasive surgery, whether it's an open surgery. And then you have our contribution, the anesthetist contribution, whether we're looking at the analgesia very acutely and we're making sure we are covering every possible avenue where the patient gets pain from. So these again matter for chronic post-surgical pain. Then you have post-operatively, when the patient wakes up, how much pain do they wake up in and how long does that pain continue? Then there are a lot of psychosocial factors associated with it. Things like, was the patient expecting that amount of pain? Like we've discussed in the past, TKR patient, they should not come out of the anesthesia expecting that there will be zero pain. If they expect that there will be about 10%, 15% of pain, what they had prior to surgery, or there is some amount of pain, their attitude towards the whole scenario changes. Chances of them getting post-surgical pain is much less. The ones who go in expecting zero pain and come out with an even minimal amount of pain have different problems. So there are a lot of psychosocial factors which matter with chronic pain. And there are associated treatment factors. Most of our patients are patients who've had malignancies, they've had oncosurgeries. So patients who end up getting radiotherapy and chemotherapy, they can have chronic post-surgical pain, not per se because of the way things were done intraoperatively, but because the next few months, they're going to be undergoing radiotherapy in the same surgical area. So they might land up with chronic post-surgical pain compared to the ones who never had radiotherapy there. So these are factors that you have to take into consideration when you look at any patient having chronic post-surgical pain. And we're talking about one bit of it. The rest of it is there, which will make a difference on whether it's going to work or not. This I've borrowed from Anesthesia, Chen et al. I think last year's. They talk about everything here. They talk about the pre-operative, they talk about the intra-op, post-op, and the recovery phase. This is a biopsychosocial model which they've tried dealing with, talking about, and looking at events which happen, risk factors which are associated with it, and if you're able to do anything about it. So in a nutshell, it actually talks about the patient, the risk factors pre-operatively, intraoperatively, post-op, any anxiety, sleep disturbances, catastrophizing. These kind of patients will tend to have longer incidences or higher incidences of chronic post-surgical pain. Now, coming to the primary problem, these are all surgical patients. They all have had some kind of surgery. Now, yes, the surgery does matters to a great extent, whether it's a minimally invasive surgery or it's an open surgery or it's a robotic surgery. It does matter on what kind of surgery has been done and what duration, what has been the insult to the tissues there. Now, that is what initiates any kind of chronic post-surgical pain. These are not patients who've had this pain prior to it. The surgical insult starts it. And the surgical insult can have a varied kind of, it can either be nociceptive, inflammatory, or neuropathic. I'll come to these. People who do not do chronic pain, these are terminologies that are difficult to understand. Nociceptive is basically activation of a high threshold at the peripheral nerve, which is normal pain you would feel with any surgical incision. It's an adaptive pain, it's a reversible one, and it's usually a peripheral pain. Inflammatory process, any process which is associated with the surgery, you have local tissue infiltration, the release of inflammatory products, the heat, the redness, the swelling, which again is an adaptive kind of a response because it wants to heal that area, and it's generally reversible. This can be central as well. There can be a central immune response as well, which can produce some amount of central sensitization. The neuropathic component is the direct injury to the nerve, either a direct incision, cutting, or a cautery or a devascularization secondary to the nerve being in the surgical field. This produces a maladaptive response, and it is variably reversible. That is, in some patients, you would be able to, it will reverse on its own, whereas in a lot of other patients, it will continue to be there even after the healing process has happened. So quite often, neuropathic component is a component which starts off in these patients where chronic post-surgical pain is there. So they have these kind of maladaptive behaviors. And this starts as a peripheral maladaptation, but progresses rapidly to a central sensitization and a maladaptation centrally. So neuropathic component is a component which actually comes up significantly in these chronic post-surgical pains. Now, what does matter in the immediate post-op period for these patients is the intensity of the pain. Now, pain is, you have to remember, acute pain we deal with day in and day out is a protective mechanism. Acute pain makes sure that the patient does not move the limb. They do not, they give tissue enough time for healing, and it's meant to be protective in nature. Now, changes in peripheral and central somatosensory circuits and sensitization can change this protective behavior to a maladaptive or to a chronic pain state. Now, it does not necessarily mean that there is neuronal damage or there is no neuronal damage. Now, you'd be surprised to know that neuronal damage happens as part of a surgical insult. You have the NMDA receptors which maladapt. You have a lot of calcium going in. You have a lot of neuronal cell death which can happen. Now, if cell death happens and plasticity happens, these patients actually do not get chronic pain. Whereas the patient in whom it has not happened, there is a constant firing going on there. and cell death has not happened, these patients tend to develop chronic post-surgical pain. So this gives something which the surgeons hang on to, that nerve damage does not necessarily cause chronic pain. So it's an adaptation which happens peripherally and centrally in some of these patients where complete cell death does not happen and they maladapt, and that's when chronic surgical pain starts. So a direct cut to the nerve sometimes is not harmful. It actually is a beneficial thing and works well. And that we see quite frequently when breast surgeries are being done. They usually would look at the T2 medial cutaneous nerve of the arm. It quite often gets involved, it gets cut away. And the patient still does not complain of any pain there. But in some patients, for unknown reasons, just the retraction or partial damage to the nerve can produce a chronic post-surgical pain. So this is something which you have to keep in mind. You cannot keep saying if there is numbness, it may just be numbness. There may not be any pain associated with it. Whereas they may have hyperesthesia and allodynia, but they'll have pain associated with it. So what can be done to help these patients, or can we prevent it? There are things which are non-modifiable, very simple things. Demographics of the patient, female patient, young patient, genetics of the patients matter, and their pain sensitivity matters. These are non-modifiable things. There are some modifiable factors, especially the way the surgical site, surgical incision is put, or the intensity of the pain during this thing, whether we've given analgesics prior to it or nothing has been given prior to it and you're giving everything post. So you can look at these kind of modifiable factors which can help you with chronic post-surgical pain. Now, multimodal analgesia is part and parcel of daily work now. Now, there cannot be a patient who has only a regional block unless, okay, things are done under a spinal anesthesia or an epidural anesthesia, or you're doing it for somebody who's high risk for a lower limb or some peripheral surgery. But most of the surgeries, multimodal analgesia is part and parcel. Even for the ones under spinal or epidural, you would probably add on paracetamol because they've been on a bed or on a table for a long time. So it's part and parcel of the whole game. Regional anesthesia or analgesia is a smaller part of this whole multimodal analgesia. And that is where we will have problems. I'll talk to you about in a little while. Why? Because we are now in an era where multimodal analgesia is an accepted standard, or it has to be a standard. We have problems on getting data for regional anesthesia. Now, multimodal is, as expected, includes everything: your alpha-2 agonists, your NMDA antagonists, gabapentinoids, Dexona, things like non-steroidals, paracetamol, duloxetine, or regional anesthesia. So you've got a drug available in each of these categories, which can be used for these patients. And quite often it is used, where it may not be all the drugs, but you would probably use at least a couple of them from each category. Now, if you look at regional anesthesia per se, the target for regional anesthesia to prevent chronic post-surgical pain, it works almost everywhere. Regional anesthesia works at the peripheral nerve level. You have it working at the inflammatory response level, whether it's a peripheral inflammation or a neurogenic inflammation. Regional anesthesia works at both levels. It also works at the DRG, that's the dorsal root ganglion, where it actually changes gene expression. So this is something which we use in chronic pain a lot, but even this change from acute to chronic pain gene expression is essential, and regional anesthesia tends to block that as well. It blocks all kinds of ectopic sensitization peripherally. It also blocks and descending facilitation from the central system or the central sensitization, along with cortical pain processing. So if you look at what regional anesthesia does, it has a role to play in every part of the system where your pain pathways progress to. So you're looking at one kind of intervention which would help with almost everything possible, except for maybe a couple of smaller things like distal nerve injuries, which only in the nerve protective surgeries will happen, or the limbic systems, where things like behavioral interventions will help you more. So you have regional anesthesia as in your armory, which will work with almost everything possible. It reduces your central sensitization, it reduces sympathetic outflows, reduces the stress, and reduces inflammation, both peripheral and central neurogenic inflammation. Now, the question is whether there is any evidence for this working. The maximum amount of work which has come out, at least till now, has been in two areas. One has been breast, and the other has been thoracotomies. Now, in breast surgeries, it has been shown that paravertebral blocks, local infiltrations do tend to help. Now, in terms of regional anesthesia, these are two factors which we do routinely, either a paravertebral or a local infiltration. And yes, lignocaine infusions have been shown to have some benefit. Surprisingly, things like PEG blocks, serratus anterior blocks, and intercostal blocks have not been shown to have that kind of a benefit as much as a paravertebral has been shown to have. So you also have to remember that these are newer blocks. So data might still be coming. This is something, again, I'll allude to later. So data might still come for these blocks, but we'll have to wait and see. But there is enough data to say that paravertebrals actually reduce chronic post-surgical pain development in breast patients. The other thing, as I said, was thoracotomies. And thoracotomies, as gold standard, epidurals work and paravertebrals work. Both of these reduce the amount of chronic post-surgical pain in these patients. Other things like intercostals or infiltrations have got very little role to play. Now, if you look at it, this is a complete list of data which is available till maybe about last year. Maximum is for breast surgeries and thoracotomies. The third column, which says that favorably for regional anesthesia and LA, that there's significant differences. So you have a lot of studies which say it does help. You have a few which says that it's a plus minus, may or may not help. But most of them would say that there is some amount of benefit from doing a regional procedure for these patients. And these have been mainly things like paravertebral blocks for breast surgeries, intravenous lignocaine infusions, continuous wound infiltrations for breast surgeries. Thoracotomies, the gold standard still continues to be epidurals or paravertebral blocks. There are other surgeries like cesareans, iliac grafts, and amputations. Now, amputations has been debated for a very long time, but unfortunately, that kind of data does not exist for amputations. But all these have about 10, other than amputations, have about 10% instances, 10-12% instance of chronic post-surgical pain. The data is not there to say that things actually do help. But there are some smaller studies which say, yes, there is some kind of a benefit with most of these in terms of whether you do a tab block or you do a continuous wound infiltration. Again, only thing which has been done for amputation has been epidurals. Epidurals seem to work well for amputations, and they've been shown to reduce chronic pain and chronic phantom pain as well with amputations. Data for others like hernia repairs is very limited. And well, because now most of it is now becoming lap hernias, the data seems to be getting lesser and lesser. Are there any other lateral benefits of having doing these kind of procedures? Regional, yes, to some extent. You do reduce opioid intake, especially in high-risk patients. Now, we were discussing some time back that patients who are already on opioids or have chronic pain. Now, these are the patients whom you would like to do a regional block and try and reduce their opioid requirements. They may not be zero, but significant reduction in opioid requirements, at least in the perioperative phase, will happen. And then you have these catastrophizing patients who are worried a lot about pain, and the only reason they are worried preoperative is how much pain are they going to have post-operatively. So these are patients in whom regional anesthesia definitely will make a difference. It may not be validated by data, but individual patients, yes, definitely there will be improvement in their outcomes. Then you have reduction in hyperalgesia states post-operatively. This is more so for patients who've been on remifentanil infusions intraoperatively, and then you add on something like morphine post-op. Regional anesthesia has made a difference and does reduce their opioid requirements significantly. So hyperalgesia states, especially if you put an epidural in, is not very common. Whereas if you are putting somebody on a remifentanil infusion intraoperatively and end-op and post-op, you give them opioids, they do tend to have a significant amount of hyperalgesia, and a lot of these turn out to go on to become chronic post-surgical pain. The other surgeries, yes, oncological surgeries. Now, there are a lot of data which came out saying that tumor recurrence was less with regional, but this has not been substantiated in all the studies thereafter. And there is a question mark. There may be some issue about direct apoptosis of tumor cells by lignocaine. There may be some reduction in the stress because the pain is not there. You do not give opioids. Opioid-induced worsening is not there. And the other fact is that immune response is kept intact if you give a regional. These might be reasons why tumor recurrences may not happen, but this has actually not been substantiated after the first couple of studies. Where are we going beyond this? Regional anesthesia is definitely a useful tool which targets multiple neural interventions, so it is worth doing it to avoid central sensitization and chronic post-surgical pain. It is worth targeting the high-risk patients, especially even if regional is not the choice in those patients. Quite often we say that regional is not needed for some of the surgeries, some of the patients, especially some of the lap surgeries. But if you're looking at a high-risk patient, you're looking at a patient who has got catastrophization, who has got very high sensitivity to pain. These are patients in whom it might be worth doing a regional procedure just to avoid significant amount of opioids afterwards, just to avoid them developing chronic post-surgical pain. Now, what may have to be looked at is whether regional anesthesia preemptively before the surgical incision is any better in reducing chronic post-surgical pain. Now, unfortunately, preemptive analgesia has always been a plus minus. Data came out saying that it was good, then data came out saying that it was not worth it. So that has always been a question mark, whether preemptive analgesia is going to help these patients. The other thing you have to remember is most of our patients now, as I said, as standard will get multimodal analgesia. Now, because they get multimodal analgesia, it's going to become very difficult to say that only regional anesthesia reduced chronic post-surgical pain. All these patients will get some or the other form of another analgesic. So going forwards, data towards substantiating that chronic post-surgical pain is reduced by regional anesthesia is going to be very difficult to come by. And that is going to be one of the biggest challenges going forward, to say that there is something which actually benefits the patient. So individual patients, you might be able to see benefit, but data-wise, you may or may not be able to see that kind of a difference, because they would definitely get something or the other as analgesic, and you'll not be able to tease out what has helped and what has not helped. I think I'll end with that, hopefully not beyond time. Thank you. Thanks, Somnath.
Thank you very much, Arun. In taking time into consideration, we'll move straight on to Dr. Preet. Can I have the slide on, Anil? We'll take questions after Preet's presentation, if you don't mind. So Dr. Preet will be talking to us today. So Dr. Preet will be talking to us about should ultrasound assessment be part of all neuraxial blocks? So Dr. Preet Anand Singh is a senior consultant and director of regional anesthesia and pain services at Changi General Hospital in Singapore. He's an assistant professor at the Duke's NUS Medical School in Singapore and honorary secretary of Pain Association of Singapore. His special interests include ultrasound guided pain, and regional anesthesia blocks, crisis resource management simulation, and pre-hospital trauma and air evacuation courses. With that, I'll hand over to Preet. Thank you for joining us, Preet.
Hi, thank you very much, Som, for the introduction. Can you hear me?
Yes, and we can see your slide too.
Do you see this one? The first slide?
Yes.
Okay, can I ask people if they've got Slido on board? If not, there's this QR code they can scan and just help me with the poll if that's okay. If you've got a phone. I hope you've had a good day so far. And I'm not stopping a lot of things. I just want to see how the survey goes. We did a survey here in Singapore and back in the UK, and we found almost 70% of our colleagues don't do any scanning. Are you able to answer? Right, we've got 2 people on board. We'll wait another 20 seconds or so. But we started doing sessions for our residents up across in the UK and then up here as well. We found that almost 70–80% of people started doing pre-positional scanning. Another 10 seconds. We've had 4 people. I'm sure this is on at YouTube as well, so people can use it there. Stop here. Right. Okay. Now, one more question, if you don't mind answering this one for me. So I see that we're sitting at almost 100% both times. Well, starting to decrease a bit. Okay, that's good to see that almost 2/3, if not more, are using or have had training and are using an actual scanning, right? Okay, I shall go on to my presentation then. Thank you very much. So I'd be talking about should US ultrasound assessment be part of all the blocks and how I do it. Thank you very much. No conflicts of interest and disclosure that I'm not an expert, more of a lifelong learner. I've been doing it for a while now and starting to learn a bit more, starting to have a lot more scanning done in my day-to-day things. Okay, so what's the purpose? My purpose is basically twofold. One is to give you a bit of evidence why we should be using scanning and then talk a bit about scanning, what visuals you see and how I do it per se. Now, as a pure breed anesthetist, we've all been taught do it landmark based. It's easy. Why should I complicate matters? I'm not here to complicate matters, but when you've got patients like this, or maybe a bigger person, a frail granny who's 35–40 kilos with who can't sit up, all bones, all calcified, or perhaps people who've had some sort of instrumentation in the back, I think ultrasound does come to your rescue. The reason we say that it should be used usually. Okay. So is there any evidence? When we talk about evidence, we think about, so what are you wanting to ask me? Is it able to tell me what levels should I go in? Isn't palpation good enough? I think palpation is good enough, but studies over the past 30 years have shown that palpation is only positive for approximately 30–60% of people, and about 40–50% people falter in what levels they are. Sometimes they might be quite high as compared to low, and that can give rise to issues, can give rise to injuries to conus medullaris, can give rise to repeated punctures and spinal hematoma, which are both catastrophic. So we have to be careful. There's evidence which shows that it works. Can it tell us depth of space? Yes. Numerous studies have been done which talk about depth of space, and it's within 3 to 5 millimeters, and I'll show you that. Does it tell me how many attempts are reduced if I use ultrasound? Am I able to redirect the needle? Is it less when I use ultrasound? Or what is the efficacy? Are the patients satisfied? Are the anesthetists satisfied? Is it safe? So I'll just take you through the evidence. First and foremost, this is an article that I published. So I'll only be talking about articles published in about past 10 to 12 years. This article published by Kijan from Toronto Western and Manoj. And this was first review article, which was quite extensive and talks about sonoanatomy, technical description. So if you have time, do look through it. I'll send you the QR code right at the end of this presentation about it. So talk about technical aspects first. This was an article published in 2016 by Anahi Perlas, Kijun Chin and company from Toronto Western. That's the QR code if you want to keep a copy of it to see what it is. It's quite detailed. It is behind a paywall, but if you want a free article, do let me know. I'll give you my email and I'll send you the article. I do have a copy of that article. So what it showed, they basically went through about 31 clinical trials up until 2014, 2015 for pre-procedural neuraxial ultrasound, both for spinals and epidurals. And what they came to the conclusion was that it improved in identifying exact or within the same levels. It also told them that the depth was pretty much within 3 to 4 millimeters, both for spinals and for epidurals. And why the depth is a bit up and down, that can be put primarily to the reason that think about pressure that we put when you put the ultrasound probe. If it's a big patient, it makes all the difference. So the reason that the depth is a bit up and down, and it did show that there was reduced risk for traumatic procedures for the patient, i.e. patients had much less traumatic spinals and the technical failures reduced down to less than 50% or so. So this was from Anahi Perlas. Take you a bit further. Kijun again wrote about recent developments, which was published in Current Opinions Anesthesiology, QR code at the end of this. And he said that the pre-procedural ultrasound imaging reduced technical difficulty, one, especially patients who were fat or patients who had scoliotic issues or even who had surgeries in the past. And this was even true for experienced practitioners, almost reduced a lot of technical issues that we normally face with such patients. He also suggested that it minimized the risks for injury to the spinal cord and also traumatic procedures and potentially reducing the incidence of post-spinal back pain. However, he did say that pre-procedural ultrasound didn't really improve the technical performance in patients who are very easy to do, which is quite common, because I think when you do it for normal patients, it does increase time a little bit for the anaesthetist by a few seconds. What has been shown has been 30 to 60 seconds or so. However, he did say that it can be effectively used for residents. They did a study in 2014, 2015 with brand new residents and taught them how to do it. And they realized that the residents became much better if they did between 10 and 20 supervised procedure. So there is evidence that it improves, the skills improve as you start doing upwards of 10 to 20 procedures or so. Current standard is approximately 35 to 40 procedures to reach a technical skill that is, you can do it unsupervised. Okay. A bit more evidence. This was published by Young from the States just a couple of years ago. And what they did was they did a systematic review and meta-analysis to see if conventional landmark versus pre-procedural ultrasound, if it improved things for the anesthetist. And what they did was they found 22 trials, and they found if you used ultrasound, you had much better first pass success rate. And the patients who've had ultrasounds in obstetrics had much lower back pain and headache. And I think this is one of the biggest complaints that we see with patients who've had spinal stroke epidurals for obstetric anesthesia and analgesia. So this is quite good to see that there was evidence that had accumulated in the previous 10 years or so for obstetrics per se. Now, this article published in April, May last year also did a systematic review and meta-analysis of approximately 32 trials and one systematic review. The QR code is here from Sujipulu et al., published in Healthcare last year. And what they found, there was reduction in technical failure as had been shown before, plus improvement in first pass needle in with ultrasound. The levels are much easily recognized, one. Number two, the depth was within 3 millimeters. And they found if you had a patient with difficult anatomy, the NNT was approximately 3. So every third patient with difficult anatomy, you were successful as compared to when you just used landmark-based ultrasound, landmark-based spinal procedure or epidural procedure. And their study was quite extensive because the trials included all sorts of surgeries, right from urology, orthopedics, to other obstetrics, and so on and so forth. So this is something to look at. This is free access. You can read the study. Okay, as we come on to final couple of studies or so, this was published from Oyong et al. And they were looking at thoracic epidurals. The evidence for thoracic epidurals has been a bit thin, but what they found was this in their double-blind randomized controlled trial, that there was decreased number of skin punches for thoracic epidurals. There were less mean pain scores post-op for patients, so lesser failures. And they didn't find that the time required to do a thoracic epidural was much higher as compared to people who were just doing bog standard landmark based. So there is decent enough evidence which now suggests that it works. So if I could summarize all the studies so far, ultrasound helps identify midline, helps us tell what the level is. So if it's L34, L45, how deep the space is. Once you've seen the posterior complex, you know where you're going. Easily shows where the interlaminar space is. You can easily mark them to give you a point of entry. It also increases the first pass success rate. Also helps assess if there's abdominal anatomy, especially when you're doing a transverse scanning. You can see if a patient's got a bit of kyphoscoliosis, you can see it's related a bit. Accordingly, you can change how you put the needle in. Plus tells you what's the length of the needle that you need. So these are quite a number of things that have been learned by doing a pre-procedure ultrasound. However, despite doing so many things, it has been shown that time remains similar, especially for difficult patients when you're doing a ultrasound-based scanning and spinal procedure. Okay, last but not the least, there is reduction in post-op low back pain, post-op dural puncture headache, as well as reduction in number of punctures and so on. Okay, so I think in my book, it's a tick mark rather than anything else. Okay, let's now talk about anatomy, gross anatomy, which is quite important. And I think over the years, it has been suggested, in fact, any regional technique as you've got in the past day and a half, you really need to know your anatomy, your gross anatomy to begin with, and with your sono anatomy. So I'll be talking about lumbar and thoracic. I will not be covering caudal. We can discuss it later if that's needed. So what do we talk about here? We talk about a vertebra, which has two parts. First is the body, right in the red, and then you've got from the body comes out the pedicles, followed by laminae. From the pedicles come out the two transverse processes, which are fairly straight in a lumbar vertebrae. And then you've got a superior articular process and an inferior articular process, and they articulate as the spine goes down. And you can see, you can access the spinal cord from two basic angles, either from interlaminar when you're doing
sorry, Preet, can you unmute you? Sorry, I think got muted.
Is that okay?
Yeah.
Okay, sure. Give me 1 second, sorry. Okay, so gross anatomy, we talked about the body and the arch. We spoke about where you can get in, both in the midline and paramedially. And then we spoke a bit, so this, so I've talked about the hard bits of the anatomy. It's the soft bits of the anatomy, what you see posteriorly when this happens. So I'm just going to bring you out here. So what you see when you put the ultrasound probe here is the ligaments. When you're between the spinous spaces, you look at the posterior complex here, which is a mixture of ligamentum flavum and the posterior dura. And you can also see the anterior complex, which is a posterior longitudinal ligament and the anterior dura, which may or may not be visible all, but between the posterior complex and the anterior complex is usually a hypoechoic space, which is usually the cauda equina, or if you're further down the filum terminal, but usually cauda equina, which you may or may not see. It's fairly hypoechoic, and I'll show you as we go on. We all know that the spinal cord in adults ends at L1, L2. From then on, it's all cauda equina going through, and then filum terminal right at the end, which ends at S1, S2. So we have to be careful that we go in at L3-4 or at a lower level. Usually the L5-S1 level is the widest of all levels. Okay, so for scanning, I'm sure many of you've done, and some of you said that you've done it. So what are the planes and the views? Basically, we're looking at 5 views with an ultrasound for perioperative views. Let's talk about planes first. One is the median plane, which is right in the midline, followed by a bit paramedian, which is called the sagittal view, which is what we do, which is also called the paramedian sagittal. And then we've got the transverse view, which is basically parallel to the ground. The sagittal view is perpendicular. The transverse views are parallel to the ground. So what are the 5 views we're looking at? The 5 views that we're looking at are paramedian sagittal transverse process, which starts from paramedian, then articular process, then you look inside. So these are the paramedian views, the 3 that have been shown here, which I'm going to show you here as well. So these are shown up as A, B, and C, the paramedian sagittal ones. So A is paramedian sagittal when you're looking at the transverse processes here, which is A, followed by looking at the articular processes, which is B, and then looking on the inside, which you do a bit of oblique, which is called the paramedian sagittal oblique, a PSO view. Okay, so these are the 3 views. I will show you how they look sonographically. So let's go on to the first one here, which is the paramedian sagittal A, which shows up like this. So when you put your probe about 3 to 4 centimeters paramedially on the lumbar spine, you see the fingers coming up, which is also the trident sign. And the fingers are basically transverse processes. So when I started learning ultrasound 15, 16 years ago, we didn't have good enough machines. We usually used to have Micromax machines. And what we could see was the trident sign. The people who were technically very expert could show very clearly, but with the newer machines doing QLB, it's very easy to see that you can see the transverse processes. So you put the probe there, you see the transverse process with the trident sign. Between the muscles is the psoas, between the transverse is psoas muscle. So when you see this, you start moving medially. So from paramedian sagittal transverse, you start moving medially onto the articular process, which is the B part of it. So what you see on this one is the humpy or the speed bump sort of a thing, which is also called camel hump sort of a thing, which is the articular processes. You can see you can't see between the articular processes because they're fairly continuous all over the place. Okay, so you can't see between the articular processes because this is how the articulations are for all the levels. From here on, as you keep on going more medially, what you see is the interlaminar view sort of a thing. And that is when you bring in the probe more medially, you start seeing the sawtooth appearance like this. And when you see the sawtooth appearance, you move your probe looking inwards. As you look inwards, this is called the paramedian sagittal oblique view. You start looking in the spaces between the laminae. That's where you start seeing the posterior complex and the anterior complex, as is shown in the next one right here. But you can see the posterior complex here, which is hyperechoic. Then you got the intrathecal space, which looks very hypoechoic. And then you see the anterior complex in the front. So once you start seeing this, if you're going to be doing paramedially, you can at least put in a caliber, see what the depth is, at least then you know how deep you have to go. Okay, so this gives us an idea where to go. However, in the same view, what you can also do, this is caudate. You can move your probe further down. So your probe being here, you can move your probe further down onto L5S1. You see a straight line, which is the sacral promontory. So at least then you can start counting the levels that this is S1 here, if this was here, for the L5, L4, L3. So you can count your spaces up and see when you're doing this, which is the widest space. So where do you put the needle in? I'm sorry, if you're brand new to this, you might find this very confusing, but the workshop in the coming 3 weeks, where there is spinal ultrasound, that will be able to help you visualize it a bit better. So you can count up and see what the level is. Once you've done the parasagittal, then you move the probe 90 degrees to make it into a transverse view. Okay, now there are 2 transverse views. One is the transverse spinous process view, which is when you look through the spinous process, obviously there's a bone. Bone is going to be anechoic, nothing's going to pass through it. So that is one view. The other one is that you see between the 2 spinous processes, and that is the interspinous view. That's for the transverse interspinous view. So let's look at the spinous process view. So now the ultrasound probe is passing on top of the spinous process here. You don't see anything underneath the spinous process. That's completely black. So you're sitting on top of the spinous process. What you see on the side is the laminae. And you may just, if you tilt it a bit caudate or careful, you might see a transverse process as well going on the side. So this is what you do. When you see this, you move either a bit caudate or a bit capillate. Once you move a bit caudate, in this case, what you start to see now is You see the interspinous ligament, you see the supraspinous ligament for the interspinous ligament, and then from here, you can easily see the posterior complex right up here, which is quite faded. And that's what you find in a lot of patients, that you may not see the posterior complex very clearly. However, what I normally tell people is, if you see the transverse processes here, the posterior complex is pretty much in the same depth. So if you're unable to see posterior complex, look at the transverse process, and that's where your posterior complex would be. You may see hypoechoic space in the front, followed by an interior complex right across. So this is where you have to go. So when you turn it transverse, you see where the midline is in the previous slide, mark a point there, and then go caudad or cephalad, and then you can see where the need point of entry is, and you can easily at least mark a couple of spaces so that you know where you have to go. Even if you falter on one, you can see another one. And I always suggest go up and down to see which is the widest space for you to get in. Okay. Right. A bit about thoracic spine anatomy. I know there's been a resurgent interest in segmental spinal anesthesia with the thoracic ones. What I would like to sound a clear alarm is that thoracic spine, especially the top ones, T1 to T4, isn't the easiest. And then T5 to T8 are quite difficult, primarily because of these things, the spinous processes, which literally sit on top of the other body, and there's hardly any space there. So if you're going to be doing thoracic spine anesthesia, you have to think about paramedian views rather than looking at a median, because you will struggle, especially between T5 and T8. However, as you go down to T9 to T12, the anatomy is quite similar to a lumbar one. So that's something that you have to think of when you do thoracic spine. However, saying all this, the anatomy and the sonographic pictures and the views remain similar. So two views as usual, the paramedian sagittal view here, which is interlaminar. Now you have to understand the laminae for the thoracic ones are not sawtooth, they're much flatter. So that's one view, the parasagittal. Another one is the transverse view here. But transverse view may not show you. So what you do is you have to do a bit more paramedian for this one as well and look for a space. Okay. So this is the paramedian sagittal or parasagittal per se, not exactly paramedian at all, about 2 to 3 centimeters from lateral, and the transverse here. Okay. So what does the parasagittal show you? As I said, the laminae are pretty flat for thoracic. So you will see flat laminae, and you would see between the laminar spaces that there is a posterior complex, and you can put the needle there. The spinal cord and the interthecal space will remain hypoechoic, and you would see an interior complex as well. Okay, so that's a parasagittal. If you went on to the transverse view, which is like this, right, just paramedially, and you would see a spinous process and laminae, and you can get your needle. If you're a bit more paramedian, especially the lower one, you should be able to get a median entry there. Okay. So that's thoracic. How to start scanning? So if you're brand new, when I started spine about 5 or 6 years ago, I took a water bath skeleton, which we had in a department. This is right to the picture of that water bath skeleton, which is the easiest way to do it because it's a osseous model. So at least you can see, once you know what your gross anatomy is, then it's easier for you to then put on soft tissues on top and underneath to get a clearer idea. But this is a good starting point. Once you've had a look at it with a water bath, then you go on to your own friends, maybe family, perhaps you've got kids, try getting them in, have a look, and then go on to normal thin patients. Go through about 10 to 20 and it'll get easier. Okay. And how do I do it on a day of the scan? First and foremost, how do we prep all patients? We have to think about position. Do you want to do it sitting up, laterally? That's one part of it. So lateral decubitus sitting. However you are going to be doing the spinal anesthesia or the epidural, take the same position. Use a curvilinear probe because it gives you a wider angle to see where it's going. Do all your pre-regional anesthetic safety checks. Make certain what's going on. Make certain the site and everything's all sorted for yourself, and put the monitoring on the patient. Then you start off, use adequate jelly, and then go from views, right, paramedian transverse process all the way to paramedially oblique, sagittal oblique, and then you do the transverse ones. So I think you have to be systematic. Do a systematic scanning as you start off, so it gets easier. Once you've done systematic scanning and you're quite adept at it, you can actually put it right at parasagittal oblique count up and down, mark and go in. What's suggested is that we should all be doing pre-procedural scanning. As you get adept at it, you can do real-time scanning, but that's a real chore, and I don't see many people doing it at this point in time. However, with improved machines, it can be a reality, especially for fairly difficult patients. Okay. Right, a bit of tips and tricks. Think about patients, start doing with thinner patients, sitting up. Once you get the pattern recognition, you start doing in almost all the patients. However, be aware of the anatomical variations. There can be lumbarization of the sacral vertebra or the other way around, and there's approximately 10 to 15% of patients. So that might mangle up your numbering of lumbar vertebrae. So please be careful about that one. There are other anatomical variations, but these are the main ones, plus the scoliosis that the patient might have, or a bit of kyphosis. There might be rotational deformity. So when you do a transverse scanning, you might see that the vertebra is a bit more rotated. If that's the case, make certain that your needle goes in the same place. So you just have to remember that. That's a bit about patients. In fact, there are lots of tips and tricks I might forget. If you're happy for the other experts to let me know if there's anything else that they would think about. Now, think about the machine and the probe. When you think about the probe, I said we normally do with curvilinear probe. However, it's a very thin, frail patient, so you might get away with a linear probe. But please be careful. Once you know the probe, have an adequate depth, you can change the focus, you can improve the gain to get you a better and better picture. Last but not the least, as I've been told every time, think about part. Think about pressure, alignment, rotation, and tilt. And be gentle. Don't be mental as you go up and down. And you start to recognize the patterns slowly but steadily. Okay. Think about cephalad caudate movements, because they will change how you look at it. And for spine, that's quite important, because you're looking for the widest space, especially for most difficult patients. But be slow, be thorough, and be systematic about how you go through. And you may not always see ligamentum flavum, as I said. If you don't see ligamentum flavum, but you see the transverse processes, that's where the ligamentum flavum lives. That's what we've been doing for quite some time. But look for the widest space and go in. Now, if you've got really big patient, or if you're going to be struggling because you've got difficult anatomy, think of a 22 gauge needle. It has been shown time and again, older patients, bigger needles really don't make much of a difference. Think of a 22 gauge needle. It's easier to go, especially if it's a longer depth. They're much more easier to manipulate, much more easier to see. And you would see as you reach the space, you were doing it real time, and you've put in an injection, the dura will move. So I think there are slow tips and tricks that you can use with time, but happy to ask for more. Okay, so in conclusion, there is good evidence that this works, and this works for a lot of patients. But start with all the patients. If you have access to an ultrasound scanner, there's an extra couple of minutes. Do scan most patients. Start simple, build your competency. It's all about pattern recognition, and mark the patients. Once you start marking, it gets better. And as you get better, you can do it real time. Okay, that's me coming to the end of it. Any questions, happy to do it. This is the QR code that are there for a few slides that I used, and happy for you to see them. Thank you.
Thank you, Preet. Amazing presentation, amazing clarity, beautiful slides.
Thank you.
So with the floor is open for questions. We just have to see if there are any questions. Take questions from faculty first, if there's anything, and then we'll look at.
I will get this model. This is the water model. So we have created this for training. This is for the lumbar spine, and we will likely get it, because bringing it to Hyderabad, and I'll bring it to Bangalore as well, so people can use it for scanning.
Thank you very much.
Any tips and tricks?
Hi, Shiv. I hope the customs would allow you to bring a skeleton to India.
I will just pack it. If they throw it, they'll let them throw.
Good luck.
I'm going to just put it into the. This is. I think this is not an actual body. This is synthetic.
But there's
We have to convince them
something
that.
else.
Oh yeah. They can look at it and look at it. It is pretty synthetic. It's not a actual bones. You know, the way it is being created, it is a synthetic one. So they should hopefully not have any problem with that.
We also have Dr. Anshuman Mishra, who does a lot of ultrasound spine. Thing to add, sir, Dr. Anshuman Mishra.
Hi, Anil. Am I audible?
Yeah, you are.
Yeah, hi. Hi, Shivshar. Hi, Dr. Somnath, Preet Boss, Dr. Guru. Actually, I just wanted to add, when we go for a focus for spine thing, the most important thing for us is an anterior complex. Usually, the anterior complex is very easily visible. People jump onto the anterior complex and they say, this is visible and this is what we are interested in. We are not interested in anterior complex. We're interested in the posterior complex. If you are getting an epidural, you should not cross the posterior complex. If you want to get a spinal anesthesia, given spinal anesthesia, then you need to cross the posterior complex. And most of the time, what we do is basically ultrasound assisted spinal neuroaxial block rather than ultrasound guided. So ultrasound guided spinal anesthesia still can be done, but for giving epidural, you need these fanciful things, the new things that probe have come for using that thing, which has you can use the needle and the probe together in the same thing, and then you can use it for epidural. That is what, just to add. And Dr. Preet usually does a very fantastic presentation every time. And today the presentations have been very nice from everyone. Thank you. Thank you so much.
I think what you said is pretty correct. It's a posterior complex we're more thinking of. But yeah, AC seem much easy. And I've had residents who look at the anterior complex and then say that's a posterior complex. So really have to tell them, that is an anterior complex. Look at where the transverse processes are. Think of that line. Do not go all the way through, because that's how you go into the cord or into the chordiac pinna and cause more problems. And quite correct, yes. And I think it's about pre-procedural ultrasound scanning is what we really have to do rather than looking at real time. Real time is a very different skill. It takes a lot of time. And I think it's still a work in progress rather than doing it regularly. It's an advanced technique, to say the least. Thank you.
I'll just narrate an interesting incident. Going back 20 years, around 2002, when I was still a senior registrar, we went to a radiologist along with one of my consultant colleagues saying, can you teach us for difficult spinals and difficult epidurals, can teach us how to use ultrasound? He, without a thought, showed us the door and said, that's my door, forget about it. It's a complete waste of time. And, radiologists have lost such an opportunity with a tool that they were using so much just because they just couldn't imagine what the scope of the equipment was. And today we are talking about routine preoperative and scanning for ultrasound scanning before a spinal. It's shows where medicine's heading.
Yeah, absolutely.
Few comments on YouTube. First is a comment by Dr. Sanath, and Dr. Shiva has already replied, but I want to put it to Dr. Guru. Has there been any process in the world where images or videos of the block has been reviewed when a complication occurs? Dr. Guru.
Yeah, look, every data, look, it all depends on local government guidelines and policies that exist, and it's different across different countries. Now, even if you scribble patient-related information on a piece of paper, be it just a tissue, right, that can be used for evidence. So, as such, anything that is related to the patient can be used for evidence, whether it's on a piece of paper, a waste paper, or digitally stored somewhere. Now, when we collect data on cloud and it's kept analyzed, although it's anonymized, the code can come back and say the law states that if that data needs to be used for a particular arbitration or whatever it is, it has to be used and it can be used. So if a piece of paper can be used, the data sitting on the cloud can be used. Now, that is where, you know, your documentation is so important, that what you document in your clinical notes is the first priority. That is what stands in the code. And digitally stored data is of lower priority and might be accessed or might be required if you got poor documentation or lack of any documentation, you know. So they will try to source any possible information, you know, and we are all bound by this law.
Guru, I think
I just like. Go ahead, Shiv. Sorry.
Go on.
So I just like to, you know, one of the things that we do when we are scanning for, you know, point of care for assisting in procedures, it's not traditional practice for us to record the event, right? So unless you record, it's not going to be saved, right? So, you know, that's where the problem is. And, you know, we will have time to time, you know, we are talking not about legal, look at a departmental level. Does any department have a mandate to say that if you're doing anything ultrasound guided, you have to record? I don't think there exists such a, as you know, say for example, as a head of department, if we mandate that, then when we have a complication, we can look at it to say what went wrong and how we could have prevented it. So I'm not thinking of the legal, yes, but once you record, that is legally available, which can be used, which can then incriminate you. But just as a process of, you know, improvement of, you know, trainees' performance of various procedures, even I'm just thinking at central line insertions and things like that. If we record, then yes, there is a possibility that we will benefit by being able to train them better and say what they did better, what they didn't do well, and how they could have done things better. So, because a lot of procedures are done out of hours, unsupervised by trainees. So that's my take on, you know, thing. But I'm not thinking as far as getting incriminated in legal procedures.
Can I come in?
Yes, sir. Yes,
please.
Sir.
Okay. Obviously, this is about the nerve injuries usually. When you're talking about the blocks and things, there are two aspects to it, recording it. And then I think the question was that, can you go back and look at the complication? And can you, you know, nail someone for the cause? You actually looking at that. First of all, the incidence of nerve injuries is very, very low. One. Second thing is that nerve injuries can happen because of surgical reasons. And there was actually one of the papers I was looking at when I was, you know, making the presentation was, you know, nerve injuries, how do they occur? Because intraneural injection, subepidural injections, do they really cause nerve injury? And there is even enough evidence actually there where you can put in injection subepidurally and still not have any physical evidence of that. But if you do nerve conduction studies, you will find some changes. Okay, so even if you are injecting it, it doesn't mean one thing. Second thing, who is actually going to review it? I mean, the thing which I actually put it up on the answer to the chat where it says no, it doesn't happen. There was actually Divesh was actually you know, in, I don't think whether he was part of that Twitter chat, but there somebody put a wrong video saying that, oh, this is a anterior approach to sciatic nerve, and we're saying, well, what are the structures there? You're putting a needle. Then they took off the this thing, withdrew that, deleted it, and then put it as separately, saying, oh, this is a lateral approach. I say, if this is a lateral approach, you are looking at how are you able to see that? Okay, immediately blocked. Okay, so people likely are, when it goes into that kind of a thing, and there's a people actually came after me, said, oh, she is a world expert in this and that. I said, okay, fine, maybe I'm wrong, but you know, if I put my probe on the side on the little side, I'm not going to see the blood vessels. That is for sure. This is simple anatomy, not that. So people will be afraid to actually put things and you know, get criticized for that. So who is going to review that? Now, when I actually do blogs, especially with trainees, I actually record each and every blog. I've got a huge data, of blogs, and I go through them. It is more for improving their blogs. Okay, you also learn during that time. It's a great teaching tool when you record and go through it with the thing. As far as medical legal aspects are concerned about this thing, I think it's very hard to prove that somebody actually has physically, until they blow up the nerve. Okay, physically, it's very hard to prove it. Guru, you got your hand up.
No. Yeah, thank you. Look, what I want to say here is that, yes, there are two sides of the coin. Like, if documentation across many parts is very poor. And to the large extent, I know that people fear documenting accurately for fear of incrementation. But actually, documentation is for their own benefit, So it's like two different sides of a coin, Same with the videos and images that you store for a patient, right? So it can be utilized for a positive intent, but the question was, can this be used to incriminate you for a possible nerve injury? And that is, so far, there has been, as far as I know, the people have not been incriminated using evidence of data that they have collected through audits. There has been no case so far, but have they been used the locally stored images and videos about a patient? Possibly yes, because that can be used. Now, that interpretation of that video is also controversial. Now, whether you say it is intraneural or is it paraneural or is it intravesicular is also questionable. Now, along with this, there should be supportive findings of nerve conduction studies and things like that. Now, there was one of the cases in my audit that I told that we had a permanent sensory loss after a sciatic nerve block. I remember that case till now, although it's been more than 8 years, because it was done by a trainee with my supervision. We used dual technique, ultrasound and PNS. Threshold current was 0.5. Nerve conduction showed that there was this. And I don't have the video. I didn't record the video. Now, if I retrospectively thinking, if that case would have gone to the court and things like that, if I had the video which did not show that there was any unintentional intraneural injection, there could be other causes of nerve injury, because nerve injury does not necessarily mean a direct needle trauma. It could be local anesthetic induced toxicity or pressure induced or some vasculopathy that caused nerve injury at that location. Now, the thing is, if you had, that could be as supportive, it could be as a support for your defense, or you could also see that you may have kind of kebab the nerve, as Shiv likes to say it, and you say, look, okay, I don't have any defense. But having said that, no matter whether it caused nerve injury or not, it all goes back to preoperative state where you have taken a proper consent, where you have explained these things and the possibility of this. And irrespective of what you have done, even if you caused a direct nerve injury, if your consent and if your documentation is improper, no matter what, if you have the best video demonstration of a nerve block, you will have no defense. So the defense lies in proper documentation and appropriate consent.
Go ahead, Shiv.
So there are two things. One thing in the US. When I was in Boston in 2018, and I was looking at their way of doing things, and they have to have not the video recording, but a picture of the nerve block being done, and that is a requirement for them to get paid for, the nerve blocks because it is done by that. So there is documentation, but not as. So they just show that this has been done. We have actually put some local, they'll take a snapshot, but they won't record a video. They will just take a snapshot of it and put it in the file as documentation that the block was done. So that is as far as documentation goes. I will actually tell you one of the incidences which actually happened at my trust, and I was actually asked to, for advice on it. So this was a patient who had bilateral hip replacement, arthroplasty. The first one, he had again GA and with lumbar plexus block, no problems. And the second time, again, he requested for the same because he had such wonderful experience. But that time, the anesthetist who had done the first side was not there. So somebody else helped them. The person who was there, the anesthetist didn't know how to do it. So asked somebody else to come and do the block. And that was a chronic pain guy. And he did the block. Everything went well. But down the line, the patient actually had cordyceps weakness. So the surgeon actually came, I remember it so well because it was a weekend. He came to see me. I was doing a trauma list. He called me and he said, I've got this patient. And first thing I said, I think you need to get an MRI done because you need to rule out if there has been any hematoma compression. And so they got an MRI done and there was nothing. So they said, well, you need to get a nerve conduction studies done then because we ruled out one thing. You get nerve conduction studies done. And it was done, it was basically the retractors, surgical retractors, which had actually gone with the sciatic nerve. So they had a segment of normal conduction followed by no conduction. So that's where it has. So it was compression from that. So a lot of these cases can be same thing with shoulder surgeries. If they are having any, they need to actually have a nerve conduction study done for that. So it goes to prove that it's not always the fault of the anesthetist. So don't get, like say, incidence of nerve injuries is very, very small. And if you follow due diligence, people talk about, triple, monitoring, which I don't actually do it myself. I tend to inject. I always say that you feel your own injection. And I teach that to my trainees. I teach it on the workshop. I say you can let go of the needle and you can inject it yourself. You need to have that feel of injection. Don't give it to somebody else who is not. Okay, if I have Anil with me or somebody else, okay, fine, I can ask them, okay, fine. But I won't give it to a ODP who doesn't know what is the pressure of a syringe feels. Second thing is that I always put local anesthesia 20 ml. So that learning over the years goes that you don't keep changing 10 ml, 2 ml, 5 ml. Keep your local in 10 ml, the pressure sensation remains the same. So again, it is teaching and training of how you prevent it. And I've shown it today in the one of the graphs. It was about interscaling, that if you do around 500 to 600, once you actually cross around 90, your complication rate starts dipping down. It is low. And once you're crossing around 400 to 600, your complication rates are almost zero.
Yeah, two questions are there.
Yeah.
Two questions are for Dr. Arun.
Sorry to interrupt, Anil. Before we change the topic, just quick question to Dr. Shiv. Shiv, yeah. I think we would like to have that evidence of experience versus safety. It's good to have because, if people can collect their own data as even as a logbook, simple logbook, or as their own audit database, and if they can show that they've done so many blocks and the association between experience with number of blocks with versus complication, right, is kind of empowers anesthetist or anesthesiologist that can also help in their defense. Sorry, Arun, you can take it.
Sir, questions for you, Dr. Arun. One is the use of ketamine in prevention of chronic pain. Dr. Anshuman Mishra wants to know that.
I think we will leave that part. I think there is more on the spine part below. I think one of the questions which has been repeatedly asked is that about the I think about dry tap. What exactly? I mean, can you identify it with ultrasound and say why it is happening? Some people say they get dry tap. And there are also incidences where people have said, I didn't get a CSF injected, still got a block. What do you think is happening in those cases? Preet, you need to unmute yourself, I think.
I presume it can be anyways from a dry tap due to a blocked needle to the needle, like we use the Whittaker needles, where the orifice of the needle is a bit further away from the pencil point. So you might find that it's a subdural injection. So that sometimes can happen. One part of it. Third part, there might be low pressure. We're using smaller and smaller, these 25s, 27s, and lateral decubitus. Might be that there's low pressure. Yeah. Last but not the least, you've had previous surgeries. There might be pockets that there's not enough CSF. So I think there are various parts to it. Is there previous surgery? Is there low pressure? Is the needle blocked? Is the needle really in the space? If it's a subdural puncture, that might be the case. So it might work if the subdural would be a very patchy block, as we all have seen with subdurals. I've seen 2 or 3 in my life. God forbid, I don't want to see another one. So I think these are the various reasons I've found for dry taps. What I suggest is if it's a difficult patient, what I've started teaching of late is use an epidural needle to search for the epidural space first. As you get in the epidural space, inject a bit, you would see the dura moving. And from then on, you use a spinal needle through it, and there's a fair chance you'll get a good tap rather than going through without an epidural needle, because that's how you search for a space. I'm not sure if that answers the question for Dr. Dilnaz, who was asked this question. Anyone else for any other expert comments?
Is it possible that they could be, because people are actually worried about going too high and they're lower down, and this is basically the area where there is just the caudal, now I wouldn't say caudal in that area, but a lot of fat rather than, the cord ending higher up rather than lower down, and they are actually going into that space.
Yeah. So fair chance they've just stuck in the epidural fat rather than going further in.
Yeah.
Fat is hypoechoic as well. So that's L5S1, the last phase, the widest of all. Quite possible.
Yeah.
I always are on the side that's more low pressure and using 27 gauge needles.
Yeah. I mean, what would you actually say that if somebody get a dry tap, would you actually suggest that they could attempt going slightly higher?
Yes. So I would suggest, so if you've got a dry tap at the lowermost, you might try L3-4 or L2-3, but you have to be careful that you actually count the levels with double surety and perhaps not just landmark based, with ultrasound based, to see that you're at the right level. If you can't count up, count down from T12 to make certain that you're not missing the spaces, but definitely not above L2 at any given point in time. And I think there is almost 5 to 6 millimeters between epidural space and the endothelial space in the lumbar area. So we have to be careful how we put in. But of late, I've realized using Whittaker needles in older patients makes your life a bit more miserable. We get 25 gauge Quinkies as well, with orifice right at the end, which helps much more. And the incidence of PDPH decreases as you get older, over 65.
Yeah.
So there.
That's very true. I think Quinky needles are actually better for that kind of patient. So I'm actually got a comment, I think.
I have a question for the entire faculty team. We enthusiasts of regional anesthesia look at the block working. It works when patients perfectly fine. Post-operatively, we send the patient back. But breakthrough pain is a reality, and a small percentage of patients will have a breakthrough pain, and they go from a state of being painless to severe pain very quickly as the block wears off. And that's an unbelievably miserable state that the patient is in. And quite often what happens is we don't get activated, patients in severe pain for 15, 20, 30 minutes, half an hour, an hour. And it just completely ruins their post-operative experience. So what do we do as clinicians to anticipate and breakthrough pain? What systems do we put in place to make sure when there's a breakthrough pain, it's active, we get activated quickly? And do any of you have any standard protocols on how you deal with post-operative with this breakthrough pain? Because quite often it'll happen in the middle of the night. There's a trainee there. and what one trainee does is different from another trainee. Does any department have a standard procedure?
I think Guru has got his hand up, so I'll let him answer, then I'll tell you about our experience on that. Guru.
Thank you. Look, that is again my area of interest, and that is what we found out through our first 2 audits. Actually, one of the most common reason for patient dissatisfaction after regional anesthesia is not the failure rate. It's about rebound pain or breakthrough pain, either of these two, right? So short-acting blocks were not useful, or blocks that wear off in the middle of the night was not useful. Now, after finding out these things and after talking to patients and obtaining their feedback, we instituted some measures. Now, that has been pretty effective to the extent that we've got 95% plus satisfaction rates in the recent years, including in my private practice. So I do a lot of shoulder cases, and this is what my practice is it starts in the preoperative phase. Okay, patient gets educated not just about the block, about the characteristics of the block, what do they need to expect post-operatively. So I spend that extra 5 minutes in the preoperative phase. Even if I'm seeing the patient for the first time in the holding bay area, just before entering the patient, I just spend that extra 5 minutes because it is worthwhile. That 5 minutes is almost like a tape recorder running loop for me, because I do this for every patient, so it's kind of embedded at my spinal level that I keep talking the same thing. I tell them about that you will experience a numb dead arm. It is okay, no need to panic, because some patients have panicked that they've got stroke or something like that, because if they're not explained about the feeling of that numb dead arm. I talk to them about rebound pain. I tell them an approximate duration of the block with a range. It lasts from 18 to 24 hours or so. And I tell them, look, actually the block doesn't wear off suddenly. You start to feel tingling as more movements coming back first, and then tingling numbness starting to wear off. Then it starts as a mild discomfort. The problem we had previously was that patients were never given any analgesics at all until they complained of pain. Yeah. Now that was the problem we identified. So I tell the patient, I empower the patient, and we have educated the nurses that even if the block is working 100%, multimodal analgesia should be started immediately after surgery. Or even during surgery, I still give Panadol. A lot of people have questioned me, you're doing this case under spinal, you're doing this case under a solid block, why do you need Panadol? Yes, I do still give them Panadol. So Panadol round the clock, by the mouth, 6 hourly. Non-steroidals or anti-inflammatories, if not contraindicated, will have to go even if there is no pain. This is the specific instruction that is given to the patient. And I tell the patient and I empower them, you need to tell the nurses, because some nurses may not be educated. They come and ask them, oh, you don't have pain, so I'm not going to give you Panadol. I'm not going to give you diclofenac. I tell the patient specifically that you will demand for it, because we need to prevent this. Third thing I do is started adding a little bit of adjuvants, and I found that adding dexamethasone to the local anesthetic, although some people don't believe that, the quality of analgesia and the block duration has improved. And I've got direct feedback from the patient and the surgeons themselves saying that, that rebound pain is not as bad at all. And in fact, patients are much more comfortable for a longer duration. So this is what we have got from our audit data, that patient satisfaction, and I've got direct surgeon feedback. Lastly, what I do is, previously we could have used long-acting opioids, but now it is definitely banned in acute pain setting. Now, I don't have many choice to give some kind of a background pain relief, especially at night, and also to help them sleep. So one of the drugs that we got in our armamentarium recently is tapentadol slow release. Although there are some restrictions for its use, and it can be privately given as a script, and patient can buy it privately rather than they get any benefits through the government. So I do tell the patient that, look, you will have to pay extra $10, $20 for this, but it is worth them on slow release Pelexia or tapentadol slow release morning and evening, and I instruct them to give it or take it at night and in the morning again. And I keep telling the word, even if the block is working. And I give them one last instruction that as the you start to feel the discomfort, if you have taken all the 3 drugs, if you start to feel mildest of discomfort, start taking oxycodone tablets at the lowest dose. So for me, as you could understand by my speech, it is so fast. This is how I give instructions to the patient. And I tell them not to worry, you get everything written up, everything given. I've got a discharge leaflet that goes with every patient. They all get automated email post-operatively about all these instructions. So there are ways that you can set up smartly, effectively, and you can improve patient satisfaction. Thanks for listening.
Yeah, that's. I think my session would have been the same. I think we need to move on. We are actually on time for the next lecture. Anil, yeah.
Again, it's been a great session from the previous one. We'll move on to the next one. The next session is on additives in peripheral nerve blocks and central neuraxial blocks. And that will be by Dr. Renita Marina Pinto. She's a consultant anesthetist at Aster CMI Hospital in Bangalore. Her areas of interest include cardiac anesthesia, transesophageal echocardiography, ultrasound-guided regional anesthesia, and medical teaching. She'll be talking to us about, as I said, additives in peripheral and central neuraxial blocks. Over to you, Dr. Pinto.
Thank you for the introduction. And thank you, team FARA, as well as Dr. Somnath, for giving me this opportunity to be part of this educational program. Good evening, everybody. Greetings from Aster CMI Hospital, Bengaluru. Regional anesthesia has become an integral part of modern anesthesia practice. Advances in technology, patient satisfaction, improved safety, fast tracking, as well as awareness about morbidity associated with poor post-op pain control may be responsible for it. However, the pain relief offered by single-shot regional anesthesia techniques is limited by the duration of local anesthesia, which may be inadequate to manage the post-operative pain. To overcome this, attempts have been made, and indwelling catheters as well as additives have been tried. And I'll be talking about one of these options, that's additives in regional anesthesia. Apart from prolonging the duration of anesthesia, these additives also improve the quality of nerve block and facilitate administration of lower doses of local anesthetics. A lot of preservative-free drugs, intravenous drugs, have been tried as adjuvants in regional anesthesia, like opioids, as well as non-opioid drugs like NMDA receptor antagonist, magnesium, ketamine, dexmedetomidine, as well as clonidine. However, one must remember that apart from morphine for intrathecal use, none of these agents have been approved by the Food and Adult Administration, FDA, or any other regulatory body for use as adjuncts in regional anesthesia. Hence, their use as adjuvants in regional anesthesia remains off-label. Nevertheless, it's unlikely that in future, any pharmaceutical company would sought any approval because of the associated cost as well as time. Further, lack of evidence of harm is not evidence of no harm. Hence, caution is advised while administering them. Opioids. By far, opioids are the oldest adjuvants used in neuraxial blocks and peripheral nerve blocks. They act on opioid receptors, potentiating antinociception by local anesthetics via G-protein coupled mechanism and causing hyperpolarization of afferent sensory neurons. However, their use is limited by the associated side effects like pruritus, nausea, vomiting, paralytic ileus, urinary retention, as well as the most feared of all, that's the respiratory depression. The extent of efficacy of these agents depends on the dose that's administered, site of injection, lipophilicity, as well as the acid-base milieu of the site where it is administered. Morphine. intrathecal route. This is the first opioid which was used intrathecally, and it dates back to 1979. Since then, preservative-free morphine has been used with or without local anesthetic, with good results in various age groups as well as for various surgeries. And it is considered to be a gold standard analgesic method following lower segment cesarean section as well as orthopedic surgeries. Its hydrophilic nature results in cephalic spread, widening the area of analgesia. It is used intrathecally in the dose of 75 to 300 mics, but analgesic ceiling is reached at 100 mics, while higher doses, that's especially about 300 mics, increasing the incidence of delayed respiratory depression, which warrants a 24 hours in-hospital stay and monitoring. This is a meta-analysis by Sultan et al. On effect of intrathecal morphine, that's low dose, that's 50 to 100 mics, versus high dose, that's 100 mics and above, up to 250 mics. And authors concluded that pain scores at 12 hours, as well as morphine consumption at 24 hours, were not significantly different between the two groups. Further, the incidence of nausea and vomiting was lower in the low dose group, favoring the use of low dose. Morphine via epidural, about 1 to 5 milligram has been used, and 3 milligram being considered as the adequate dose to balance the analgesia and the side effects. Palmer et al. In their study reported a ceiling effect, analgesic ceiling effect at 3.75 milligram for epidural morphine. In pediatrics, caudal epidural morphine in the dose of 30 to 70 mics per kg has been used, and Baduni et al. Concluded that caudal epidural morphine significantly prolonged the duration of analgesia with higher doses, that's 70 mics per kg, increasing the risk of respiratory depression. Because of weak evidence of benefit, currently morphine is not recommended in peripheral nerve blocks, as studies have failed to show any advantage over intravenous or intramuscular routes. Fentanyl neuractually. Compared to morphine, fentanyl is more lipophilic, which limits its rostral spread and thus the feared complication of delayed respiratory depression. It has a rapid onset of 5 minutes following intrathecal administration and 10 minutes after epidural, and a short-lived duration of action, about 2 to 4 hours. Its rapid onset of action is beneficial in labor analgesia as well as for lower segment cesarean sections, but the duration of post-operative analgesia would be limited because of its short duration of action. Currently, it is recommended intrathecally in the dose of 10 to 25 mics and for epidural dose loading in the dose of 50 to 100 mics. And for continuous infusion, along with bupivacaine, it has been used in the dose of 2 to 4 mics per ml. It does not prolong the duration of motor block when administered along with local anesthetics, but certainly it improves the quality of the block. Leo et al. In their study involving 8 volunteers concluded that 20 mics fentanyl to lidocaine spinal anesthesia prolonged the duration of sensory anesthesia without affecting the motor recovery or time to micturition. Further studies have failed to conclusively prove benefit of fentanyl added to peripheral nerve blocks. Hence, currently it is not recommended. This is a chart on suggested doses of intrathecal opioids for different types of surgeries. And as you can see, as the level of incision moves cranially, the requirement of morphine intrathecal goes up, and thus the incidence of post-op delayed respiratory depression. The other opioids that have been used include sufentanil, hydromorphine. Hydromorphine is preferred in patients with renal insufficiency because of its better adverse effect profile. Buprenorphine, apart from intrathecal and epidural routes, it's also been used with good results in peripheral nerve blocks in the dose of 0.3 milligram, that's 300 mics. Tramadol, current evidence suggests to use it only epidurally in the dose of 1 to 2 milligram per kg. Diamorphin, this is a diacetylated analog of morphine with about 2 times more potent than morphine and has a shorter duration of action. Hence, in future, it may replace morphine. Alpha receptor agonists, they have been the focus of interest recently because of their sedative, analgesic, sympatholytic, anesthetic sparing, as well as hemodynamic stabilizing properties. Generally, they are used as adjuvants to local anesthetics and not as a solo agents. Neuraxially administered agents, they inhibit nociceptive impulses by activating the alpha-2 receptors in the dorsal horn of the spinal cord, as well as decrease the sympathetic outflow. Perineurally, they act by hyperpolarization of nucleotide-gated ion channels. In addition, by alpha-1 receptor action, they cause local vasoconstriction, reducing their vascular uptake. Clonidine. This was first used in 1984 for epidural blocks, and it has an alpha-2:1 activity ratio of 220:1. Intrathecally, it has been used in the dose of 15 to 40 mics, and this dosage has evolved from the initial high dose of 150 mics to balance the analgesia versus cardiorespiratory side effects. Epidurally, it has been used in the dose of 25 to 50, and in peripheral nerve blocks in the dose of 0.5 to 5 mics per kg. In pediatrics, for caudal epidural, it has been used in the dose of 1 mics per kg, which doubles the duration of action of local anesthetic. Adverse effects include bradycardia, hypotension, and sedation. Caution is advised while co-administering it with the intrathecal opioids, as it enhances the analgesia from them. This is a systematic review of 22 randomized trials evaluating the efficacy of clonidine as an adjuvant. Authors conclude that clonidine in the dose of 15 to 150 mics prolonged in a linear dose-dependent manner the time to 2-segment regression, as well as the time to first analgesic request with more episodes of arterial hypotension. This is another meta-analysis on clonidine as an adjuvant to local anesthetic for peripheral nerve and plexus block in the dose of 30 to 300 mics. And authors concluded that it prolonged the motor, sensory, as well as duration of analgesia by about 2 hours, irrespective of whether an intermediate or a long-acting local anesthetic was used. Dexmedetomidine, this is about 7 to 8 times more potent and more specific on alpha-2 receptor than clonidine. Intrathecally, it has been used in the dose of 5 to 10 mics and epidurally in the dose of 1 mics per kg with good result. Current evidence suggests the use of 1 mics per kg in peripheral nerve blocks, and adverse effects include bradycardia and hypotension. This is a meta-analysis on whether dexmedetomidine is beneficial as a neuraxial adjuvant, and authors concluded that neuraxial dexmedetomidine significantly decreased postoperative pain intensity as well as prolonged analgesic duration, and increasing the risk of bradycardia. Further, this is a recent study published in the year 2020 on the effect of different doses of intrathecal dexmedetomidine as an adjuvant for lower segment cesarean sections along with ropivacaine. And authors concluded that addition of 3 mics dexmedetomidine intrathecally along with ropivacaine improved the intra-block characteristics as well as elevated shivering in these patients, while having no effect on motor recovery, suggesting probably this would be the better dose to be used for in cesarean sections. These are studies comparing the effect of dexmedetomidine, clonidine, and fentanyl, and they show the superiority of dexmedetomidine over the other 2 agents in prolonging the duration of block. Further, dexmedetomidine or clonidine administered intravenously within 1 hour of subarachnoid block also prolongs the duration of the block by about 1 hour. Then how do we know that a perineural or a intrathecal route is better than an intravenous route? Where is the evidence? So this is a study which compares the effect of intravenous and intrathecal dexmedetomidine in spinal anesthesia. And the authors concluded concluded that the intrathecal dexmedetomidine significantly prolonged the duration of analgesia compared to that of intravenous. So favoring the use of intrathecal dexmedetomidine over intravenous. Dexamethasone, this has been extensively used in the past decade as an adjunct to local anesthetic in central neuraxial block in the dose of 8 mg intrathecally and 4 to 8 mg epidurally, and in peripheral nerve blocks in the dose of 1 to 8 mg. It basically acts on the potassium channels on nociceptive C fibers via glucocorticoid receptors, affecting the nerve activity of the nerve fibers, and also by suppressing the ectopic neural discharge. Adverse effects include hyperglycemia, immune suppression, delayed wound healing, as well as increased risk of infection. And in vitro studies have shown risk of peripheral neurotoxicity. Now, these are the studies supporting the use of dexamethasone as an adjuvant in intrathecal route or epidural route, as well as in peripheral nerve blocks. And Rasmussen also et al. Showed a 37% prolongation in the ropivacaine block on addition of dexamethasone. This is another study on dose response of dexamethasone as an adjuvant in peripheral nerve blocks, and authors conclude that low dose dexamethasone, that's 1 to 2 mg, was as effective as 4 mg dexamethasone in prolonging the duration of block. Now, despite of these evidences, it is speculated that the effect of dexamethasone is due to systemic involvement, and the analgesic effect which is obtained following the IV administration for post-op nausea, vomiting prophylaxis. Hence, more studies are required to know which route is superior. Adrenaline. This has been used as an additive to local anesthetic since a very long period. A typical dose of 0.5 to 1 mics per kg in a concentration of 5 to 10 mics per ml produces local vasoconstriction, decreasing the systemic absorption, prolonging the duration of action, and thus decreasing systemic toxicity. Accidental systemic administration can cause hypertension, tachycardia, as well as arrhythmias. It is known to decrease the nerve blood flow following intrathecal or perineural administration, and hence currently not recommended for intrathecal or perineural use. And its use is basically limited to rule out intravascular migration of epidural or perineural catheters. Magnesium sulfate. This has been investigated extensively for its analgesic effect in various clinical scenarios. It's basically a non-competitive NMDA receptor antagonist and a voltage-gated calcium channel blocker. Intrathecally, it is used in the dose of 25 to 100 milligram and epidurally 50 to 100 milligram, usually along with opioids. Now, Bhuvanendra in their study showed that intrathecal magnesium prolonged fentanyl analgesia in patients, in laboring patients requesting for analgesia. In peripheral nerve blocks, it is used in the dose of 200 milligrams and is known to prolong the duration of nerve block as well as hastens the speed of onset. Adverse effects include bradycardia, hypotension, sedation, headache, and periumbilical burning, currently not recommended due to paucity of clinical trials. Ketamine is another NMDA receptor antagonist, but with the local anesthetic properties, and it has been tried in various routes. Intrathecal and epidural ketamine as an additive to local anesthetic shortens the onset time, but simultaneously also decreases the extent and duration of the block. Hence, it is used in day case surgeries. Not recommended as an additive in peripheral nerve blocks because of high rate of psychomimetic side effects with no effect on duration of block. Midazolam, it's a short-acting benzodiazepine. Neuraxially administered midazolam exerts its analgesic effect by suppressing the spinal sensory input as well as its antinociceptive effect via GABA receptor agonistic action as well as opioid receptor. Peripherally, it acts on the translocator protein. It is used intrathecally in the dose of 1 to 2.5 milligram and epidurally in the dose of 50 mics per kg diluted in 10 ml of saline. Neurotoxicity is a concern, hence not recommended for routine use. Anti-inflammatory agents. Ketorolac has been shown to prolong local anesthesia in conjunction with regional anesthesia by inhibiting prostaglandin synthesis. In view of limited research, it cannot be recommended for neuraxial as well as peripheral nerve blocks, and neurotoxicity is been a concern. Sodium bicarbonate, it was used as an additive to local anesthetic to fasten the onset by alkalization, facilitating more non-ionized fraction, but currently, it hasn't been approved for clinical use. Adenosine, it has been studied for its analgesic effect mediated through spinal adenosine receptors and minimal neurotoxicity. However, Appen et al. Didn't find any beneficial effect on adding adenosine to local anesthetics for peripheral nerve blocks. Neostigmine, it's an acetylcholine esterase inhibitor and acts by increasing the level of acetylcholine. Intrathecally, it has been used in the dose of 5 to 10 mics to as high as 150 mics. And high doses increase the risk of adverse effects, especially GI adverse effects, that's nausea, vomiting, as well as bradycardia. Epidurally, it has been used in the dose of 1 to 4 mics. Not recommended currently in view of neurotoxicity. Other drugs that have been tried include hyaluronidase, verapamil, methylprednisolone, phenylephrine, and the list goes on. Now, this is a research article on local anesthetic peripheral nerve block adjuvants for prolongation of analgesia. And the authors concluded that buprenorphine, clonidine, dexamethasone, magnesium, and dexmedetomidine are promising agents for use in prolongation of local anesthetic peripheral nerve blocks. And hence, more studies are required to establish the safety as well as efficacy. Now, an ideal perineural adjuvant should only prolong the duration of sensory block or analgesia without having any effect on the motor block. Now, this is a chart which I borrowed from BGA, which comparing the effect of perineural adjunct block characteristics. And as you can see, buprenorphine prolonged the duration of analgesia by about 500 minutes while having minimal effect on the motor block. So probably in future, this may become an ideal adjunct to peripheral nerve blocks. Future trends, butyl amino benzoate, which is an ester local anesthetic, which provides analgesia for about 14 weeks by blockade of sodium and potassium channels. Another novel approach is use of charged molecules to produce local anesthetic effects. Novel delivery systems like dextrans, liposomal local anesthetics, and microspheres, as well as neuromuscular blocking agents have also been explored. Reiterating, only preservative-free drugs should be used as additives in regional anesthesia. Intrathecal morphine has analgesic ceiling at 100 mics, with higher doses increasing the risk of adverse effects, especially the respiratory depression. Opioids except buprenorphine, not recommended for peripheral nerve block usage. Dexmedetomidine is superior to clonidine in prolonging the duration of peripheral nerve block, but can cause bradycardia. Dexamethasone as additive prolongs the duration of analgesia. Adrenaline as additive should be used only as a marker to rule out accidental intravenous catheter migrations. Addition of magnesium to neuraxial opioids with or without local anesthetics does prolong the duration of analgesia. And lastly, choose your additive wisely based on significant scientific rationale after weighing the risk-benefit ratio, as except morphine, none of them have been approved by the FDA. These are some of the references. Thank you.
So we need to unmute yourself.
Sorry. Thank you, Renita. Very exhaustive presentation. You've covered a lot of stuff. We'll take questions for you at the end of this session. We now will move on to what has been touted to be a very interesting pro-con kind of situation where Dr. Shiv and Dr. Guru will be talking to us about the 10 blocks you need to know and the 5 you need to master. Over to you, Shiv, and Guru. You've been introduced, so we'll not waste time.
I think I will start off. Give me 1 second, and then I will hand over to Shiv, and I might come back. So give me 1 second, getting onto the share. Okay, so very interesting topic, and often not very well discussed at all, because I can see there is huge enthusiasm in novel techniques. People love novelty. People love new names. People love new acronyms and different approaches and things like that. And I feel that only a very small percent of it actually benefits. Now, there are many reasons why we need to understand this talk, and I will come to that in a moment. A lot of my talk has been based on this article from Lloyd Turbid from UK and all other colleagues about, what is the future directions, and it's a wonderful saying what Albert Einstein said, any intelligent fool can make things bigger and more complex. It takes a touch of genius and a lot of courage to move in the opposite direction. And often see that we are not moving in that direction. And this is not going to help patient benefit. And I'll tell you why. Now, this is a classic example. I love it. There are many, many more examples. When we talk about these chest wall blocks, we had this during the last FARA. We had lots of talks, and I think Divesh Arora is pioneer of all these blocks, and he does lots of these blocks, and he's very keen to do new blocks and all those things. Look, I'm not saying that it is bad, but does it serve the purpose of a larger good to the community, right? Now, if you look at what was started as just a simple paravertebral block with a needle and a syringe of local anesthetic, has gone on to a very advanced techniques or so-called advanced techniques of retrolaminar block, or then there is, paraspinal intercostal plane blocks, the anterolateral wall blocks. You can see there is serratus plane block, which is superficial, deep, the PEX 1, PEX 2. And if you go even more anteriorly, then there is PIP block, superficial, deep, and anterior cutaneous, and many, many more, thoracic kind of external intercostal nerve block, and all those blocks have been mentioned. If you look at analgesia for lower limb, we started off with a simple, humble femoral nerve block and a sciatic nerve block, right? And I can guarantee that there are a lot of anesthetists who still struggle to do these blocks effectively. But a lot of people talk about this femoral triangle block, the adductor canal block, the adductor hiatus block, the IPAG, EPAG, what sort? There will be more blocks that will come into the picture. So the idea is, the central part of all these things is that, we need to have block that can work anytime, anywhere, in terms of the patient's best interest. It should be quick and easy to perform. It should be in terms of a low risk block with terms of quality and ease. It's what is important is we look at what is the return, where you require minimal equipment, so that, even if you are in a resource poor situation, and you can provide adequate analgesia to your patients. That should be the single. So put patients in your center of your care and then think around that, right? There should be consistency in what you do. You should be reproducible in terms of efficacy and minimization of harm. Yes, you need to eliminate the opioid requirements, but even if you are able to reduce it, it itself is sufficient. So you don't have to have a perfect block. And also, if you can possibly reduce the likelihood of requirements of general anesthetic in resource poor situation, these blocks will be efficient. And why I talk about this is that, when people talk about analgesia or anesthesia or peripheral nerve block as a sole technique for some surgery, a lot of people are deviating from the good old techniques to a new novel blocks which don't provide the degree of surgical anesthesia, and trying to replicate some of the Western activities. So I think you should look into your own practice, and you don't have to have the latest novel block in your practice, but what is effective for your patient is what is more important. So the summary of that article was very clear. And look, it reflected my thoughts absolutely the same. And they came up with this table, and it's just what I had in my mind too. And I think she will come up with his own thing. But what they said is you need to categorize between two groups of anesthetists: those who are regular anesthetists who are not necessarily proficient in blocks, and those who can do all advanced blocks, right? So you need to know your strengths and your limitations, your resource settings and your abilities to develop your own top 10 blocks. But what has been described is shown here for upper limb, lower limb, and trunk and spine. And I agree with this, and we'll go through that later on. Over to you, Shiv.
Good things. We haven't shared our slides, but you will be surprised that what I'm going to say is, why is it mine not showing?
Now, purposely, I didn't want to share my slides with you so that
absolutely. You have stopped sharing your slides, isn't it?
Yes, I have.
So why is it not showing my thing yet? Because I'm trying to actually share mine. I have only got a few slides. I've not actually talked about. Yeah, I think this is it.
Yep.
Is it showing the?
Showing a blank slide.
Start from the slide. No, it's gone.
Yeah, it is blank. I have actually put it. Is it showing the whole screen now?
Yeah, that's right.
Right. Okay. So the 10 blocks you need to know. And number games, but before I click on, yesterday I was talking about how we say that ultrasound is making life easier, but I think it is making it complex. It is because of these blocks that everybody is looking for nook and corners to put a local anesthetic and name a block after themselves. That's what has actually happened over the years. So things have been, instead of being simplified, they have been made more complex. But now people are realizing, I say, they need to, get to a point where people should not be confused with all those various acronyms for, blocks, just put in a certain plane. So starting with the head and neck, one of the blocks which was not included in the slide which Guru posted, I would actually start with cervical plexus, because there are surgeries which are done in the neck. And if you look at it, cervical plexus block is probably one of the commonest blocks done for carotidectomy, but they can also be used, as Kala had yesterday mentioned, for a lot of surgeries in high-risk patients, thyroid surgeries, even tracheostomies, central venous cannulation. So I would add that to that. So these are mostly, block. Interscalene and supraclavicular, they're just extension of each other. You take a probe, you start looking at supraclavicular, at an angle of 45 degrees, and straighten it, tilt it up, you're into interscalene area. So they're just one block. People now have been talking about, superior trunk block, this block, that. It is nothing. If you give low volume at interscalene, it'll give you a trunk block. Okay. So it's nothing complex. I think still supraclavicular interscalene block is something, if you master one, you can master the other. Now coming to below the clavicle, any block, if you actually look at it, whether they're retroclavicular block, this block, that, they're all basically axillary block. Because if you look at the axilla extends from your pit and it opens into the supraclavicular fossa. Right. So if you're actually giving block just under the clavicle, you're giving block at the apex of the axilla. So that is superior. And I've classified that. If you go at the level of the coracoid process, that is somewhere in mid this thing. And if you go lower down into the axilla, the base of the axilla, and that is your classical axillary block. So I think if you know these blocks for upper limb, you're well enough. So this covers the whole of the upper limb and the head and neck as well. Then we move out to the anterior chest wall. I think all the PAC 1, PAC 2, serratus anterior, this, that, I think it's a waste of time, to be frank. If you want really good analogies here and you want to know, obviously there is So I would actually go onto the back and say, I think you need to know how to do a thoracic paravertebral block, and erector spinal block is just one step. So when you did, a thoracic paravertebral block using a needle, all you did was you hit the transverse process and you walk off inferiorly at 1.5 centimeters. You needed to actually hold that needle and go in. And that's what you did. Somebody yesterday was talking about a midpoint of this. Yes, I think a lot of blocks were not exactly in traversing the superior costotransverse ligament. I don't think you ever pierce it all the time. Sometimes you're depositing, localizing that area. And erector spinal block is just you hit the transverse process and you inject local anesthetic. That's what is erector spinal block is. Nothing again fancy. You can do it with a needle and a syringe filled local anesthetic. Coming to the abdomen, I think if you know how to do a tap block and rectus sheath block, you can cover more of it. Yesterday we were talking about the BD tap, which is basically giving tap on 4 sides, but we're talking one side is BD. One under the costal margin, one above the iliac crest. Classical areas, you cover most of the abdomen. If you're using ultrasound, you can use rectus sheath block for the ZIFU to umbilicus. And if you give local anesthetic at the, just in the tap plane over the iliac crest, mid-axillary line, the classical area, you would cover mostly T10 to L1. You go a little posteriorly, and that's towards the initial, which Peter Hubbard described as the transversalis fascia block. That's a posterior tap. It works as good as any other quadratus lumbar. People can call quadratus lumbar 1, 2, 3, 4, doesn't matter. You give it there, you get a pretty extensive spread. So know how to do tap block, rectus sheath block, you have covered the abdomen. Coming to the limbs, okay, the blocks you need to know is femoral nerve block, and then you can move down to erector canal block, which will cover most of your anterior part of the thigh and saphenous on the medial side of the leg. But for your posterior part, posterior compartment, you need to know how to do a sciatic block, whether it is a proximal or a popliteal fossa, depending on where the surgery is. If this was going to be a PNS guided block for the lower limb, I would actually say just 2. If you know how to do lumbar sacral plexus block, you can block most of it. But that is, I think these are advanced and deep block. So if I were to actually summarize the whole thing, so looking at the blocks in the neck, this is what the images I would actually put in. So you do cervical plexus, interscalene, supraclavicular, axillary for the upper limb, and then head and neck. Then you come to the back of the thorax. There you can erect thoracic paravertebral or rectus spinae block, abdomen, tap and rectus sheath block, lower limb, femoral, adductor canal, and maybe sciatic. So these are the 10 blocks which I think are enough to do most of the surgery. Rest is all, show off. It's all for publication. It's for name and fame. Over to you, Guru. These are also some of them described. So yeah. Yep. Sorry, I need to stop sharing.
Yeah, thank you.
Yeah. I think we were there. I think except for the added few blocks. Yours was 7. I put it at 10.
Yeah.
So I think we were almost there.
Yeah. Look, thank you very much. I think you described it really well. I think the whole context being, being able to provide no patient should be denied analgesia because of your lack of skills. Now, a lack of skill to do a complex retrolaminar block is not required, but a lack of skill to do a simple block which can provide analgesia is something not, may not be considered as acceptable at the standard of care. So look, every surgery can be done with a bucket of opioids and ketamine and all dexmedetomidine and all those things. But we all know of the benefits of regional anesthesia, be it within the OR setting or outside OR setting. So now coming to what top 5 to master. Now, when the word master comes, again, we need to question what is expertise, how to achieve it. And Shiv thankfully talked about it, so I don't have to talk too much about it. So defining expertise, I would divide it into 3 parts. It's about knowledge, skills, and attitudes, and to large extent, you will learn all these 3 aspects when you attend a live workshop also. Much of this cannot be told as a didactic session. So I suggest people to attend the TACON if possible. If they can't attend the TACON, and if they live in and near Bangalore and Bengaluru, and you should attend the Pure 2022 workshop. Now, most of the didactic sessions are covered here. So all those 1.5 to 2 days is purely on improving your skills and attitudes, and you will understand how this can be achieved. So what is it about knowledge? Knowledge is not just knowing, I still go back to my first year residency, where the first thing I was asked to do is write the brachial plexus branches and how it joins and things like that. It was good, but it had no relevance to my actually practical performance of the block. Actually, even when the ultrasound came, it was very hard to correlate drawing a 2-dimensional on a piece of paper to actually seeing it in a on patient, using an ultrasound and things like that. So it's not just about knowledge of anatomy, it's knowledge about sonoanatomy. It is knowledge about the variations that happen. It's knowledge about the machine, the PNS, the ultrasound, and knowledge about pharmacology. So it's just not about simple knowledge about the basic anatomy. It's about knowledge about your patient, what the patient has got, right selection of right patient. It begins from there. Skills. Now, how quickly you did a block or even a central neuraxial block. A lot of the time I've seen, even on the Facebook group, I've seen many disappointed anesthetists that their achievement of skill rate of getting spinal, I failed it so many times, I'm very dejected, I've failed at this. Skills are not just about doing a block in a single shot or a single attempt. It is about the understanding or the feeling, the feelings of passing through the ligament, the feeling of pop, the feeling of the tissue, and the smoothness in your needle insertion. If you're learning to be an expertise in ultrasound, it's about your hand-eye coordination. It's about your ability to minimize the needle entries, the ability to be correct location. I'm not a proponent of intraplexus low volume regional anesthesia, especially when you are trying to develop your skills and trying to master. The reason being is that you enhance the risk of nerve injury. Sometimes acceptance of analgesia in the form of just a periplexus, large volume local anesthesia can be better than trying to achieve that low volume intraplexus injection. About attitudes, it's about empathy towards the patient. It's about communication with the patient. It's about all those things that I talked earlier, telling them about what to anticipate, telling them about what to do, in terms of rebound pain and all those things. Attitude is also about team working skills, communication with your team and not just with your patient. So she already went through that. I put it this new nomenclature myself now that I've got this number needed to be expert, and it's hugely variable. Now 20 to 30 cases with success rates of 70% is somewhat literature says. And look, logbooks are not sufficient. You need to have an audit or a proper database with more accurate data. And PNBs have got the highest learning curve. You will understand by this learning curve, I can go in length, but because of, we need to get on with our lectures, we can go through this. There are enough number of articles explaining the learning curve, how quickly you can achieve that proficiency of a set number, be it 100 cases, 200 cases, or 600 cases. And there is also not just about having done a number, but it's about continuity of providing that number. So finally, my word for that top 5 blocks that you need to master is, I would put it as brachial plexus because you need to know interscalene, supraclavicular, and axillary based on the location of surgery, based on possible anatomical variation. Now, when you want to do a supraclavicular, and if you see a straight artery coming out right through the plexus, you should be able to understand that, yeah, look, I need to know another technique or another site to do the block to provide the same analgesia. With the lower limb, I would go with femoral fascia iliaca, ACB, adductor canal block. I would put it at the lower grade. Popliteal sciatic, yes. Now, the reason I say a fascia iliaca block is that it does produce relatively consistent, although not as great success rate, but it can be given anytime, anywhere, and the success rates can be achieved better and it's got a much steeper learning curve. So I believe it can be provided anywhere with minimal equipment required. That is another criteria, that a patient in a periphery, or if you find a patient in trauma lying outside somewhere in the road traffic, you can provide analgesia right there if you have a syringe with a needle, with a local anesthetic. Trunk and abdomen. Now, throughout this, be it chest or abdomen, I believe you should know the erector spinae block. That will simplify the whole process. You don't necessarily need to have ultrasound, but if you have, it may improve efficiency. So you can give erector spinae at the lumbar level also. Possibly, I would add tap and rectus sheath, but if I have given a choice of 5, I would go with erector spinae. Thank you.
Guru, something which reminded me, because you actually talked about fascia iliaca block, and there was there was a ASA meeting recently, and also our meeting, and people actually posting about SIFI, suprailiac fascia iliaca block, and I'll look at it. I said that's another invention of the ultrasound. You wouldn't go suprailiac without ultrasound. But does it provide any better analgesia than a infrainguinal, the usual standard fascia iliaca block? Probably not. Okay,
probably it may, but having said that, would it achieve proficiency among large group of anesthetists? No. Is my question. For me, no. If you take around 1,000 anesthetists, right, and if you teach a simple fascia iliaca block versus a suprainguinal fascia iliaca block across these 1,000, now how many of them would become proficient much more quickly in doing a simple fascia iliaca block compared to the suprailiac fascia block, where sometimes you may even have to bend the needle to achieve that continuity in plane. So from that perspective, look, I think a simple fascia, it may, I don't know the evidence, it may provide better success rate, better coverage, but I think, does it serve the purpose for a great large mass of anesthetists and for the patient is what is questionable.
Well, it's just shown that it still goes over the iliacus muscle, because you're suprailiac, so it'll spread iliacus, it'll give you a femoral lateral cutaneous, and that's what the other do. Maybe a small percentage, it might give you a obturator nerve with a medial spread, but again, not highly proven. Anyway, I think with this, I think we still have got few minutes. If people want to ask, I don't see any questions on the YouTube, but if anybody had any burning questions.
I think Preet mentioned about Plan A blocks. Can you talk about it?
No, I did. That's why I did put the last one of the slides, which was Plan A block, which has got seven blocks in it. So those are, we have covered. They are the Plan A blocks, and these are the blocks which I think most people need to know and master. Once you have developed those skills, I think people get dazzled by all this new terminology and new blocks, and it's like, do I actually? That comes with a little bit of experience, and maybe once you become a little wise, you're not going to run to and get the latest phone and you say, well, my 3 years phone works very well. I don't need to spend that extra money on that. So it's all about, how wise you become with time. But anything which is new is going to attract the attention of people. Anything which is sounds, sexy, they would So all these acronyms based on that. And again, how much chatter goes on the Twitter and other social media, that also attracts. But again, I had said yesterday, thing is that some of the social media things, I think, except for like our Facebook group where we actually talk about all kind of things, something like Twitter, they are actually just like, they would never ever actually talk about PNS guided block or landmark guided block. People will be looked upon if they're doing it. And we have to look at the real world. There is no real world data. And in the recent the meeting we had in Liverpool, British Association of Indian Anesthetists, we had one of the RA UK council member giving a lecture about what's new in regional anesthesia. And she put up a chart, and all the data was actually from the Europe, from US and Australia. There was huge area which was, there was no data at all. So there's no real world data available to compare.
To be honest,
yeah,
what you see in this literature is also actually not real world. You know, even the literature that comes out of from developed nations is actually not real world. You know, so the question about real world data is itself, you know, there is a lot of ambiguity there. But yes, as you said, real world is what we need to cater to. You know, our patients are real. Our society infrastructure is real. And we need to cater to those people and not try to look. On one hand, yes, we need to develop a culture of innovation and development of new kinds of blocks that may improve safety. Otherwise, there wouldn't be something new. Erector spinae block wouldn't have come into the picture of what we are talking now. But then we need to draw a line somewhere and question about practicality, simplicity, and applicability and consistency. You know, if you look at those aspects, then you choose a block and a technique. So I won't hesitate to say that I don't do those blocks. I don't do any of those retro. I don't do those things. It is okay. It is a lot of the time that acceptance that it is okay to do normal, simple blocks, common man blocks is what we need to understand, that it's okay. You know, you can still be called an expert, but I might not get called an expert. I don't care, but because I might not do all those novel blocks, but it is individual's perspective, but they should start to look at what they provide to their patient in their resource settings.
One point I want to actually just highlight is that if you were to actually look at those blocks, I mean, we talked about the 10 blocks and 5 or 7 blocks, which are important, or plan A block. You need to actually be mindful when people actually talk about them, is that there are blocks, certain blocks, which you cannot actually do without ultrasound. Do they then apply to the whole of the real world? You know, some blocks can only be done with ultrasound. They cannot be done otherwise. So the blocks.
Can you give me an example?
Universal is that.
Can you give me an example?
Like retroclavicular block.
All right.
Retroclavicular block.
I don't know. I don't
care. And those blocks. Yeah, the blocks. They anterior chest wall block somewhere, and one facial block, small space block, and things like that. When we
talk about these blocks,
they should be all be universal. Yesterday I put up a slide. Yesterday I put up a slide of all the blocks, because there is a editorial where they are now talking about we need to simplify all the spatial blocks. We need to have a standard nomenclature for the blocks. Can we give it below the intercostal muscle? We can give it above that, below that. All those kind of things are actually
inside that.
Yeah. Or we would be puncturing the pleura. So why are you using ultrasound? There's the whole idea of using ultrasound is that you're not able to puncture the pleura or vessel. Okay, then why do you want to do it? So those kind of things, we need to actually be very specific that a block is a block which can be done either ways. You can, whether landmark, PNS, or ultrasound. Rest of the blocks should be like consider as, these are only for a certain group of patients. Anil,
Yep.
yeah.
Yes.
That's all.
The purpose
Really?
of this session was the same, because with the advent of ultrasound, there are many new blocks which are coming up for the same kind of surgeries. I mean, the surgeries aren't developing, but every day there is a new block. But my point is, with these new blocks, are we making the things complicated? When we can deliver a simple block with the same outcome, with the use of an adjuvant which can prolong for a quite a duration of time, whether the ultrasound now is making things more complicated?
The answer to that is both yes and no. I'll let Dr. Somnath speak about it.
I in a way agree with what Anil is talking about. I think a very important principle that's guided my clinical practice is the KISS principle. It's keeping it simple and stupid. It's you do the simple things that work, like Guru, you were talking about, just maintain, do the same thing again and again, become an expert, make sure you're consistent, make sure it's predictable, make sure it works in all circumstances. For example, you may be an expert in ultrasound guided blocks, but there will be one day you drop your probe and the probe's gone and you can't do anything without it.
Yeah.
Then you just can't, right? So these are things that will happen, and you then are completely handicapped. And I think it's better to be an expert in a few things than try to become an expert in hundreds of blocks. And as long as the outcomes are the same, a lot of this can be achieved, with a few blocks, as you guys said. It's, I take this last session as a fantastic conclusion to the entire, nearly 12 hours of lectures and everything else that we've had on regional anesthesia, because we'll now be moving away from regional anesthesia onto POCUS. So amazing concluding remarks from the two senior most faculty in this group, Shiv and Guru. Thank you very much. Really appreciated this last lecture.
Thank you.
Thank you, guys.
I just want to add one last thing. I suggest every viewer to attend the workshop to make the best use of it. TACON 2022 in Hyderabad and Pure at Bengaluru, November 19th and 20th, because that is where we'll focus on helping you to learn it practically and become a master as soon as possible. And in those things that will work for you in the best. Thanks.
Thank you, Shiv and Guru. We'll move on now to the POCUS presentations. We have with us Dr. Mohan Kamaraju. He was one of our colleagues, and he'll be talking to us on ultrasound in difficult venous access and arterial cannulation. Dr. Mohan is presently senior consultant, intensivist and anesthetist, and he is present. His areas of interest include sepsis, ARDS, neurotrauma, staff training, ultrasound focus, megacode leadership. So, Mohan, hand over to you, ultrasound in difficult venous access and arterial cannulation.
Okay, is my screen visible now?
Yes, yes, Mohan, go ahead.
Okay. Good afternoon, everybody. The topic assigned to me today is about having vascular access. With the ultrasound, life is more easier, as we all know. So firstly, I'll go to the veins. Central venous catheterization, I will not go too much in depth with the the procedure itself. I'll try to focus more on the ultrasound aspects. CVC device is a catheter that has its tip located in the SVC, and or the RA or the IVC. It can be placed via access in the proximal upper extremity or in the neck into the thoracic central veins, which is the internal jugular vein subclavian, or through the external jugular vein, which is very uncommon, and placed via access in the groin into the abdominal central veins through the femoral vein, or very rarely through the great saphenous vein. Peripherally accessed central lines are also done, and access is commonly through the basilic vein and sometimes through the cephalic vein. And again, brachial vein is also slightly uncommon. Advantages of using the ultrasound: one, we get to choose the most appropriate vein by doing a scout scan before the procedure itself. And to determine the presence of any anatomical variations, those who have used ultrasound for the vascular access, they know that anatomical variations are quite common. This is the reason why when we do the routine non-ultrasound method, there is a failure or multiple attempts are required. With ultrasound, again, the number of attempts are also reduced. And it helps us to rule out the venous thrombosis, especially in patients with multiple lines before, or the hemodialysis patients or oncology patients. And another thing is we are able to reduce the arterial punctures, which is very important, especially in patients with bleeding diathesis. In the intensive care, especially, we get these sick patients who have a higher risk of bleeding with all kinds of bleeding and clotting variations. And one more thing we can do is check the progression of the guide wire itself and the catheter, and to see the tip and navigate it to the correct place. And we can also rule out puncture-related early complications, which is a pneumothorax or a hematoma. And you can also assess the tip of the central line by the using the echo when we are doing it for the upper limb. Limitations are ultrasound resolution is decreased with increasing depth. So in a morbid obese patient, it can be slightly difficult. And subcutaneous emphysema will preclude good ultrasound visibility. And in a volume depleted patient, the venous caliber is small. So just even the weight of the probe itself can collapse the vein. One should be cautious and try to fill the volume for the patient, or go for a Trendelenburg position if it is clinically feasible. And ultrasound needs a good training. One needs to know how to handle the machine itself, the knobology, the physics, and then about the central venous catheterization itself. But one thing is that it has a very rapid learning curve. With quite a few number of procedures, one can achieve great proficiency. The transducer used is usually the high frequency probe, which is the 5 to 10 megahertz one. And in facilities where the hockey stick probe is available, that can be used in children or for the subclavian venous access also. And ultrasound evaluation of the vessels itself, the lumen is normally anechoic, black, surrounded by a tissue which is gray in color. The veins are usually oval, and they have thin walls and are easily compressed with light pressure. Arteries are circular, thick walls, and less compressible. But in a hypovolemic patient or in a patient with shock, it might be difficult to differentiate, especially with a low pulsatile pressure. And veins are non-pulsatile. I'll just show a short clip. On the left side and the bottom, that is the vein. With excess pressure, you can even compress the arteries. So one should be mindful of the pressure being applied. Veins may show valves sometimes, mistakenly taken for DVT, but that can be further confirmed by panning and scanning the vessel, or go for a longitudinal view. And veins have to be distended with maneuver like Trendelenburg or Valsalva, and tourniquet when we are doing the PICC lines. And arterial diameter will usually remain the same. Doppler, to identify whether it's artery or vein, you can get that pulsatile noise. In the venous, the flow is much steadier. Color interpretation is not recommended, But one should know that the red is towards the probe and blue is away from the probe, and it has nothing to do with identifying whether it's an artery or vein. So it depends on whether you're pointing the probe towards the heart or away from the heart. You can make out that the Doppler has been placed over the artery, and we are getting the pulsatile noise. Whereas in the veins, you just get a constant whoosh. There is a slight pulsatile sound that is from transmitted pulsations. Ultrasound views in plane approach is used for subclavian and PICC lines. Out of plane approach is routinely used for the internal jugular vein or the femoral vein. And planning the exit site for the ultrasound is also very important, especially when we are doing the internal jugular vein cannulation. Out of plane approach, we'll end up with a slightly lower site, and it will be prone to infection and difficult to do the dressing, and it can also end up with dislodgement. And one more thing is with the out of plane approach, we get a higher chance of perforating the posterior wall of the vein also, because we are not seeing the full length of the needle here. So here on the top, we are seeing the out of plane approach, where we are seeing the needle in the center of the vein here. And this is the in plane approach, where you get to see the length of the needle. Of course, the orientation should be good. Otherwise, you may still get a cross section and mistake it, and you can still hit the posterior wall with this. Preparation. The most important thing is to use aseptic precautions. Sterile technique is very, very important. This is the reason why one needs to observe, and then start to do those procedures by assisting, and then get supervised, and then do it independently. Because most of the mistakes happen with the sterility, because people are overwhelmed with the technique and using the probe and doing the dressing for that, and all the needles and guide wires. Sterility should never be breached. That's why I stress the second point also, that aseptic precautions and sterile technique is very important. Hand washing, of course, and using the PPE, maximum barrier precautions should be used. The whole of the patient is ideally draped and leaving a small opening for the focus of the area being, where you're doing the procedure. Ultrasound cover, another assistant is there to apply the gel to the head of the probe and avoid any air bubbles or gaps in between. And then we put on the probe and try to squeeze out any excess air around. And then we also need a sterile lubricant gel. It can be even saline or chlorhexidine also, which is readily available when we are doing these procedures there. Skin antisepsis, use the routine 2% chlorhexidine with alcohol. A scout scan is done first to find out any thrombus again, and the intended site of puncture. Procedure, center the object of focus in the center of the screen. Here the vein is centered, and a local anesthesia is also given with the ultrasound guidance once you have decided your puncture site. And the needle is introduced and advanced under visualization. And here the most important thing is, when you put the ultrasound probe on the skin, you need to note the distance from the skin to the vein. And even when you're going at that 45-degree angle, you should never cross too deep into the skin. If you're not able to see the tip, you have to move the probe till the tip is visualized. Do not move the needle. And especially once the needle is inside, do not horizontally move the needle, because you may nick the vein. The needle tip is quite sharp. It can nick and cause unnecessary bleeding, and nurses will end up continuously doing the dressing once your procedure is over. And the point which I stress now, assess the depth prior to insertion of the needle. And post insertion of the guide wire, it is very important to pan through the vein as far as possible to confirm the guide wire position. It is not that you just see that it enters the vein and you let go of it. You have to go deeper and see whether you have punctured the posterior wall, it has come out, or it has come out and gone into the artery again, because we don't want to cause an AV fistula there. Confirmation is very, very important before dilating the vessel. And lastly, locating the tip by echo after the procedure. Here, out of plane scout scan and in plane scout scan before the procedure. One more thing, what I commonly do is doing the scans just before the procedure. I don't use the ultrasound jelly, which is a little messy to clear. You can use the chlorhexidine itself, so that you don't contaminate the site, unless you scrub it well. Here we can see the guide wire on the left side of the screen, going well through the vein, and this is the view when you have the in-plane approach. The second picture shows the guide wire, and this is the out of plane view where you have to go down and pan it as much as you can. We scan and identify where is the artery, where is the vein, the relation of it, for any anomalies also. This is the ultrasound method for the subclavian venous access. We can see the needle entering the vein. And always have the negative aspiration technique, so that you can see the flash of blood as soon as you enter the vein. Sometimes you may miss the tip going into the vein. At least you can note the flash of blood and stop instead of going too deep. You can see the good flash of blood. There should be a good easy flow. Once you get the good ease of flow, drop the ultrasound probe. Do not move the needle. Hold it gently but steadily. Your guide wire should be close to the procedure site and not be difficult to reach. Otherwise, you will displace the needle tip. So, threading the guide wire. Next would be, of course, confirming the guide wire before the dilatation. You can see the guide wire below. Then coming to the arterial access, it is commonly not used because it is easier to get it we are doing clinically. But when you have a low volume pulse patient, septic or hypovolemic, and you quickly need to resuscitate, know what are the exact blood pressures, instead of ending up in an arrest situation, arterial line will guide you very well compared to the non-invasive blood pressure. And always prefer the non-dominant hand radial artery as a first site, and then the other hand, and then you can go for the femoral as the next site. and never use the brachial unless you don't have any other option. Femoral gives good accurate values in patients, especially on high supports of pressors. And for the arterial access, usually in plane is preferred compared to out of plane, because the vessel wall is also thin. You need to be mindful that you are not going to do a posterior puncture. And you may be doing these procedures when you don't have values of the coagulation parameters or the platelet count. So always you need to be mindful of the depth and position of your needle. What you see on the ultrasound, and also what is expected, where the tip is lying, you should be having that picture in your head. Indications, when it is difficult to palpate, there are no absolute contraindications here. Identifying the appropriate site is very important. An untrained or an inexperienced person is a relative contraindication. Preparation, it should be sterile, the same as you would do for a central venous catheter insertion. One should not take shortcuts thinking that arterial line sepsis is lesser. The frequency and the incidence is, in some studies, comparable to central line insertion site sepsis. Positioning, supine with outstretched hands, especially when you're doing on the left side, you should try to get in between the patient and the outstretched hand, so that your non-dominant hand is proximal and your dominant hand is distal to the patient, and it is easy for you to insert and thread the needle. Of course, use a local anesthetic like you would do with any other arterial cannulation. And always prefer the arterial cannula. Do not use the IV cannula. It may look similar, but it is a little more thrombogenic. So the arterial cannula is very important. You don't want to end up with the ischemic hand and have a prolonged discussion with the family. And finishing is very important. It is not doing the procedure and running away. All the sterile connectors need to be connected instead of having the nurses scrub up and do the same thing again. Since you are already sterile, this needs to be done. This will reduce your infections. All the IV fluids, pressors, and whatever reasons you connect, you inserted the central line or the arterial line, it is good for you to connect that and apply a transparent dressing, which is important so that we can watch later for infection. Successful procedure is not just the procedure itself, the indication for the procedure, and going through the process, trying to avoid all the complications, and post procedure monitoring the patient, that is also very important. And also during the procedure, you will be having a lot of sharps. It is very important that you personally dispose them off into a bin, because you know where you have kept the needle, under the bowl or under the tray, wherever it is. We should reduce the incidence of housekeeping accidentally getting pricks with these needles which we just left around, and leave the site very clean, not messy. It is uncomfortable both for the patient and the nurses. Once you use ultrasound, the amount of bleeding will reduce, because the number of attempts also will reduce, and you will identify the vessel also easily. And talk to the patient always when you're doing the procedure and after the procedure also, because any procedure is maybe just a procedure for us, but for the patient it might be great agony. You need to keep the patient comfortable always, and observe for any immediate complications. Hang around, and if you have trained staff, you can let them know what to observe for. And pulse oximeter on the same limb, especially when for the arterial line, it is important so that you can monitor the wave amplitude and identify any ischemia and take measures before it goes for a flat line. And all these lines are unwanted foreign bodies. It should be removed as soon as possible when they are no longer required. Just inserting the line, like I said, is not important. You should know how quickly to get it out also, because the patient comes with a disease and should not end up with disease going away and being left with a complication. And never change over with a guide wire unless it was a very difficult procedure. You are untrained. You don't have any senior to come and help you over, because this can never be done in a sterile manner. It's very difficult. and rarely use the brachial artery side. If at all you're using, use it only for a short duration during the resuscitation. Once you have the perfusion going well with the resuscitation, you should try to switch over to an alternate side, which can be the radial or brachial. And when you're using this brachial, it is very, very important to personally monitor the limb perfusion. And before doing any procedure, one should learn to identify the complications and have an idea about how to get a remedy for that also. Go steadily forward. First step, learn the theory, like what we are doing with this training. It's very wonderful. Observe people doing it. Here, the most important part is the sterility part. Then assist a good senior who is doing the procedure well. Learn all the nitty-gritties, and then only you can go for doing it under supervision. And like Hutchison said, from making the cure of the disease more grievous than endurance of the same, good Lord, deliver us. With this, I conclude my talk.
Thank you, Mohan. Very detailed, very elaborate, very thorough, as you always have been. Thank you very much. We'll just briefly open for questions because we are a bit ahead of schedule. So if anybody has any questions, we'll take them now.
You can stop sharing your screen, please.
Mohan, if you can stop
yes,
sharing.
yes.
Yeah, thanks.
Thank you.
Question, sir. I have a question.
Yes.
Most of the times I come across posts on Anaesthetist group, as well as I had this problem where the guide wire crosses from IJV to the subclavian or to the other side of the IJV. So are there any tips to reduce that kind of malpositions?
It's very difficult. It happens randomly. You can just check with the ultrasound probe regarding where it has gone and try to reposition it. The correct side of the guide wire should be used. The bent side, which is the softer one. And if there is any thrombus, usually this happens when the patient has had multiple HD catheters or has had a prolonged stay of 4 to 6 weeks with multiple central lines. Particular tips, I don't know if anybody else can help.
So this, Mohan, when you try to put a subclavian and then it goes into the IJV, there is some evidence that rotating the head towards the side of the procedure and maybe angulation of the head may prevent. But again, as you said, it's random, not often predictable. And my question is, even if it does, what's the problem?
Yes.
Yeah, it's still in a central vein. The purpose of the drug is the line is we rarely use it for central venous pressure monitoring. We mainly use it for giving drugs. Even if it goes in the opposite direction, it doesn't matter. And the most often what will happen is as the plastic or the polyurethane becomes softer, quite often it will migrate back. So just doing a check, a day or two late, in 6 to 8 hours, quite often the line will migrate. So that's my take on that.
Most of the times we just leave it as long as it is in a big central vein, like you said.
I actually received a comment from someone who does a lot of CVCs. He has advised if we face the bevel, if we keep the bevel towards the heart, most of the times the guide wire goes towards the SVCs, what he says. But I have yet to try that aspect. And one more question I have for all three of you, including Dr. Shiv. If there is a valve, suppose you are doing IJV, right? And if there is a valve, you go proximal to it or you go distal to it, the puncture site?
You can go proximal. There is no contraindication.
Okay.
No reason to change it for the purpose of the valve, because once your catheter is put inside, it goes through the valve and there won't be any problem with tip getting blocked or the lumen opening getting blocked. because the tip is far away from the valve actually.
Go ahead, Shiv.
Yeah, one thing about that bevel makes no sense at all because it's quite proximal and your guide wire actually has got soft thing. It is going to curve, so it makes no sense. It's not going to guide the guide wire into the right place. But if you are, there are two things which I would actually, I wouldn't say suggest, but at least look into. If your guide wire is actually going into the other side, if there are no anatomical anomalies, sometimes go into the history if that site has been cannulated before. And the clot formation organization with a small lumen in it sometimes actually prevents the guide wire going to the right direction. We see this very commonly in renal patients, and they would have had cannulation done. So when you do a scout scan, just don't go, because you'll have a big vein. You get excited about it, especially, I mean, I do most of my lines, whether it's arterial, central, inline, so I actually see it. But most people tend to do a cross-sectional, puncture or the autoplane technique, where they'll find a good vein, they get excited about it, go in, get blood, fine. Because proximally it is constricted, you'll have a large vein. But if you do scan it all down, even if you're doing a out of plane, and make sure there is no thrombus or organized thrombus, which can prevent that. So there are chances where the guide wire actually can coil itself and go up as well. That has also happened. So we have seen, I think, almost everything. And like I said, I don't think there is any particular way of thing. Yes, with subclavians, we always did that. You're right, absolutely so. And when we were doing subclavian, we were actually told the patient is awake, ask them to turn their head towards you so that it doesn't go up. That was a practice thing throughout. But with internal jugular, most of the straightforward course, it should actually go into the superior vena cava into the right atrium. So I don't think that's a problem most of the time. So it's usually with the subclavian which can happen. Yeah.
So I'd just like to add a couple of comments. What happens when people are learning to do ultrasound guided central lines, they become blind to where exactly they're keeping the probe. And I think it's very, very important to still remember the anatomical landmarks and keep the probe at the level of the cricoid so that you're not too low down. The other simple thing I say is make sure you don't, when you're learning, you're focusing only on the screen and you're not seeing how far your needle has gone. So just make sure you don't cross more than 2.5 centimeters. If your needle is gone more than a standard IJV needle is about 8 centimeters. So make sure you don't get more than 2.5 centimeters of it in. And these are just some of the simple principles that I follow. And as Mohan said, don't dilate the vein unless you've confirmed the guide wire is gone in the vein. Though Mohan did show about cannulating the subclavian vein, I wouldn't, it's an advanced venous access. It's not for people in their early part of their learning curve. They must be able to be proficient in inline blocks and being able to monitor the needle the entire length before they go, because with the in-plane subclavian cannulation, the problem is the angulation of the needle is towards the pleura. So there is a possibility that you will, if you're not monitoring the entire length of the needle, that you will go past the posterior wall of the vein or go beside the vein and end up in the pleura. So it's just something that you have to be really proficient in. If you're doing a blind subclavian, you're going parallel and heading towards the suprasternal notch, whereas with the in-plane subclavian, you're heading directly towards the chest. So that's just a caveat. Don't do that. It's not for early part of your learning process. Yes, go ahead, Shiv.
With the subclavian, it's actually more, with the ultrasound, it's actually an axillary vein you are going to cannulate. And so you are a little bit more kind of proximal. I'm not talking proximal to the heart, but as a venous return. It's proximal venous return. So it is actually gets safer as you go from there, and you can use a longer cut. But the problem happens with, instead of going to right atrium, going to the other side, that will remain. The problem will remain. You can't actually do much about it. The other thing, which I don't know whether Mohan you mentioned or not, one of the things where you can't have patient, head down or whatever it is, using Valsalva maneuver. Okay. Or if the patient is on tube, increasing the PEEP or will also increase the volume of the vein and will help you with easy cannulation, especially if you have got patients who are hypovolemic and in shock. Increase the PEEP on the thing, you will likely have vein distending, or use a Valsalva maneuver, which can be done again with the bag or awake patient holding that, increases the size.
Just another small thing that we follow in the department is if we have somebody who's on very high vasopressors, somehow you have an arterial line in the radial artery, quite often it will not reflect a true blood pressure because the artery is under so much vasoconstriction because of noradrenaline. And quite often we will go in for a femoral line that's a bigger artery and doesn't constrict as much to noradrenaline. And the blood pressures may be very different. So it's just something that we do quite often.
Okay, I think there isn't much then, and then.
So anything you would like to add, Mohan?
Would you recommend routine?
Nothing, sir. Just like you said, common sense very important, and that needle depth never more than 2 centimeters or 2.5. Because always commonly that we see the first 3 or 4 times somebody has learned ultrasound, they would have gone the entire depth of the needle and they're still not finding the tip.
Yeah.
And it gives us a shock at that time.
Okay, thank you, Mohan. Lovely videos as well. We'll now move on to Dr. Bhargavi. She'll be talking to us on EFAST and DVT. Anil, if you can kindly just pull up the screen. Thanks. So Dr. Bhargavi is one of our consultants in anesthesia and intensive care. Her main areas of interest include infection control, trauma, and ATLS, and medical education. Over to you, Dr. Bhargavi.
Good evening, one and all. Just see my screen. My screen is visible?
Not yet, Bhargavi.
Bhargavi, if you're having problem with the connection, if you actually switch off your video and only talk, then it'll be better.
Just keep your Great. We can see your screen. Proceed.
Thank you. So I'll be talking about EFAST and DVT screening. When we say EFAST, the thing that comes to our mind is ER and trauma patients. That is where it was first used for. EFAST is extended focused assessment with sonography in trauma. It's a bedside ultrasonic protocol designed to detect peritoneal fluid, pericardial fluid, pneumo or hemothorax in a trauma patient. Initially, it was the FAST scan that where 4 areas were screened. That is the pericardial space, perihepatic, perisplenic, and the pelvic area. Then we added on the extended FAST, which additionally surveys the anterior and lateral pleural spaces to evaluate for pneumothorax or pleural effusion. Now, applications beyond ER and trauma, where do we use this EFAST? These are some of the cases that we had in the last year. A 65-year-old gentleman with known diabetic and hypertensive, he underwent TURP under SAB with intrathecal morphine. Intra-op, he was hemodynamically stable. Just at the end of the procedure, he developed sudden onset bradycardia, vomiting, diaphoretic, feeble pulses, and BP not recordable. He became confused, agitated. So quickly we got the ultrasound machine. We kept it in the pelvic area. There was free fluid. There was bladder perforation. The next case, a 50-year-old diabetic, morbidly obese, with posted for lab cholecystectomy. Her room air saturation was 92, 93. Chest X-ray done, which was normal. Echo normal. Breath sounds was diminished bilaterally. She was obese. Bedside, we just took the ultrasound machine and we saw there was right-sided effusion. Again, we had a renal donor with no comorbidities. Post-extubation in the ICU, he started having increasing oxygen requirements. He became tachypneic with borderline blood pressure. Again, bed sound, we did the ultrasound and it showed pneumothorax. So what is the TAT for a bedside chest X-ray or getting a CT done? I'm sure it's somewhere between 10 to 30 minutes and even 1 hour in a very busy radiological setup. Whereas with an ultrasound, it is going to take just a couple of minutes, just 2 to 3 minutes to screen the whole area. So how do we do it? Again, the patient is supine, adequately exposed. The site does not actually matter. This is done in an emergency setup. Wherever you're comfortable, you just stand and screen. Otherwise, position yourself on the right side of the patient. Place the ultrasound machine across the patient within your eye line. You're not supposed to be moving here and there, seeing where the screen is. Normally, we use the low frequency curvilinear probe. For the thoracic, we use the linear probe, and echo probe is better when we are looking for pericardial fluid, but doesn't matter. With the low frequency curvilinear probe, all the areas can be scanned. Just apply the gel, wear your gloves. If possible, give Trendelenburg position with the arms behind their head. That can improve the sensitivity of examination. The areas that we scan are subxiphoid, right upper quadrant of the abdomen, left upper quadrant, pelvic, and in the lung, anteriorly, right and left, both the sides. Again, there is no particular protocol that you start from here, end here, or anything. If you're having a patient with breathing difficulty or with a chest trauma, you start from the chest. Abdomen trauma, abdomen issues, you start screening from the abdomen. Again, in a hemodynamically unstable patient, if you're having a positive EFAST, then immediately go for an intervention like a tube thoracostomy or a pericardial window or laparotomy. If the patient is hemodynamically stable, then it gives us time to go and get a CT scan. The desired area you can test. EFAST should be complete within less than 5 minutes. It hardly takes to finish the whole scan. Coming to the areas that we scan, right upper quadrant, that is what we usually start when we first start scanning the abdomen. That is because the right paracolic gutter is deeper and is left obstructed than the left. So fluid will preferentially flow towards the right side. For this, the transducer is kept longitudinal with the marker pointing towards the head end. We usually scan in the mid-axillary line over the lower ribs, 9, 10, 11 ribs. Always do not just keep the probe and say there is no fluid. We have to slide up, down, rotate, and pan the whole area to check for whether there is any fluid present. The areas that we see here are the hepatorenal recess, that's the Morrison's pouch, inferior pole of the kidney into the right paracolic gutter, below and above the diaphragm. So just a video of how we scan. We pan up, down, right, left, the whole area. We have to pan and to look for presence of fluid. Normally, there might be very minimal fluid. Just by keeping the probe, we cannot identify. Again, so this is the liver. This is the liver. This is the kidney. This is the white line that you're seeing, that's the diaphragm. Above it is the thoracic cavity. Below is the peritoneal cavity. And this is the Morrison's pouch. And this is a positive FAST where we can see fluid in the Morrison space and just above, just below the diaphragm. Here, we can see fluid above the diaphragm. We can see the lung floating in the fluid. This is effusion or hemothorax. Next, the anterior thorax. Here we prefer the linear probe. If in an emergency, we can use the curvilinear probe as well. The marker will be towards the head end. We scan in the mid-clavicular line, both the right and the left side, 3rd to 6th intercostal space. Again, to look for pneumothorax, just don't place the probe in one area and say there is no pneumothorax. A small pneumothorax might not be there anteriorly. It might be there even laterally, posteriorly. So scan both anteriorly, laterally, all the areas to rule out the presence of a pneumothorax. What do we look for in the thorax? A sliding of the lung. The pleura is seen as a silver line. So the ribs, the black shadows are the ribs. The silver line here is the pleura. This is the pleura, that is the sliding sign of the pleura. That if the lungs are, if the sliding sign is present, that means there is no pneumothorax. Also here we can see small, I don't know whether it's visible, small longitudinal lines from the pleural lines. These are called the B lines. Presence of B lines also indicates that there is no pneumothorax. To confirm again, we put it in the M mode. In the M mode, this is the characteristic thing that we see. Sand on the beach appearance. This is the sand, and this looks like the wave. So sand on beach appearance, which is the norm, which is normal. Whereas here, if we see, we cannot see that the movement of the pleura is not seen. Now, when I put in the M mode, we see there is no sand. It's completely a barcode. This is barcode or stratosphere sign, classic of a pneumothorax. You reconfirm always with scanning the opposite side as well. Here I can see the pleura sliding. And when I put in the M mode, we can see the sand in the beach appearance. So presence of this barcode or stratosphere is diagnostic of a pneumothorax. As I said, we have to pan. It might not be there anteriorly. We have to scan from anterior, go lateral. We get a point that's called the lung point or the curtain sign, where the pleura that is moving will suddenly stop moving. That's also diagnostic of pneumothorax. Next is the subcostal or subxiphoid four-chamber view of the heart. For this, again, it's a transverse. We keep the probe transverse. A curvilinear probe, or if you have an echo probe in your institute, that is much more sensitive. Marker must be pointing towards the right side of the patient. Probe is placed in the subxiphoid space directed towards the left shoulder of the patient. Again, it is pressed deep inside. Depth here needs to be increased. You will visualize the four chambers of the heart will be visualized here. So this is how you place the probe, the marker towards the right side in the just below the xiphisternum, directed towards the left shoulder, deeper inside. We can see the four chambers of the heart here. The left ventricle, right ventricle, left atrium. Here is the RA. Here, any fluid that is seen here will be the pericardial fluid. Again, how do we differentiate between pericardial fluid and pleural fluid? So we can see that we can see the descending aorta on the scan. Any fluid that is present above the aorta is pericardial. Below the aorta is pleural fluid. Some things here, the pericardial pad of fat that can also be mistaken for fluid, and some pericardial cysts, they can also be mistaken for fluid. Again, we need to assess clinically and radiologically, both needs to be correlated. Next is the left upper quadrant. Transducer is longitudinal. The marker is pointing towards the head end of the patient. This is slightly more superior because of the position of the spleen, and it is more posterior than on the right side. So we go towards the little upper rib, 6 to 9 ribs in the posterior axillary line. The areas here we see are the splenorenal abscess between, again, the diaphragm and the spleen, left paracolic gutter, and above the diaphragm, the pleural cavity. So we can see here, this is the rib shadow. This is the spleen. This is the diaphragm. This will be the lung above. This is the kidney. Usually the fluid will collect above the spleen, between the spleen and the diaphragm. In the pelvis, we have to do both longitudinal and right side. You pan both the sides. You will see the bladder, uterus in the females, and rectum in the males. So between the utrovesical pouch or the rectovesical pouch, usually the fluid will collect if there is free fluid. Limitations again, this is operator dependent. It's got a high sensitivity and specificity for intraperitoneal fluid, but it does not tell what structures are involved or what fluid it is. We can have false negatives in morbidly obese patients in the presence of subcutaneous emphysema, and false positives, like I said, epicardial pad of fat or pericardial cysts. And if the patient also has a pre-existing ascites or effusion, we can have false positive reports. Again, doing an ultrasound, screening ultrasound is not a static imaging. It needs to be dynamic. Initial scan might not show anything. We need to reassess the patient after a few hours, look at the vitals, look at the labs, some discrepancy, again, keep the probe and see. That is the biggest advantage of the ultrasound. It is easily available. You can keep it at any time, and it gives us quick results. A quick word on DVT screening. This is not to replace the traditional Doppler done by the radiologists. This is a screening that we do routinely bedside in the ICUs, and the utility of this has increased post-COVID pandemic. We have seen a lot of thromboembolic complications during the COVID. So here we just look only at the femoral vein compressibility in the inguinal area, mid-thigh, and the popliteal areas. Because any thrombosis below the popliteal, we do not give more weightage to that. These are the three important areas that we scan. The advantages are it is impracticable and difficult to transfer a sick patient to radiology on a daily basis or frequently. And post a long duration OT case, it can be quickly done bedside, and it can help in early detection of a deep vein thrombosis. So this is the probe we keep in the inguinal area. We just look for compressibility of the vein. This is the femoral vein. This is the femoral artery. Vein will be completely compressible if there is no clot present inside its lumen. This is at the area of the mid-thigh. That's the femoral vein and the femoral artery. And then we screen at the popliteal area, popliteal artery, popliteal vein, look for the compressibility. This is how a clot will be looking inside. Sometimes even valves present inside the vein can mimic a clot. That's why we need to screen even longitudinally. Also, acute clots, we cannot see it in this way. We cannot see it as a whitish thing, or a plaque cannot be visible. They do not change color acutely. In that case, the vein will not be compressible. Thank you.
Thank you very much, Bhargavi. Very detailed presentation, lovely videos. We are running early, so Dr. Jose has logged in. Any questions for Bhargavi? You can take them now.
Doesn't look like there are any on the live chat.
I think the one thing that I'd like to just say here is, like she said, what are the problems with the eFast? It's very, very operator dependent, and it's very important that we gain some degree of proficiency in it, do it repeatedly under supervision before we, are making a diagnosis of no hemoperitoneum or no hemopericardium or no hemothorax in a critically unwell patient. So I think that's just something that is very important. Jose is already online.
Can you hear me, Somnath?
Yes, Jose, we can hear you. Anil, can you just put up the slide?
I think, Bhargav, we need to stop sharing a screen.
Yeah.
Are you able to see my screen?
Yep.
Not yours yet. Jose, we just have Anil putting up the introductory slide.
Okay, sure.
I'll just briefly introduce you.
Okay, thanks.
Jose, Dr. Jose Chacko is, I consider, as one of the dons of intensive care in Bangalore. He's one of the senior most consultants. I've had the honor and pleasure of being his colleague. He's a senior consultant in critical care at Narayana Health City. His areas of interest are ultrasonography, echo, renal replacement therapy, and ventilation in ARDS. And in any area of the interest that he is put up here, he's an absolute expert. I'll hand over to Dr. Jose to talk to us about lung ultrasound, as well as assessment of fluid status.
Thanks, Somnath. Is my presentation on the screen now?
Yes, Jose. Yes.
Okay, thanks a lot for those kind words. I have fond memories of working with you too at Manipal. It was a pretty long time ago. So during this session, we will talk about two important facets of care with the use of ultrasonography in the ICU, ultrasonography of the lung, and the determination of volume responsiveness in critically ill patients. So how do you go about this? First question, what probes would you use? You can use several different probes. It depends precisely on what would you like to see. If you want to see the pleura particularly, you would use the high frequency linear probe, as you see on the screen here. If you want to see deeper, you can use a microconvex probe. This probe is 8 megahertz, not available with all machines. You have to ask for it. And it's particularly useful to see the pleura as well as deeper into the lung. You could use the 5 megahertz curvilinear probe as well, but then you might lose some of the information from the superficial layers, including the pleura. So generally speaking, if you want to see the pleura, you use a linear high frequency probe. Deeper down, of course, will require a low frequency probe. A microconvex probe, if you have, will be most suited to visualizing the lung. So that's what you would see with a linear probe. You can see the pleura slide from side to side. I'm sure this picture is familiar to most of you. And there you see the periosteum of the rib, not to be confused with the pleura. As you can see, the periosteum of the rib is static. It doesn't slide, while the pleura slides on either side from side to side. This is a view from the 8 megahertz probe. And you can see the pleura and deeper down as well. With an echo probe, you can see much further down, but then you lose some of the visibility of the pleura in the process. So how do you view the lung? Just like you use the stethoscope to view different areas, there are specific areas of the lung, of the chest, that you need to demarcate beforehand to make sure that you don't lose track of what's going on right throughout the lung. So it's convenient to divide the chest into 6 zones on each side, 2 vertical lines, which is the anterior and the posterior axillary lines, as you see here, and then a line that cuts across these 2 lines horizontally will give you 6 zones on each hemithorax. And most importantly, you shouldn't forget to scan the posterior most areas of the lung, the zone 6 as it is called, which is very crucial because that's the spot at which changes occur first in critically ill patients who are supine on their backs. Be it consolidation, be it collapse, they tend to happen first here. Very often you might miss if you just confine your scanning to the anterolateral parts of the hemithorax. So it might mean you may have to turn the patient a little bit to the other side to have access to the posterior parts of the thorax. So let's begin by trying to intubate our patient. If you place the probe on the neck, just below the thyroid cartilage, you will see a tracheal ring below the cricoid. And then just to the, to the left of the trachea, you see another lumen here. That's the esophagus. So you see the trachea like that, and the esophagus just next to it on the left side. So suppose you intubate the esophagus by mistake, what will it look like? You can see the trachea here. The endotracheal tube is coming down the esophagus, and you can see it as almost like a double shadow of the trachea, almost like a reflection of the trachea, esophagus lying next to the trachea with the tube inside. So if you get this picture, you can rest assured that your tube is not in the right place, and you need to pull it out and replace it in the trachea. This is something that you could see beforehand, particularly in a difficult airway, difficult intubation scenario, wherein you expect trouble. If you keep your machine booted up by the side, you can look at it almost real time. Of course, capnography is the gold standard, but like with any other mode of screening, capnography may also have its own limitations of false negativity sometimes because the tubing may be kinked, it may be disconnected, etc. But ultrasonography will give you a real-time view. Now, once you intubate your patient, it's a good idea to scan the lungs to see where does the air go. Does it go to the right places? As you can see here, you can see the pleura slide nicely from side to side using a linear probe. And if you see something like this, what do you see here? You see the rib. Below the rib, you see the pleural line. And the pleura obviously is not moving in this particular case. Now, there may be several different reasons as to why the pleura may not slide, and we will definitely look at it. But post-intubation, one of the things that you need to consider is, has my tube gone down into the right main bronchus or the left main bronchus, as the case may be, too deep down, such that the lung may not be expanding on the opposite side. So that's, again, if you have the machine ready by the side, particularly if you expect a problem, it's always a good idea to keep the machine by the side handy to have a look and check if you have air entry on both sides. So this is actually with a microconvex probe. You see the pleural line, and what else do you see? In addition to the pleural line, you see two lines further down, which are parallel to the pleural line and at equidistance to each other. Now, these lines, as many would already know, are A lines. There is nothing there which particularly demarcates these lines. It's just an artifact of the pleural line itself. It's a reverberation artifact of the pleural line itself. So if you see A lines, that's a good sign. It means the lung is normal. It doesn't depict any particular structure within the lung. If you have a lot of B lines, they wipe out the A lines, so you won't see them. So those are A lines, readily visible in most patients, parallel to the pleural line and equidistant to the pleural line. Now that's a normal lung with a, again, 8 megahertz microconvex probe. You see the pleura fly from side to side. There is no B line visible, obviously. But look at this particular image. You have the pleural line and you see several laser-like lines that start from the pleural line, go down to the bottom of the screen and move with the pleural line. So these are, as I'm sure you're all familiar with, typical B lines that suggest interstitial fluid, intraalveolar fluid, in that part of the lung. And it may be that your patient may be volume overloaded, or there may be a consolidation. So you need to take cognizance of the fact that these are not normal. So they are, in this case, you will see the B lines are well separated from each other. They are discrete, and they are called discrete B lines. And these are same discrete B lines that you saw on the previous image. But look at this particular image. You see the pleural line, and instead of seeing discrete B lines, you see that the B lines are coalesced with each other to make it look like almost like a uniform whiteout, or the so-called ultrasonographic whiteout of the lung. So that's discrete B lines, and there you have the coalescent B lines. Which is worse? This, of course, is a milder form of fluid within the lung, and this indicates much more fluid, and your patient may well require some sort of respiratory support in this particular case. Now, what do you see here? The probe is in the right hypochondrial area. It looks like the liver, but you can see there are white streaks which seem to pass through this tissue. It is actually the consolidated lung, and you see air moving back and forth within the bronchi, which represent the ultrasonographic air bronchograms. So that's a typical feature of consolidation. But let's look at this image in this particular case. The probe is at the same spot, right hypochondrial area. You see a lot of whitish streaks like you do here. But if you look closely, these white lines, they seem to be static. They are not moving up and down, side to side as they do here. So these are static air bronchograms. Now, when do you get dynamic air bronchograms like you see here? And when do you get static air bronchograms like you see here? As I mentioned, this is a typical feature of consolidation. It simply means that there is no obstruction to the airways. There may not be any obstruction, but the lung itself is consolidated, which makes it look like tissue. And you can see air moving back and forth within bronchi that are not obviously blocked. But in this case, there is blockage distally, air is stuck within the bronchi, air lies trapped within the bronchi, it cannot move back and forth, and you get a picture of a static air bronchogram. So that is typical of collapse. This image is typical of consolidation. This is in fact a patient who came to us post-operatively. If I remember right, he had a tracheostomy, surgical tracheostomy, and then he had problems, ventilation, intra-op. We did an ultrasound before we did this X-ray, and the image that you saw is the same as you see previously. We saw a lot of air bronchograms in this case. They were static air bronchograms, and that made us do a bronchoscopy. We sucked out the secretions, and then it resulted in a lot of clearing and much improvement in the ventilation. So that's how useful it can be to instantly diagnose a problem such as collapse, which may occur within a matter of a very short time. So if you have the skill and the equipment by the bedside, it's very easy to directly visualize rather than ask for X-ray and wait for an inordinate period of time. Now, based on the appearance on ultrasonography, you can score the aeration picture in the lung. That's called the aeration score. 0 points, you assign points to each zone of the lung. As you can see, there are 12 zones, 6 on each hemithorax. 0 represents normal lung. 1 point stands for well-separated or discrete B lines, 2 points for coalescent B lines, and 3 points for consolidation. So the score ranges from 0 to a maximum of 12 times 3 will be 36. That's pretty bad, of course. So 0 would stand for normal, 1 for discrete B lines, 2 for coalescent B lines, and 3 for air bronchograms representing consolidation. And in this particular case, you can see the chest X-ray looks fairly okay, but the pleura is thickened, and you can see subpleural consolidation as well. A lot of coalescent B lines. Here again, the X-ray may be fallacious in that it may not convey the whole picture. That's what the CT looked like in this patient who had COVID at that time, long time ago. So there again, the ultrasonography may be a much more precise, much more informative compared to bedside radiography. We saw this image previously. You saw that the pleura was sliding nicely here, not sliding at all here. I know that you have seen this before. Maybe I will ask a question as to what does this represent. So that in this particular case, you can see the pleural line, but the pleura moves only in that particular area. In that particular spot, it doesn't move. And there is a junction between the pleura that moves and between the pleura that does not move, which represents what's called the lung point. And if you see this, there is only one diagnosis possible. It is 100% specific for a pneumothorax. So if you see lack of pleural sliding, it may or may not be pneumothorax. It may occur due to collapse of the lung there. It simply means that there's no ventilation happening there. Could be consolidation, could be collapse, could be air DST to any reason. But if you see a lung point like this, it is a pneumothorax and nothing else. You saw in the previous presentation that with a pneumothorax, the normal pattern of stratosphere and sea and shore sign gets wiped out, and you get a uniform barcode sign from top to bottom on the M mode. But that's not very important if you see a lack of pleural slide in a clinical situation that is strongly suggestive of a pneumothorax, such as a patient who was doing okay, suddenly becomes hypoxic, airway pressures go up, you don't know what's going on, and you see the pleura doesn't slide, strong suspicion of a pneumothorax. Or after a central line in a patient who was otherwise okay, strong suspicion. But that is only a suspicion. Lack of pleural slide is not specific. It is very sensitive to pneumothorax, but not specific. The 100% specific sign is the lung point sign. What do you see here? You see the probe is on the right side around the hypochondrial area. You see the liver, the diaphragm. You see a lot of pleural fluid. You see the lung floating within the pleural fluid like a jellyfish. This is described as a jellyfish sign by Daniel Lichtenstein, and he actually called it the jellyfish sign. It does look very much like a jellyfish when the collapsed lung floats within an ocean of pleural fluid. Once you see that, and if you need to drain the fluid, it's a good idea to do it under real-time ultrasound guidance, like you see here. You see the needle come through. You should be able to see the diaphragm here. Now that's the diaphragm, so you know the needle is actually well above the diaphragm. And once you pass your wire, it's always a good idea to confirm that you see the diaphragm and you make sure that your wire is indeed above the diaphragm and not below. So we saw several different reasons as to why your patient may become hypoxic and how lung ultrasonography might help you to diagnose the problem. In case you find in a severely hypoxic patient, the lung ultrasound looks completely normal all over, then your focus, of course, should be directed towards the heart. Does my patient have a pulmonary embolism? As you can see in this case, normal lung ultrasonography, but crossly dilated right ventricle, right atrium, and there is impaired RV contractility with apical sparing as well, which is obvious here. So that is, of course, strongly suggestive of acute pulmonary embolism. Not that you can diagnose all acute PEs with echocardiography. Of course, if it is not a major occlusion, you may not see any changes, and you might well require a CT angiography to confirm the diagnosis. Ultrasonography is an important tool when you're weaning the patient off ventilator support. There are three key functions that you need to look at when you're weaning your patient. You need to look at the lung, first of all. You do a scan of the lung pre-spontaneous breathing trial, and then later on, at frequent intervals during the spontaneous breathing trial in a situation where you expect a problem. You specifically look at the lung, the heart, and the diaphragm. In the lungs, of course, you look for any evidence of B lines that arise during the spontaneous breathing trial. And also, your patient may collapse down the lung because of reduced ventilation pressures, and that may be very obvious, as you see in this case. There's a large area of collapse that happened during a spontaneous breathing trial in this patient, which suggests that he is not quite ready, not quite there. You might need to give him a little more time. And if you score, the lung pre-spontaneous breathing and during spontaneous breathing, you can actually get an objective idea of whether the score has increased during the spontaneous breathing trial, and if you really need to go back and offer full ventilatory support in this particular patient. Very important, it's not part of this talk, of course, but very important to look at the heart. The systolic function in many of these patients may be normal, and you don't expect any change in the systolic function during the spontaneous breathing trial either. But what you really need to look at is the diastolic function. Diastolic function, of course, is a whole chapter on itself, but you look at the E to A ratio particularly, and the deceleration time, E to E prime if you have tissue Doppler, and that will give you a very important clue during the course of weaning if your patient is ready or not ready, not quite there for extubation. The diaphragm is the most important muscle in the body, and during weaning, you will get a very good impression about whether the diaphragmatic function is okay or not. In fact, you should do this prior to setting out on a spontaneous breathing trial. So that's the diaphragm as you normally see it. That's the liver, and you can see the diaphragm move in this case. You can see it move down during inspiration. Down means to caudally, and reverse during expiration. And if you switch to the M mode view, you can see the diaphragmatic motion, the upward motion of the diaphragm at this particular spot. So normally the rough ballpark number is 20 millimeters of rise or descent of the diaphragm during inspiration. Let's see what's happening in this patient. This patient had severe neuromuscular weakness, and as you can see, there is hardly any diaphragmatic excursion visible. So in this patient with very poor diaphragmatic excursion, you will not embark upon a protracted weaning trial at this particular point. The second important thing is to look at the diaphragmatic thickening. This is done with a high-frequency linear probe placed in the 5th, 6th, 7th intercostal space on either side in the mid-axillary line, roughly. You see, starting from superficial to deep, skin, fat, muscle, and then you see two parallel lines. And then you see the liver or the spleen, as the case may be. These two parallel lines with thick muscle in between represents the diaphragm. And you can see the diaphragm thicken during inspiration, and during expiration, it thins out. So that's thickening during inspiration. It has thickened to this level. So let's see that one more time. It thickened from this baseline thickness to a peak inspiratory thickness of this much. Roughly 20 to 25% is a thickening fraction in normal people. So that's normal thickening fraction. Now let's see in this patient. You can see the diaphragm. There is thickening, of course. It may not be as much as you saw in the previous image. That image, of course, was a normal patient with a normal diaphragm. Here it's not so much, but still it may be more than 20%. I haven't measured it, but it may well be more than 20%. But compare it with this particular patient. You can see the diaphragm. There are two parallel lines that represents the diaphragm, but there's hardly any thickening in this particular case. Here again is a patient, severe neuromuscular weakness. You might take a long, long time to wean off ventilator support. How do you calculate the thickening fraction? You need to measure the end inspiratory and the end expiratory thickness. End inspiratory is the thickest part of the diaphragm. End expiratory is the thinnest part. So end inspiratory minus end expiratory divided by baseline, which is again end expiratory multiplied by 100 to express it as a percentage. As I mentioned, 20 to 25% is a rough estimate of an adequate thickening fraction of the diaphragm. Can you use ultrasonography of the lung to estimate recruitment? In fact, we've been doing this in the last few months on some of our patients, and the results have been quite good in the sense that's the lung pre-recruitment. You can see there is quite considerable subpleural consolidation. And as you increase the PEEP or do a recruitment maneuver, you can see that the areas of subpleural consolidation collapse, they reduce, and more lung gets recruited. So if you are willing to stand by the bedside for a few minutes as you increase the PEEP levels and keep looking at the same area, same collapsed or consolidated area of the lung to see if it recruits, it might give you a very good indication as to whether your patient is going to respond to recruitment with an increase in the level of PEEP. So let's go on to assessment of volume responsiveness. I will just briefly go through this particular aspect of care. You're very familiar with this curve, the Starling curve, which is the preload plotted on the x-axis versus the stroke volume on the y-axis. And if your patient lies along the rising part of the Starling curve, this point or that point, you would give them fluid. And if they are in this flat portion of the Starling curve, you wouldn't give them any fluid, or should be very reluctant to do so. So the whole point is to determine if your patient lies in the volume responsive part of the Starling curve or the static part of the Starling curve. The most reliable method, at least in my experience, by the bedside to estimate volume responsiveness with echocardiography has been to measure the cardiac output, or at least the velocity time integral. The principle is a very simple physical principle. If you measure the flow, velocity of flow across a cylindrical tube, and if you measure its cross-sectional area, it is a simple estimate. So once you estimate the velocity and the cross-sectional area, if you have the velocity and the cross-sectional area of flow, you can calculate the flow with the simple equation. Cross-sectional area multiplied by velocity will give you the flow. So if you apply this to the left ventricular outflow tract or the aorta, if you have the velocity time integral, which is a direct measurement using echocardiography, and if you have the left ventricular outflow tract area, you can calculate the stroke volume just by multiplying the velocity time integral, which is VTI multiplied by pi r squared. R, of course, is the aortic diameter. So how do you do this? You need to get a 5-chamber view of the heart by echocardiography, as you see in this case. A 5-chamber view includes the left ventricular outflow tract, the aortic valve, and the aorta, as you see here. And you place the cursor at the left ventricular outflow tract. And you must also make sure that the line, the Doppler line, axis of the Doppler, is along the same line as the left ventricular outflow tract. If you cross this line, or if the line is not parallel with it, you will get erroneous values. So it has to be in the same axis. And once you do that, you push the pulse wave Doppler, and then you get the velocity, the flow waveform, as you see here. You need to mark out the waveform. And once you do that, the machine will automatically give you the velocity time integral. So you have the velocity time integral directly, which is the velocity of flow across the left ventricular outflow tract. And then if you need to calculate the stroke volume, you need a radius. And the radius is measured in the parasternal long axis view by measuring the aortic diameter. With the aortic valve in the fully open position, you measure the distance from the bottom of one cusp to the bottom of the other cusp, leaflet to leaflet. So that's the diameter. Diameter by 2 is the radius. So simple calculation, VTI multiplied by pi r square will give you the stroke volume. So if you are a little bit pushed for time and you don't have the time to calculate the stroke volume with all this, some machines, of course, will give you a direct readout of the stroke volume itself in some of the newer machines. But even if you do not calculate the stroke volume itself, if you just go by the waveform, the flow waveform across the LVOT, it'll give you plenty of information. As you can see in this case, there is a lot of variation in the waveform from breath to breath, and that suggests fluid responsiveness if the patient is not breathing spontaneously. And even if the patient is breathing spontaneously, you can do the passive leg raise test. And with the passive leg raise test, what do? You measure a left ventricular, you measure the 5-chamber view, measure the velocity time integral from the 5-chamber view pre-passive leg raise and post-passive leg raise. And if the VTI increases by more than 12 to 15%, you don't need to calculate the stroke volume. Even if you don't calculate the stroke volume itself, if you find that the velocity time integral, which is a direct readout, increases by more than 12 to 15%, it is strongly suggestive of fluid responsiveness. Of course, fluid responsiveness is not the only criterion to go by to decide whether your patient needs fluid or not. Normal people are also fluid responsive, so that doesn't mean that they need intravenous fluid. So the decision to give intravenous fluid would depend on several other things, including urine output, acid-base status, lactate level, capillary refill time, and so on. So you take all these into account and get a holistic picture of the patient before the decision on whether to give fluid or not. The inferior vena cava, of course, is familiar to all of you. And in a patient who is not breathing spontaneously, it might help by calculating the IVC size variation, which is maximal minus minimal diameter divided by mean, multiplied by 100. And if this is more than 12 to 15%, that suggests fluid responsiveness. It's not very reliable in spontaneously breathing patients. Of course, you have the collapsibility index and so on. But even then, as many studies have shown us, the IVC diameter by itself is not at all a very strong indicator of fluid responsiveness. So just to sum up, when you look at the lung in a hypoxic patient, what are the specific things that you look for? You look particularly for pulmonary edema, consolidation, pneumothorax, collapse. If none of these things exist, you look for a pulmonary embolism. Pulmonary edema will look like discrete B lines or coalescent B lines. Discrete means milder forms of fluid, and coalescent means there is much more fluid accumulation. Here you see subpleural consolidation, and here you can see the typical dynamic air bronchograms that you get with consolidation. So this patient, if he is hypoxic, obviously has a consolidation. If you see that the pleural line does not slide, it obviously means that there is no ventilation happening there. And along with it, if you see a lung point, you don't need to investigate any further. Your patient may well need a chest tube. If you see static air bronchograms like you see here, it means that the lung is collapsed in that particular area. You may need to increase your PEEP, change position, or maybe do a bronchoscopy to make sure that the lung opens up. And if none of those things exist, the lung looks absolutely normal on ultrasonography. You turn your attention to the heart. Does my patient have right-sided dilatation and acute pulmonary embolism? And of course, you will look at the veins as well to see if there is any DVT. And do not forget, if your patient appears to have refractory hypoxemia, and if progressive increase of PEEP only seems to worsen it, please do this test. That's the bubble test, where you inject about 20 mils of normal saline into preferably a central line. And if you see a pacification of the left side of the heart, instantaneously, it obviously means there is a shunt across the atrium. In this particular case, you can see a pacification of the atria and the ventricles. So it means that there may be a foramen ovale which is patent, and you may be opening it wider and wider with increasing levels of ventilation. So that's something you need to be aware of as well. With that, I will finish off. If there are any questions, please feel free to ask.
Thank you, Jose. Amazing lecture as always. I was just completely riveted to the presentation. I will wait for comments from the rest of the faculty and any questions from the students.
It's amazing. I think we need to actually have one whole session for Jose, just on this. I think we should have given him a whole platform for this. I think it's just too good, too good. I think there aren't questions, but I mean, there are lots of comments. Wonderful presentation, excellent presentation, very informative talk. Okay, so one question obviously is, this is, I think, asked, is there an ideal location to measure IVC diameter? Or IVC, I think.
Sorry, can you repeat the question, please?
Is there an ideal location to measure IVC?
Yeah. The preferred location is from the subcostal area, just below the sternum.
Yeah.
You get the long axis view of the IVC. That's the preferred location. But if you can't get it at that location, of course, you can move to the right hypochondrial area and visualize it from there. But the preferred location is from the subcostal area.
Yeah. I think that was the only question. The rest of them are just very, very interesting and amazing lecture by Dr. Josh.
Just a comment. I think the important thing is we often see our trainees confusing the aorta with the IVC, and you have to track the IVC going into the right atrium to confirm it's the IVC, and you will also see the hepatic vein draining into the IVC.
Yes.
I think these are two very important things that we must, because otherwise you'll easily confuse the IVC and the aorta. And the IVC, as always, will be on the right side of the midline, hopefully. And we generally measure the IVC diameter at a point little less, around 1 centimeter below where the hepatic vein joins.
That's correct. Yeah, that's the ideal location of IVC measurement.
Go ahead, Anil.
Dr. Anil here. Do you use VEXUS score, or are you only into VTI measurement of cardiac output for volume responsiveness?
Some of our colleagues do use the VEXUS method. I don't use it routinely, but of course I do use it once in a while to see if my patient is volume overloaded, particularly to decide if you need to remove fluid actively by diuresis or with fluid removal with renal replacement therapy. But it's, of course, one of the methods that you can use.
About the fluid responsiveness, once you know there is a room for fluid, how do you go about it? Like you give boluses, or how do you go about it?
What we conventionally do, if you feel that your patient is fluid responsive, we give a ringer lactate bolus of 250 mils over a period of, say, 15 minutes or so usually, and then use the same parameter, usually the velocity time integral that I mentioned, measure it again and see if there is any response. And if you feel that more is required, you keep on topping up. Of course, there is no hard and fast rule, but you try to measure whatever indicator you used previously and then go by that again. And there are several clinical pointers as well, which some of us at least use in daily practice, like the capillary refill time, which I feel is a very good clinical sign that's been, in fact, been well established by the Andromeda shock trial as well. Urine output, acid base. So you take all these things into account and decide on what is optimal fluid resuscitation, not just stick to a single parameter. It's a combination of all.
Thank you, sir.
Any other comments from the faculty? Anybody? Any other questions?
I think, Dr. Dilnada, have you actually ever come across hydrated cyst during lung ultrasound? I think it's quite common in India, so that's why I think she's asked that question.
It's not very common.
We have seen cysts in the liver and lung, of course. I don't think
liver
I have
also, yeah,
seen.
that's right.
Liver, we've seen quite a lot.
Okay, so liver.
Somnath might remember the patient who came with the ruptured hydrated cyst of the lung. Remember?
Correct. Yes.
And we had to do emergency thoracotomy and fix the problem. Yes.
I know. Baswaraj was there.
Yes.
If we are ahead of schedule, thanks a lot, Jose. It was a pleasure listening to you again after many, many years. We thoroughly enjoyed it. I'm sure your video will be seen on YouTube several times by many of the students. Thank you. Thank you very much.
Thanks a lot, everyone. It's my real pleasure to be here. Thanks once again. Thank you.
We'll move to the left.
Stop sharing your screen, please. Your screen is still on, I think.
Jose, can you just stop sharing your screen?
Somebody has actually commented our capillary refill time. So CRT is commonly mentioned in our ITUs and for in ED patients. It says it's like landmark guided block, equally effective as the ultrasound mark. How come I'm seeing yours this thing, but on my screen I still see Joseph's.
Yeah, he's just logged off. Yeah.
Okay, yeah, but on the YouTube I could actually still see Anil's slide actually. So
all right, okay. Yeah. It just must have frozen. We'll move on to the next lecture, which is the last lecture for the day. We have Dr. Anshuman Mishra, who will be talking to us about measuring gastric residual volume and bladder ultrasound and its relevance to the anesthesiologist. So Dr. Anshuman Mishra is consultant anesthetist and acute pain service in Kailash Deepak Hospital. His main interests include transplant anesthesia, POCUS, onco and orthopedic anesthesia, and regional anesthesia. It's a pleasure. We look forward to listening to you, Dr. Anshuman Mishra.
Last but not the least.
The icing on the cake.
The icing on the cake, yeah. There you go,
Just give me a second, sir. Let me.
No problem.
Start.
What the hell, man? You got the Russian flag on.
That's actually, sir, the other laptop is down. So I spoke with Anil today itself. So it's my younger son's laptop. So one loves Russia, the other loves Ukraine. So you can understand what's happening in my house.
Okay, let's go.
So basically, I think it's fine. So at the fag end of the day, I'll be starting and discussing on the topic, which will be basically abdominal ultrasound that will take into consideration both gastric ultrasound and abdominal, this bladder ultrasound. So as we move further, let me tell you what is important is that gastric ultrasound, it's an POCUS, it's a point of care tool for aspiration risk assessment. So the importance is that it can determine whether what is the content of the thing, whether it is empty, whether it is clear fluid is there, or whether there is any solids. Suppose it is having a solids, then usually you think then that's a full stomach. So do not need to see that part. But suppose we see there is a clear fluid, then we need to find out how what is the volume of that, and we need to use that findings. It's not that everywhere you can find out the exact value of the gastric volume, and it could be inconclusive in certain conditions, like there is some anomaly, which could be a physiological, like something physiological means per se present in the patient, like an gastric band or a large hiatus hernia, or if the patient has undergone some sort of a gastric dissection or bypass or a previous fundoplication. So in these patients, it will be difficult to find out a gastric residual volume. And the question is why it will be difficult. We will be discussing it further. Now, what is the aim? What is the aim of performing a POCUS for gastric ultrasound? First point is that it should be a standardized gastric ultrasound exam. That means it should be reproducible. Whoever does the gastric ultrasound, every operator should get near about the same thing. Number two, it's like identifying the sonographic features of the empty stomach versus the clear fluid one. So first we need to see how does the stomach looks inside in an ultrasound image. And then only we can see the content, whether it has any content, and if it has any content, what type of content is that? And if it is a clear fluid, then only go to the measuring the gastric fluid volume. And then utilizing all this knowledge that we have gathered with this in interpreting the findings and then putting it in the implication of aspiration risk assessment. So what are the indications? So indications could be secondary to lack of adherence to any fasting instruction. It could be there is a communication error. It could be there is we said to the senior doctor says to the RMO and it has not been passed on, or it is an emergency procedure that needs to be done. A lot of times in our subcontinent, we have this option of an unreliable or unclear fasting history. The patient gives a time of having food. The first relative who was there with him gives another time. And the person who is not there, he gives absolutely different time. And then it becomes difficult to find out what, when, and how much. So that is very important. Secondary to that, it could be secondary to an altered sensorium. It could be there is a language barrier if you have any international patient, or there is a cognitive dysfunction and you do not know exactly. There are certain conditions where we as an anesthetist should be aware that this patient, even though he is a fasting patient, we must be considering him as a full stomach patient, like any pregnancy or patient in labor, in patient who has a diabetes mellitus, severe liver or kidney dysfunctions like end-stage liver or kidney disease, and neuromuscular disorder patients. Now we come to the scanning technique. How do you do a scanning technique? We take a curvilinear probe you can take for a large child or an adult, we take a curvilinear probe. And for a small child, even a linear probe can be used. It's used in the abdominal setting. The patient is supine, and the operator, the person who is doing this, sits on the right side of the patient if you are a right-handed person, and on the left side of the patient if you're a left-handed person. And the machine is just in front of you. So the operator, the patient, and the machine are in a straight line. So that is very important. Then you start scanning from in the sagittal plane. Start from sagittal frame and from left to right subcostal margin. Once you do that, you see the gastric antrum, and then we ask the patient to turn to the right lateral decubitus. Never ever give an empty stomach based on supine position alone. If you anytime you give a patient to be supine, finding an empty stomach in supine, you make the patient right lateral decubitus, and then you see the volume. And we'll be explaining it why. The question is, stomach is a very big hollow viscous, it's the hollow organ. So how do you see the whole organ in this thing? So it is said the stomach is an window to the abdomen, and antrum, gastric antrum, is the window to the stomach. The advantage is that it is usually located superficially. It is a hollow viscous, and it is a multi-layer wall. Because it has a number of muscular layers, it's the most thickened part of the stomach. So whenever you see anything that is being seen in the antrum, that gives a corroborative finding what is available in the stomach. So how do you find out where the antrum is? It has very peculiar presentation. It has a big liver anteriorly, a pancreas posteriorly. And other important landmarks that you should be knowing are the aorta, vena cava, and superior mesenteric artery and vein. Why they're important? Because the antrum in a compressed stage may look like any other vessels also. So you need to know exactly how the antrum looks like. So when you put in a sagittal plane, that's how we are seeing this. So we're putting this thing in sagittal plane, and this is the cephalate and the caudal part. So this is how you look. So this is what you get as the liver part, and this is the antrum, gastric antrum, and this is the pancreas. So the gastric antrum sits always between the liver and the pancreas. So all this black structure that you are seeing, this is antrum, and this is colon, and this is small intestine. In this image, you can even say aorta, spine, even to the posterior wall. You may not get the same thing in any patients, but issue is that the whole idea is that if you get a picture, this is how it should look on when you put a probe. Now coming to the gastrical proper, why it is important, let's discuss few things about this. This is a blown up image of the gastric antrum wall, one side wall, when we're using a linear probe. So if we start from outside to in, so we have the outside of the serosa, which is a thin and hyperechoic layer, and then we have muscularis propria, which is a thick and hypoechoic. Then submucosa, which is hyperechoic, muscularis mucosa is hypo, and mucosal interface is thin and hyperechoic. So if you look at this table, you see this is an reverse, this is a corrugation sort of thing, like a level of thin, thick, thin, thick, thin. Again, hyper, hypo, hyper, hypo, and hyperechoic. So this is a sign we say as a squirrel sign, the same way the squirrel has alternating layers of thin and thick, or hyper and hypoechoic. Is it important for us to know? It is not important. Just to explain that why antrum is important to us and why we see the content in gastric antrum, because it has so many layers. If the volume is present in the antrum, it is definitely present in the stomach, because stomach gets distended. Antrum doesn't get distended that much unless the volume is definitely big. So empty stomach has something like this. The antrum, it has no appreciable content in both supine and right lateral decubitus. So it's called a grade 0 antrum. It appears flat. If you can see, this is an ultrasound image, and this is the image which is corroborating with that one. So you see there is a liver, and this is the rectus sheath, the skin, this is the cephalate part, and this is the antrum that you are seeing. This is the pancreas, this is the antrum. So antrum looks like a thick, thin, collapsed structure. So it's called to be a bullseye. Someone tells it a target, someone tells it a ring. It's not important if what you tell it. What's important is to find it, yes, that is there. Suppose the person takes some amount of clear fluid. What will happen is that this thick antrum, see here the antrum wall is this thick. Once the person takes some amount of fluid, the antrum swells up and the wall becomes thinned out. So from this, it will leak. It could be anechoic or hypoechoic based on the amount of fluid it has and what type of fluid it has. The size of antrum is proportional to the gastric volume, and always it will appear larger in the right lateral decubitus compared to the supine position. Suppose a person has some solids, not liquids and solids. So what will happen is that this antrum, the solid part stays here and everything below becomes dark. The rays cannot go below and tell you anything about that. So we say this as a frosted glass pattern. This is usually shortly after a solid meal, initially just after a solid meal. So suppose you're getting this image and the relative say, or the patient says, okay, I haven't taken anything for the last hour or so. So you put and probe and you can see very well whether it is an early stage solid or it is a late stage solid also. So in a solid late stage, after usually a couple of hours, what happens is that the antrum you can see, but you can see very clearly things inside that. It won't be very clear as an clear fluid looks. If it is a dairy product, it could be an homogeneous hyperechoic content, or it can have, if the milk curdles, it can have a particulate thing. So it can keep on changing what pattern of images you're getting. But what is important is that you're not getting any, you're getting some collection inside this. Suppose someone has a very fancy thing and he feels probably I'm going for an operation. Let me take a Red Bull and then go for an operation. I will be better off. So you can find that out because here the antrum will give you a starry sky appearance because this air bubbles will give you a starry sky appearance in any that can be on any effervescent drinks or stuff like that. It can, you can find out the gastric volume in these fluids also, but it will be slightly difficult to exactly say how much it is because it contains both gas and liquid. Now we know, suppose we have some gastric content, we know exactly how the gastric content will look. Suppose you have a solid, we know this is a solid in early or late stage. Suppose you have an effervescent liquid, we know what is the status. Then comes to the thing, how do we calculate the volume of that thing? So for that, gastric volume calculation is there for the clear fluids only. There is a chart which will correlate the right, this side has the, in the right lateral decubitus position, you need to see the cross-sectional area. And based on the age, it will tell you exactly how much this will be. So there are 2-3 ways to do it. One is that you keep this chart with you, take a cross-sectional area and you do the calculation. The calculation can be done based on this. The volumes in males will be around this figure, 27 plus 14.6 into RLD, and the difference between cross-sectional area minus a figure of 1.28 into the age. This is applicable to non-pregnant adults for volume up to 500 mils. The easier option is that and then question is how do you do a cross-sectional, how do you calculate a cross-sectional area? So this is a way, so I'm just thinking the same issue. There is some issue. So let me say. Okay, okay, I will see this. I will show this image later on because there is some issue with this. This is not playing. Now coming to the next part, I will tell you exactly how you do the calculation part. I have a video for that. This is what a gastric volume calculator, this app is available online. So you can put the right little cross-sectional area and age in years, and it will give you an estimated volume also. Okay, how much the estimated volume would be. Once you get a volume of the whatever you know, what is the cross-sectional area, then you start doing the grading system. So suppose the grade 0, it is empty in both supine and right lateral decubitus. The volume implications are minimum and the aspiration risk is very low. Suppose it is 1, that means it's empty in supine, but there's clear fluid is visible in right lateral decubitus. So if it is less than 1.5 mils per kg, it is compatible with the baseline gastric secretion. Supposing a person is of 70 kg and you do get a volume where the cross-sectional area tells you that volume to be around 100 mils. So 70 kg persons with a less than 1.5 will be around 100 ml. So any volume less than 100 ml for in 70 kg persons is a low risk. Any fluid more than 1.5 ml, there is a higher risk of aspiration or any solids. So most fasted individuals, more than 95% present at a grade 0 or 1. 0 or 1 are comfortable with us. If it is grade 2, then there is difficulty. There is definitely some difficulty, and we need to see it must be a full stomach patient. Once you have that the person has some food or liquid and you have calculated volumes, now how do you interpret and utilize that for your own benefit? So first you do a qualitative examination. We see there is an solids. If it is a solid, it's a red box. It's a solid, it's a high risk, no question asked. Suppose it is a clear, suppose it is an empty, it's a grade 0, then it is a low risk. Then again also it is a clear thing. Supposing you have a clear fluid, then you find out the volume. If it is grade 1, the volume is less than 1.5 ml per kg, then it is suggesting a low risk. If it is more than 1.5 ml per kg, it is a high risk. So these two things are low risk and these two things are high risk. So volume of up to 1.5 ml per kg, that one should remember, is roughly around 100 ml per an average adult, is normal in fasted patients. The same thing can be used in a pediatric age group. They have another different chart. And this 3-point grading system can also be used, but they have a different formula to reach the thing. And the normal upper limit is 1 to 1.2 mils per kg. That is what the normal decision decided amount. Suppose you have a pregnant female. So there is some difficulty when you get a pregnant female. What is problem is that you have a, why do you put the epigastric probe? Because you're putting, as you saw that I'm putting out on the epigastrium. So that part is already blown up. So it is very difficult to put a gastric probe placement, and it may not come in contact because of the curvilinear approach. You have a gravid uterus, you may have a moving fetus, so and a displaced stomach. So if you are, and there is the fast and shallow breathing also. So what can one do is that you can make the patient go a semi-recumbent on directly go to right lateral decubitus. You can manually displace the gravid uterus so that the antrum comes into the picture, and ask the patient to have a slow deep breath or breath holding at the end of expiration. This sensitivity of test is highest for solid versus fluids or empty states. So these are the few images where you have this placenta and this is the antrum that you are getting. So this is these are the few images. Supposing there's a morbidly obese patient. So how do you see how it will look? So the empty antrum can be identified in more than 90% of patients at a depth of 70 centimeters. So compared to non-obese subjects, these present with a larger antral cross-sectional area and absolute fasting gastric volume, which is, you should consider on the absolute body weight. And a mathematical model to measure volume in subjects BMI more than 50 is not yet available. I mean, it gives a given fair idea okay, how much, yes, he is fasting or not, but the volumes calculation will be it will be not that accurate. So now, whether do we really need anything? How to the diagnostic accuracy of point of care gastric ultrasound in day-to-day practice? So this is a good article that they did. This is there's a study they did in 2018, and this was a double-blind thing. And the results they do with 80 study sessions, and the results suggested that bedside gastric ultrasound is highly sensitive and specific to detect or rule out a full stomach in clinical scenarios when the gastric content is uncertain. Now we come to, I will be showing you the picture of how to calculate the cross-sectional area once I finish this thing. Then we come to ultrasound of bladder. So when you go to Google the ultrasound of bladder, you find all these things like a wall thickening, trabeculation masses, diverticuli, pre and post micturition volumes, vesiculated junctions, calculi, foreign bodies. But what is important, it's and also an acoustic window to assess the prostate and gynecological structures for a radiologist. But this doesn't fascinate me as an anesthesiologist. It doesn't help me at all. I mean, why do I need to have a look at all these things? I do not need to know these things. So for me, what is more important is that I see the importance of anesthetist is to differentiate between intra and extraperitoneal bladder rupture, location of fall is inside the bladder, and help in ultrasound guided suprapubic puncture. The presenter before me who presented in EFAST, there you saw a very good idea about how to do and find out if there is a bladder rupture. So location of follies and differentiation between extraperitoneal and intraperitoneal bladder rupture and helping in EVC-grade suprapubic puncture are some things which are of importance to us as anesthetists. So here again, we expose put the patient in supine with suprapubic area exposed. We examine sagittally in the midline angle laterally and sweep the probe both left and right to check the lateral margins. So this is the bladder. This is how the bladder looks. The whole this thing looks like. Then what you do? Then you rotate it 90 degrees and you put it on the transverse plane and sweep through from superior dome to the bladder base. The whole idea is that you start from here and you come down over here. So once you did from left to right, from midline, and then you go up and then come down. So, but what is important is that most of the people put it in a perpendicular to the abdominal wall. What is important is that the ultrasound beam is projected as perpendicular to the bladder wall as possible, and that will be looking into the pelvis. That is, we're looking deep into the pelvis rather than putting perpendicular to the skin. That is important. Let me see if this video plays. So this video, if I showed you, I'm showing you this video. This is a bladder. You need to look for the ureter, the urine outflow. So this is the ureter. These are the two ureters. If you can see, so the urine is coming into the bladder. So this will tell us about the patency of the ureter. This is just a video that I have put to show how it will be difficult. Now there are some take-home messages. Let me tell you that, and after that I'll show you that scan of that cross-sectional area. Always do a scan in right lateral decubitus before commenting whether the person is empty stomach or what is the volume of the gastric content. Calculate the cross-sectional area. It is 1.5 ml per kg. If it is less than that, you are safe. If it is more than that, you are unsafe. Easier option is that what I do is that I just square the cross-sectional area. Suppose the cross-sectional area comes around 10 centimeters square. You'll just square it. It will give you the volume of the total gastric volume. My advice would be learn in normal persons before using in abnormal patients. That is everywhere. It is very important. Learn to differentiate between aorta and IVC and the gastric antrum. Just for that sake of putting it, aorta will be having a single pulsation. All the IVCs will be having a dual pulsation or triple pulsation. So IVC has a multiple pulsations, aorta has a single pulsation. And if you do some scans, so it may be like that you may feel that this is aorta or IVC or antrum. When you are doing a bladder ultrasound, the direction of rays should always be into the pelvis. If you're directly going perpendicular to the skin, you may not visualize the pelvis, and always scan from the top to bottom and from right to left to see the bladder is not breached, and wait for the urine trickling into the bladder to see how good whether the ureters are functioning or not. And let me just show you this the video that somehow is not playing in that. So this is a video. So what we have done is that we have put the probe and we have seen this is the liver, this is the rectus. See, this we did in a normal patient, so we may not appreciate the volume. So this is the gastric antrum that we have got. So what we do is that we put this is the video that I'm showing. So what I'll be doing is that I have put this. When I get this image, a good image where the antrum is clearly visible, I freeze the image. And this whole video is all about that. So what I'm doing, I have frozen the image. Then I'll go over here and I'll put that annotate and then find out the area. So this, so we put this A square and then we take this cursor around that antrum. So when you take the cursor around that antrum, it will tell you exactly this is the 5.08 centimeters square is the gastric volume. So 5.08 square is gastric volume. If we just square it, it's roughly around 25 centimeters square. This is in an adult person. So this person had come fasting on that day. So we just do it to see, and a 50-60 kg person. So if the volume is less than 75 mils, because if you square it up, it is roughly around 25 mils. So this person is definitely an empty stomach patient. So we can go ahead with a good surgery, and there won't be any issues. So that is what my whole thing is. And thank you, and I'll be ready for taking the questions, if any.
Thank you, Anshuman. Again, something that I have not ever looked at, GRV. It's not something that's interested me, but we'll look into it. Thank you very much for stimulating us. Any questions for Anshuman?
Hello, sir.
Yeah,
there
please.
is one question from Dr. Sanath. He asks, does CSA square, cross-sectional area square, give true value of gastric volume?
See, Dr. Sanath, basically what we are doing is that we are corroborating some findings. I mean, it's easier to do it at bedside rather than pick up a chart and cross-check. And it's not that chart is telling you the exact volume also. It is giving you a fair idea. It's an eyeballing you the volume, how much the gastric volume could be. It's not that if it is saying 100, it cannot be 110, 120 or 90. It can be any way. It's just a mathematical calculation to reach a number figure. It will give a fair idea. That's it.
Okay, sir.
I think that was the only question.
Yes, sir.
Sir, at the last of the Sunday evening, people are really dead tired and rusting, having an empty spectrum, everyone having.
Don't look at it that way. Don't look at it that way. Your presentation was very clear.
No, sir, it's not about that. I'm saying this, sir, because this has had a empty, and everyone has an empty antrum now. So
it's only, yeah, it's not even dinner time, man. Chai, the people must have had chai samosa already. Yeah.
It's thank you very much, everybody. If there are no more questions, I think it's been a great day. I'll just move on to my closing remarks. It's been a great day today. We've closed exactly on time, actually, well, few minutes ahead of schedule, 5 minutes ahead of schedule. And thank you, everybody. Thank you, Shiv. Thank you, Guru. I'd like to also thank Mr. Prashant, who is Guru's, the other director running Medusis. And thank you, Anil, for coordinating and keeping everything on time. Shiv, again, delighted to have taken this opportunity and delighted to work with you. I think with that, we've had a long day. I feel like a light bulb where somebody switched me on. It's like I'm feeling enlightened.
No, it's been great sessions, and I think for people who don't know, me and Som go a long way. From our MBBS, we've done MBBS together in JIPMER, Pondicherry. And for those who don't know, Devnath is Som's younger brother. So we have a lot of connection. Arun was our junior as well. So we've been quite a few people who today were actually on the scene here from JIPMER days. So absolutely fantastic. I think everything went as per
we're just 30 years older, Shiv. That's the only difference.
Older, it doesn't matter. We're in just a different time. That's it. Yeah. So yeah, I think we can conclude this sessions, and we will in a few weeks' time be in Bangalore for face-to-face.
Yeah, let's hope we'll get enough people for the face-to-face, and let's take it from there.
Yeah, whatever numbers we get, I'm sure there will be people who will be interested to know more about ultrasound, regional anesthesia, and about POCUS.
Yeah. Thank you, Anil, again. Thank you, Shiv.
Thank you, sir.
So we can end this live streaming.